एक डेढ़ महीने से हम सब लोग लगे हुए हैं और आज वो दिन आ गया है कि हम जो रोबोटिक्स के ऊपर पूरे पैन इंडिया में काम हो रहा है उसको दिखाएं। और फरीदाबाद की इस पावन धरती पर मैं आप सभी लोगों को नमन करता हूं, स्वागत करता हूं। आदरणीय अतिथिगण, देश के विभिन्न भागों से पधारे हुए सम्मानित चिकित्सक महोदय, सर्जन लोग, मेरे साथी, मेरे सहयोगी, आज का यह क्षण बहुत ही महत्वपूर्ण है और अत्यंत उत्साहपूर्ण है, क्योंकि जैसे जैसे समाज ओपन सर्जरी से लैब की तरफ और लैब से अब रोबोटिक की तरफ जा रहा है, तो कहीं ना कहीं रोबोटिक सर्जरी आने वाले समय में मुझे ऐसा लगता है कहीं ना कहीं बहुत ऊंचाइयों पर जाएगी। और स्पेशली टेली कंसल्टेशन की अगर हम बात करते हैं कि देश के विदेश के एक हिस्से में बैठे हुए एक सर्जन को अगर सर्जरी आती है और वो देश या विदेश के दूसरे हिस्से में ऑपरेट करता है, तो कहीं ना कहीं मरीज को फ़ायदा पहुंचता है। जब हम चिकित्सक अपने इतिहास को देखते हैं तो पाते हैं कि कुछ युग में ऐसे क्षण आते हैं जो भविष्य की दिशा तय करते हैं। जब लेप्रोस्कोपी लॉन्च हुआ तो बहुत सारे क्रिटिसिज्म थे, प्रोन्स कॉन्स थे, और धीरे धीरे लेप्रोस्कोपी फेमस हो गया। रोबोटिक सर्जरी केवल मशीन का उपयोग नहीं है, ये एक मानव बुद्धि का जो विकास हो रहा है अत्याधुनिक तकनीक के साथ, उसका एक जीता जागता उदाहरण है। और आज इस रोबो फेस्ट में आप आए हैं और इसका आयोजन QRG मरिंगो हेशिया हॉस्पिटल SS मंत्रा द्वारा किया जा रहा है और हरियाणा मेडिकल काउंसिल ने इस कॉन्फ्रेंस को स्टेट काउंसिल का दर्जा दिया है। उसके लिए हम हरियाणा मेडिकल काउंसिल, SS मंत्रा और QRG मरिंगो एशिया का धन्यवाद करते हैं। यह सम्मेलन का उद्देश्य केवल और केवल ज्ञान साझा करना नहीं है, पर इस कॉन्फ्रेंस का उद्देश्य ये भी है कि हम इस फरीदाबाद की धरती पर ये दिखा सकें कि यहाँ पर बहुत सारे ऐसे चिकित्सक हैं, बहुत सारे ऐसे हॉस्पिटल्स हैं जो बहुत अत्याधुनिक तकनीक के जरिए काम कर रहे हैं और पूरे विश्व में फरीदाबाद को एक चित्र पर हम ला सकें कि भाई यहाँ पर भी एक बहुत बड़ा काम हो रहा है। क्योंकि जनरली पहले क्या होता था कि लोग दिल्ली कहीं भी कॉन्फ्रेंस हो, जब हम भी पढ़ रहे थे तो ऐसा होता था कि चलो भाई कॉन्फ्रेंस है, दिल्ली चलो, दिल्ली चलो। मेरा ये मानना है कि मेरी पर्सनल ये मानना है कि इस धरती पर, फरीदाबाद की धरती पर अगर पॉपुलेशन डेंसिटी वाइज आप जाएंगे तो सबसे ज़्यादा हॉस्पिटल हैं, सबसे ज़्यादा स्टूडेंट्स भी हैं, DNBs हैं, PGs हैं, और बहुत अच्छे सर्जन्स भी हैं, बहुत नामचीन सर्जन्स हैं, बहुत अच्छे हॉस्पिटल्स हैं। परंतु जब हम भारत में जाते हैं तो फरीदाबाद का जो मैप के ऊपर जो नक्शा है चिकित्सा के मामले में, शायद ही इस तरीके से जाना जाता हो कि भाई यहाँ इस तरीके की सर्जरीज होती हैं। तो इस तरीके की सर्जरीज जो यहाँ हो रही हैं आज, उनको भी दर्शाया जाएगा। और मुझे लगता है कि जो ये चिकित्सा का क्षेत्र है तकनीक से नहीं चलता, लेकिन समर्पण, करुणा और सेवा भावना से भी चलता है। तो ये नहीं है कि कोई पेशेंट हमारे पास आ रहा है तो हम उसको रोबोटिक ही ऑफर कर रहे हैं। देयर आर इंडिकेशंस ऑफ ओपन लेप्रोस्कोपिक ऑल्सो, पर रोबोटिक्स की अपनी एक एडवांटेज है। जहाँ लेप्रोस्कोपी बहुत कठिन होती है वहाँ रोबोटिक्स उसको आसान बना देती है। हालांकि एक लर्निंग कर्व है और वो डॉक्टरों के हाथ में केवल उपकरण नहीं होते बल्कि लोगों की जान होती है। किस तरीके से आप बचाते हो, किस तरीके से आप प्रदर्शन करते हो अपनी स्किल का, वो भी मायने रखता है और रोबोटिक्स आपकी स्किल को भी एनहांस करता है। तो आज के युवा सर्जन जो पुरानी है ओपन, बहुत सारे ओपन सर्जन हैं, तो ओपन टेक्निक का अपना महत्व है, लेप्रोस्कोपी का अपना है, रोबोटिक्स का अपना है। तो मुझे लगता है कि रोबोटिक्स की तो कॉन्फ्रेंस है क्योंकि थीम होती है कहीं ना किसी चीज़ की, पर ओपन का अपना महत्व है। तो ये ना समझें कि ओपन सर्जरीज खत्म हो जाएंगी रोबोटिक आने से, उसका अपना महत्व रहेगा, क्योंकि ओल्ड इज गोल्ड, ओल्ड इज ऑलवेज गोल्ड। तो आप सभी लोगों का रोबो फेस्ट में आने पे मैं हार्दिक स्वागत करता हूं, अभिनंदन करता हूं। और जब कॉन्फ्रेंस की शुरुआत हो रही थी तो रितेश मोगा सर हैं और आज सर का जन्मदिन भी है। तो हालांकि मुझे कहा गया था मंच से कि इस बात को बताया ना जाए, पर क्योंकि ऐसा होता है कि हमें नहीं बताना होता, लेकिन कुछ नटोरियस लोग होते हैं मेरे जैसे, तो मैंने कहा सर मैं नहीं बताऊंगा, लेकिन मैं बता दिया। और आज वुमेंस डे भी है, तो महिला सशक्तिकरण का दिवस भी है। तो इतना अच्छा अवसर है और ये बाई चांस हुआ है कि 8 मार्च हमें हरियाणा मेडिकल काउंसिल से मिली कि हम इस दिन आ पाएंगे। रजिस्ट्रार साहब हमारे मनदीप सचदेवा सर हमारे बीच हैं, अभी आ जाएंगे थोड़ी देर में। तो रितेश सर बहुत बहुत धन्यवाद। रितेश सर ने मैं एक सरकारी अस्पताल से आता हूँ, ईएसआईसी मेडिकल कॉलेज फरीदाबाद। हमारे डीएमएस और मेरे एचओडी सर हैं, सुमित सर हमारे बीच हैं, और विवेक अग्रवाल सर हैं जो जिनके सानिध्य में मैं काम कर रहा हूँ। इनका भी मैं धन्यवाद देना चाहता हूँ कि इन्होंने मुझे इस कॉन्फ्रेंस को करने के लिए खुला हाथ दिया, क्योंकि सरकारी तंत्र का और प्राइवेट तंत्र का जो तालमेल है वो बिठाना कहीं ना कहीं आज की डेट में थोड़ा सा टफ होता है। लेकिन रितेश मोगा सर से जब भी बात हुई, जितने भी कॉरपोरेट्स हैं, सबका साथ सबका विकास वाली बात रितेश सर के साथ जब भी होती थी तो उन्होंने भी, और क्यूआरजी मरिंगो एशिया से हमारे नवनीत छाबड़ा सर हैं, एफडी हैं, और पूरी टीम एसएस मंत्रा की मैं सबका धन्यवाद देता हूं, स्वागत करता हूं। और अगर मैं प्रबल सर का नाम ना लूं, एकॉर्ड से हैं, मैं सर के साथ काम किया हूं, मनु सर मेरे गाइड रहे हैं, तो आप सभी लोग आए, सभी लोगों का प्रेम मिला, कल भी मिला और आज भी मिला और पूरे दिन मिलता रहेगा। मैं आप सभी लोगों का ऋणी हूं, तहे दिल से धन्यवाद करता हूं रितेश मोगा सर का, जिन्होंने कहा हेमंत बस करता जा। जब भी बात की, हेमंत क्या चाहता है, कैसे चाहता है, कैसे होना है, तू बता और कर। मुझे मंच दिया, उसके लिए रितेश सर बहुत बहुत धन्यवाद, क्यूआरजी का धन्यवाद, ईएसआई का धन्यवाद और एसएस मंत्रा का धन्यवाद। थैंक यू वेरी मच, थैंक यू वेरी मच। जय हिंद, जय भारत। थैंक यू।
Thank you so much, Dr. Hemant, for that inspiring start to our evening. Good morning, everyone. On behalf of the organizing team, it is my privilege to welcome such an esteemed gathering of clinicians, academicians, and thought leaders. My name is Dr. Jahanvi, and I have the honor of serving as your host for today's conference. Joining me today proceedings is Dr. Obeda, and together we will guide you through what promises to be an engaging and intellectually enriching program. We're delighted to have such distinguished faculty and participants with us today, and we look forward for a day of meaningful academic exchange and collaboration.
Thank you, Dr. Janvi, and welcome everyone. It's my great honor to invite Dr. Colonel Navneet Singh Chhabra, Medical Director, Meringo Asia Hospital, Faridabad.
Please give it up for Dr. Navneet Singh Chhabra.
Good morning, everyone. It is such a pleasure to be amongst such distinguished faculty, delegates, and guests today, beautiful morning of 8th March, which happens to be a International Women's Day. We celebrate this day, and also birthday of Dr. Ritesh, and of course, I'm sure we'll have a very exciting day ahead, followed by a cricket final match, which will conclude the day. So today I am here to just take you through the landscape of Meringo Asia hospitals. 10 minutes is too small a time to take you through excellent clinicians we have about the hospitals we have, but I'll try to wrap it up and tell you what Meringo Asia stands for and what we are doing in this today's imparting the medical knowledge and treatment. So we are a hospital group which started in a small apartment in 2020 with a great vision, and in next 5 years we are now 8 hospital big. We are backed by our investors, which are Samara Capitals, Godrej, Havels, and when these stalwarts met Dr. Rajiv Singhal, our CEO and Group MD, Meringo Asia Hospitals was born. In 2020, as I said, from a small apartment in Gurugram, and now we are present in India and abroad. So, Marengo Asia Hospital believes in creating center of excellence, imparting best clinical care, and setting up the benchmark for exemplary healthcare. So, our values are, as you see, we are usage of technology as a to the enhance the clinical outcome. So, we as an institution, as an organization, are very particularly focusing on usage of technology. And as we sit here today, as we talk here today, we have the best, most advanced robotic system in India. We are the only one, and we have one of the best teams to do the robotics. It is a pleasure to tell you that Dr. Ritesh Monga, in last couple of months, he has achieved a milestone, and we have done 50 plus robotic surgeries at Marengo Asia, Faridabad, and it's really an honor and a privilege to have such a excellent team of doctors with us, backed by the technology which we so much appreciate. So, we started with Ahmedabad, then we took over Faridabad QRG Hospital, and latest acquisitions are W. Pratiksha Hospital in Gurugram. We have just acquired a hospital chain in Gujarat, and that is in Vadodara and Surat. Along the way, we also operate and manage Bhuj Hospital. We have a presence in Varanasi, and we have a hospital in Nazran, the Kingdom of Saudi Arabia. So these are the 8 hospitals we have, which we. So we are building a robust framework, creating a center of excellence. As you know, we already have a center of excellence in urology, in neurosciences, in cardiac sciences, and in transplant surgeries. We are very honored to have one of our stalwarts, Dr. Rajesh, who's a pediatric CTVA surgeon, and similarly, Dr. Ritesh, Dr. Tarun, Dr. Anurag, they're all stalwarts who have been associated with us and being the part of the Center of Excellence at Marengo Asia Hospitals. So we invest in people, we invest in processes, we invest in infrastructure, and we invest in academics. So apart from these 8 hospitals, we have something known as clinical corridor. We work on 3T advantage. What is 3T? 3T is something which Dr. Rajiv Singhal, our group MD and CEO, envisaged, and this stands for teach, train, and treat. Teach, when we say teach, it is to do with academic excellence. When we say train, we are imparting training to various doctors and healthcare professionals across the globe. And when we say treat, we empower these healthcare systems across the globe to treat their patients effectively. So, if you see, we are present in 7 countries at 15 locations, and we are associated with Mass General Hospital, which is an affiliate of Harvard's Medical School. We are also having a tie-up with NHS. We have our presence in Kenya, Iraq, Mongolia, Fiji, and Ghana. So name the country, we are there, and we are imparting our clinical excellence in these countries. And we are exchanging academic knowledge, we are imparting training, we are imparting good, excellent healthcare. Marengo Asia Hospitals, Faridabad. We are a capacity of approximately 600 beds. We have now 10 modular OTs. This you see 7 here, but we are in the process of making two more, and we have 107 ICU beds. We are a super specialty hospital with neurosciences, urology, cardiac sciences, orthopedics, and gastroenterology and transplant as center of excellence. We are the only hospital in the region to have done 100 liver transplant in 1 year, and we are aggressively doing transplants, both kidney and liver. We are we have a strong presence in the medical valued travel, and we are getting to various countries across the globe for their medical needs. We have a robotics center. As I said, we are proud to have a team, surgical team, urology team, who are very actively involved in robotics. And today is the testimony of that excellence we have. We also serve the community as any other large hospital would do, and we are looking after our population, senior citizens. We are actively doing all that is possible, health camps, RWA engagements. So we are also engaged in communities services. We are technologically equipped, we are infrastructurally equipped, and we are aggressively following the ESG goals. We, as a responsible institution, responsible organization, we feel that it is our duty to have the ESG, we follow these ESG goals, and towards that we are into green energy, we are into saving of the fuel, we have installed PNG, we have the electric vehicles, we have done away with all the petrol and diesel vehicles in our hospitals, and we are using renewable energy, solar energies all across our chain. So, apart from all this, we are also academically, we are very active. We have DNB programs in almost all the specialties with 21 seats as of today. Cardiology has been added recently, and we are in the process of adding urology, neurology, and neurosciences, that neurosurgery, as DNB seats in the coming months. So we are total of 37 students as of date, and digitally we are far ahead. We are doing very well. We have patient mobile app, we have chatbot, we have smart scan, we have QR buddy, we have you name it, and we have. Our IT presence, our technology is quite superior, and we are doing well. So these are some of our awards. We have been adjudged the second best hospital in Faridabad by the Times survey. We have been awarded by NABH being the as a mark of excellence by Quality Council of India. We have also received the best hospital for pediatric surgery. Dr. Rajesh, who's sitting there, he truly deserves all the accolade for leading the pediatric surgery department, pediatric cardiac surgery department in Marengo Asia hospitals. We have just successfully concluded ITAC 2.0. ITAC is International Trauma and Acute Care Conference. We have collaborated with NHS, we have collaborated with Mass General Hospital, Harvard's Medical School, Indian Society of Trauma and Acute Care, and BAPIO to hold this conference, which concluded on 17th of Feb. And we have come out with a white paper how to improve the trauma care in India. We are collaborating with the Government of India. We have also collaborated with the various personalities in the film industry who will promote our initiatives, and we will come out with something, training of people for trauma care, establishing trauma care centers on the highways, along with our partners like NHS and Harvard Medical School. This is a path-breaking milestone. Dr. Ritesh, he has recently done a tele-robotic surgery sitting in Marengo Asia Hospitals, operating on a patient who was in Kolkata. And this was a great surgery which he performed, and the patient was very grateful, and he became so well, and so he was so mobile in just a matter of 4 to 5 hours after the surgeries. And this surgery was performed with the help of SSI Mantra 3.0, which is the most advanced robotic system which is present in our hospital. This was followed by a press conference, good press coverage. And also we have Dr. Anurag Agarwal. He is an orthopedic surgeon who has done 100 plus robotic surgeries, knee surgeries. And it gives me a great pleasure to say that Dr. Anurag also performed the first robotic total knee replacement in Kenya. That was the first operation which he did, any Indian did, or anybody did for that matter. And he has that advantage, and he has that honor. We are the incredible workplace to work, definitely. Again, this time for the year, second year in continuation, we have been ranked second in Faridabad. We have our Group MD and CEO is the chairperson of FICCI, and we are quite actively involved in medical value travel and the healthcare ecosystem of India. All in all, a 360 effort to deliver excellent care to every patient, every time. Thank you. Thanks for your time. Thank you.
Thank you, Dr. Chhabra, for that insightful address and for your inspiring leadership at Marengo Asia Hospitals. Your vision truly reflects the direction in which modern healthcare is evolving. Over the last 2 decades, surgery across the world has undergone a remarkable transformation. What once relied purely on human hands and vision now has evolved into a precise synergy of human expertise and robotic intelligence. Today, we gather not just to discuss technology, but to celebrate how robotics is redefining surgical precision, improving patient outcomes, and shaping the future of medicine in our country.
With that perspective, we now move into a session dedicated to Indian robotic journey by SSI Mantra.
History has always been shaped by those who dared to dream what others could not. And a dream is only as powerful as the will to make it real. Today, that dream is transforming lives across the world. SS Innovations, pioneering the future of surgery.
In the heart of Bharat, where dreams meet challenges, a new advanced technology is unfolding to help patients not only in Bharat but also worldwide. Dr. Sudhir Srivastav while living in the United States, performed over 1,400 robotic cardiac surgeries, which was the highest number globally. He made the decision to return to India.
February of 2011, packed the bags and came to India with family and left everything in United States with the idea to launch robotic programs and train people in the country.
It's delightful and quite ironic that another surgeon, Dr. Srivastava, is a cardiac surgeon that never gave up. There's very few people on the planet that have that background, and is now leading the charge for the development of a next generation robotic system that will, among other things, I think, continue the development of robotic cardiac technique along with the procedures that are better established currently.
At the heart of SS Innovations lies a sprawling 75,000 square feet of state-of-the-art facilities, each division meticulously designed to ensure optimal production. The company's commitment to innovation is unparalleled, with dedicated assembly areas for each component, ensuring efficiency and precision in every unit.
In less than 3 years, Mantra has already installed over 170 systems and enabled 9,000 plus surgeries across specialities, including the most complex of cardiac surgeries.
Traditionally, all the surgical robotic systems, most of them are closed console and also robotic arms coming from a single tower. But our Mantra surgical robotic system is an open console and we have the modular system. Apart from that, we have the AI-driven DICOM viewer, and not only limiting to that, we have like in a pre-operative and intra-operative application which guides for the surgeons and also the tableside staff.
If you take India as an example, almost more than 60-65% of our population is in rural areas, small communities. So they don't have access to the highest level of care.
So by making available these resources in the tier 2, tier 3 cities within India, what you're doing now is you're changing the migratory pattern of these patients so that now they don't have to go far outside of their home in order to avail of these services.
And so, SS Innovations set out to change the course of medical history with a groundbreaking technology, telesurgery.
What SS Innovations has done now, that we have developed the Mantra robotic system with the idea that to be able to equip it with the abilities to do telesurgery.
For the first time in history, distance was no longer a limitation in surgery. In a landmark achievement, SS Innovations successfully conducted the world's first robotic cardiac telesurgeries over 300 kilometers, a breakthrough that is now redefining global healthcare.
Today, with our tele abilities and technology and high-speed connectivity, we can literally bring the care to these patients. When we talk of the telesurgery, especially in relation to the surgical robotic, itself is a teleoperation whereby the surgeon sits away from the patient and the signals from the hand and the feet are taken through a computer system and controlling the robotic arms and instruments, and so we are able to perform all these very precise and delicate maneuvers and do the operation without making large incisions. And I think I'm very happy and proud to say that we are the only company globally that have a formal regulatory approval from CDSCO, which is the Indian regulatory body, to be able to do not only telesurgery but also teleproctoring.
With SSI Mantra, the world's leading surgeons could now perform complex procedures from hundreds, even thousands of kilometers away, with the same precision, the same expertise, and the same life-saving impact. Whether in a small-town hospital, a remote village, or a military field hospital, telesurgery ensures that no patient is left behind. Innovation is only meaningful when it empowers people. At SS Innovations, we are not just building technology, we are training the future and building a new generation of robotic surgeons, equipped with the skills to lead the medical revolution.
There are two types of people who carry knowledge, those who want to keep it inside and those who want to be like open source. I think we look at this sort of open source knowledge sharing and knowledge transfer as part of the evolution of science.
We have an absolute responsibility actually to be able to share knowledge. Because if I look at myself, everything I know somebody else has taught me. It is a moral responsibility that we must teach others. But that's how the progression continues, and you hope your student will be better than yourself.
And with the SSI Mobile Telesurgery Unit, SSI Mantra M, training is now reaching even the most remote regions, empowering local doctors with cutting-edge surgical expertise.
So the whole idea was, again, to be able to have this bus go to smaller communities, rural areas, and then because of the high-speed connectivity, I can sit in the bus and operate in any other hospital, literally sitting there. And I think this will be a wonderful thing for our army, for instance, where they are in remote locations.
The power to heal should know no limits. The world is on the brink of a new paradigm in healthcare.
SS Innovations International has set a new benchmark in surgical innovation with the launch of SSI Mantra Asana. The launch event was attended by a large number of media organizations and medtech experts. The Mantra Asana Telesurgeon Console, a world-first innovation, allows surgeons to perform remote telesurgery with unparalleled precision and ease from any location. Seamlessly integrated with the Mantra surgical robotic system, it enables real-time control of robotic instruments, extending expert-led procedures across distances. Its compact design eliminates the need for a full operating room setup, making telesurgery more accessible and flexible, revolutionizing the field by bringing surgical expertise to any environment. We have developed 5mm instruments for pediatric and other specific indications where this will be very helpful because of the smaller size of the instruments.
The thing that I am most proud of, that this high-tech surgical robot has been absolutely developed by a team within India. So it is truly indigenous, made in India for the world.
You know what is the very unique of SSI? Don't think it is economical, very cheap, affordable. No, that is collaterally came. The purpose was to build the world-class, state-of-art, best technology.
We can do total bypass surgery with the help of robot. And in this world, at present, only SSI Mantra gives this technology.
The undisputed pioneer. He's blessed.
The SSI Mantra story is about changing lives, fulfilling dreams, and building a healthier future for all.
Every year, over 14,000
As we just witnessed and mentioned by respected Colonel Navneet Singh Chhabra, our hospital has extensive experience in donor nephrectomies with more than 50 plus done so far. Our team of urologists at Marengo Asia hospitals ensure maximum safety and patient care. I would now like to share a video of a remarkable story, a wife who selflessly donated her kidney to her husband, highlighting the life-changing impact of a kidney transplantation.
Every year, over 14,000 patients across India undergo kidney transplants. life-saving procedures that once demanded long waits, extensive recovery periods, and costly treatments, often only available in metro cities or large corporate hospitals. But today, a revolution in healthcare is changing all that. Thanks to the Mantra surgical robotic system, world-class surgical care is now within reach for patients in Tier 2 and Tier 3 towns across the country. Marengo Asia Hospital in Faridabad stands as an institution, distinguished by its state-of-the-art facilities and unwavering commitment to delivering exceptional, patient-centric medical care.
Transplant is close to my heart. Robotic surgery, especially in urology, has made a big change in the recovery of the patients. Because a robot, you can go through all angles, visualize the tumor better, do a better dissection. Your blood loss has gone very low, and the lesser the blood loss, better is the recovery and more precise is the surgery. I think precision has improved so much after the robotic surgery that you are able to give the appropriate and the desired results. And secondly, because you have smaller scars on the patient's abdomen, so pain is lesser. Patients usually start accepting orally by the evening of surgery itself. So all these lead to less complications intraoperatively, which itself leads to better recovery of the patient.
No longer do patients need to travel hundreds of miles for treatment. The future of surgery has arrived.
मेरा नाम पूनम है। हमारी शादी को 15 साल हो गए। 14 साल का बेटा है, 12 साल की बेटी है। अच्छे से ज़िंदगी चल रही थी हमारी, अच्छे से रह रहे थे। फिर हमारे पति बीमार हो गए, डॉक्टर के पास गए। डॉक्टर ने बोला कि आपके पति की किडनी खराब है। डायलिसिस हुई मेरे पति की, उनका फिर ट्रांसप्लांट करने के लिए हमने सोचा। मेरे देवर भी थे, वो भी बोल रहे थे कि आपको किडनी दे देंगे, पर मैंने ही बोला कि नहीं, आप रहने दो, मैं ही दे दूंगा अपने पति को।
We did a robotic donor nephrectomy. We have been routinely now doing robotic donor nephrectomy. We want that we should be giving maximum comfort to our donors, because donor is not undergoing surgery for himself. Donor is undergoing surgery for his family member or her family member. They are doing it for as a donation to someone. So it's our responsibility that the pain to the donor should be less, the recovery should be fast, and they should be able to return to work as early as possible. Moreover, most of the donors have to take care of the recipients also, because after a week or so they have to take care of the recipient. So that is where robotic surgery helps in.
जब से इसने मेरी वाइफ ने मेरे को किडनी दी है, इसको भी कोई प्रॉब्लम नहीं है, ये भी पहले जैसी नॉर्मल रह रही है।
अच्छा महसूस करे। मेरे पति भी बहुत अच्छे हैं, मैं भी अच्छे से रह रही हूँ, खूब अच्छा काम कर लेती हूँ, अपने पति की देखभाल कर लेती हूँ, दवाई से, गोली से, कपड़े से, खाना देना बनाना सब कुछ कर लेती हूँ।
फायदा किस कारण हुआ? जो रोबोटिक ऑपरेशन कराया है उससे बहुत जल्दी रिकवरी हुई है इसकी।
With SS innovation, I feel time is not far, where all the parts of the country, small districts, small sub-districts are going to get the advantage of the robot via telesurgery and other means coming.
At SS Innovations, the mission is clear: to make robotic surgery accessible and affordable to the masses anywhere in the world.
और मैं तो यही मैसेज देना चाहूँगा, जो भी सर्जरी कराए, जिसको भी किडनी की प्रॉब्लम रहे, तो रोबोटिक सर्जरी ही कराए, उससे बहुत जल्दी रिकवरी होती है, बहुत फास्ट रिकवरी होती है। मैं रितेश सर का बहुत बहुत धन्यवाद करता हूँ, और SSI मंत्रा जिससे मेरी सर्जरी हुई है उसका बहुत बहुत धन्यवाद करता हूँ। मेरी सर्जरी सक्सेस हुई, बहुत बहुत धन्यवाद।
Robotic surgery has significantly transformed the landscape of general surgery. enabling greater precision, enhanced visualization, and improved patient outcomes across a wide spectrum of complex procedures. We now move to our next session, dedicated to robotic surgery in general surgery, where we will hear insights, experiences, and evolving perspectives from experts in this field.
It is our privilege to introduce the convener for this fantastic session, Dr. Sachin Mittal and Dr. Hemant Atri sir.
Thank you very much. I would like to, thank everybody to come here. So now we will be starting with a very important session, robotic in general surgery. Nowadays, robotic has gone, way beyond in this field, and maximum numbers are being done nowadays in general surgery. So it's an important topic of discussion. So I would like to invite our moderators for this session, Dr. Balkishan Gupta. Sir, please. Dr. Ved Prakash, sir. Dr. Narottam Goyal, sir. And Dr. Narendra Gai, sir. So you are all welcome on the rise. So we will be changing chairpersons after every 2 sessions. हाँ सर प्लीज So we will starting this session with Dr. Vikrant Sharma, tips and tricks of robotic mini gastric bypass. I will like to invite Dr. Vikrant Sharma. So Dr. Vikrant is a very dynamic robotic surgeon, and he is practicing in Ghaziabad. And I welcome Dr. Vikrant.
A very good morning to all, and I would like to thank the organizers for giving me opportunity to present this talk, especially, and a very happy birthday to Dr. Ritesh sir. So I'll be talking about the tips and tricks of robotic mini gastric bypass and how it is different from conventional laparoscopic mini gastric bypass. So just to start with, so the first robot was shown in a movie in 1926 Metropolis, and the word robot was coined by the Czech writer, that was Karel Čapek, and it stands for artificial humans. So the role of robotics in bariatric surgery is the first robotic sleeve gastrectomy was performed by Michel Gagner, and around 600,000 bariatric surgeries are performed worldwide annually, out of which 10 to 20% are done robot assisted. The number continues to grow as more surgeons are adapting to robotic surgeries due to its ease and efficacy. So the mini gastric bypass was first done by late Dr. Professor Robert Rutledge in 1997. So it was a simplified bariatric surgery procedure as compared to the conventional Roux-en-Y gastric bypass. It involves a creation of long narrow gastric tube, and hence the name single one anastomosis, hence the name the mini gastric bypass. The early controversies involving the mini gastric bypass was the skepticism from the bariatric community, and concerns included bile reflux, marginal ulcers, malnutrition. Global acceptance and evolutions happened between 2005 to 15. Last series from Europe and Asia showed comparable or superior weight loss results, excellent diabetic remissions, and shorter operative times. The term OAGB, that is one anastomosis gastric bypass, gained preference to reduce the stigma of mini gastric bypass, the word mini. So the official recognition was in 2018. The IFSO recognized OAGB as a standard bariatric procedure. Long-term studies, 10-year trials confirmed durable weight loss strong metabolic benefits and acceptable complication profile. The present status in 2020 is it is considered as the third most common bariatric procedure worldwide after sleeve gastrectomy and Roux-en-Y gastric bypass, and it is widely practiced in India. So the basic questions lies with is it better, is it safe, is it easy to learn, and can we afford it? So for the surgeon, yes, is it safe? It gives the surgeon excellent control of anatomical structures, decrease the fatigue that surgeons would experience during laparoscopic surgery. Robotic arms lift the abdominal wall of the patient on itself, so eliminating the torque which is experienced and the fulcrum effect which is experienced by the surgeon during the conventional laparoscopic surgery. Tremor filtration and no unwanted movements. Stability of the camera decreases fatigue on eyes. So you don't have to be dependent on the camera person, and the static camera gives you gives you ease in performing the surgery. And due to long and strong instruments, 9 instruments, the reach and maneuverability in obese abdomen is very easy. It is less. There is a less dependence on assistant in traction and exposure, and it's a stereoscopic 4K 3D view. So these things you already know that it overcomes the limitations of conventional laparoscopic surgery, and it has an ergonomic user interface, coaxial hand-eye movements, stereoscopic viewer, elimination of fulcrum effects. So yes, obviously by adapting robotic surgery and performing it, you are in a safe hands. For the patient is early recovery, less blood loss, minimum pain score that vary as compared to laparoscopic surgery, it is 2/10. In laparoscopic surgery, it is 4/10 to 5/10. And cosmetically it is equivalent to laparoscopic surgery. So here I present a 40-year-old female patient presented with increase in weight for the past 5 years with OSA and diabetes type 2. Clinical examination revealed weight of 120 kg with BMI of 46.5 and morbid obesity grade 3. After necessary workup, patient was planned for robotic mini gastric bypass. The video is not playing. The video is not playing. So these are, yeah. Can you play the video? Yes. Okay. Robotic sleeve at volume up. So I'll show you how to talk. So it's just a video of the port position. The primary camera port is in line with the angle of the his. So it goes straight. This is the camera port. Roughly 3 fingers above the umbilicus, but it depends from the distance of the sternum. So camera port is here. Then you have this, the R1 port. R1 port, you can show from there. R1 port, that is the 10 centimeter apart and a finger above the camera port. Then we put the Nathansons. So Nathanson. So the idea of the putting camera port towards that side of the umbilicus is that the camera comes a bit sidewards, not on the Nathanson. Otherwise, it will hamper its movement. So these two are in different lines. Then the R2 has been put here, and this will be the stapler port. As so the stapler port is put extra. Yeah, the stapler port, because the mantra has not, SSI guys, they're like it's in research and development. The staplers are not yet been finalized. So the patient is in head up and supine position, leg split. Yeah, again then start the video please. So we are presenting a case of robotic mini gastric bypass, and this is a patient with BMI of 46.5 with grade 3. So we are presenting a case of robotic mini. So this I have already gone through. Port positions have been discussed. So to start with, as compared to laparoscopic surgery, we first measure the limb length earlier in the robotic surgery, so that we can hitch the small bowel in the upper abdomen, and we don't have to go again in the lower abdomen for this process. So first the adequate limb length has been measured, and it has been hitched to the lateral parietal wall with the help of the Weichel 2O. So according to the weight, the limb length was measured and it is hitched. And after this step, we will be proceeding towards. So also it is important to mark the distal and proximal. So So this was the earlier video when I was not using the Nassenson detector and I was using the needle holder for the same. The bougie has been put. So I was telling that you have to mark two threads for the distal and the proximal part of the small bowel, so that you don't confuse and you don't anastomose it in the reverse way. So this is the creation of the lesser curvature window using the ligashore, because at that time also the vessel sealers and was not developed, and we are using a external port for the firing of the staplers, and the green cartridge is fired from the lesser curvature. So after making a window and entering into the lesser sac, subsequent fires with the blue cartridge using the GST blue reload from the Johnson & Johnson company, it has been used. And again for the posterior adhesions, the help of ligashore is taken. So the main two things that need to be developed by the SSI Mantra is a good vessel sealer. They have come up with a new expert seal and obviously the stapler, so that it becomes fully robotic procedure instead of robot assisted. So with the help with bougie, with 40 French bougie inside the pouch, alimentary pouch, subsequent fires has been taken. So discussing about the benefits regarding over the laparoscopic surgery in robotic is that you can see the camera is very, very static, and when you are using your two arms, then you have an excellent control in a difficult anatomical area which will be proceeding towards the angle of his and towards the short gastric arteries. So here you can see in laparoscopic surgery continuously the cameraman struggles and there is a loss of vision. So here you can see the window is created near the spleen, and due to the very static camera, very easily the window is being made, so it enhances the safety of the patient. So and there is a less chances of bleeding because you are seeing what you want to see. The camera is in control with the operating surgeon. And in the obese abdomen, when there is so much of torque is there, sometimes the laparoscopic instruments, they bend and you are not able to approach the area or reach the area. Sometimes the length of the instruments, there it is also compromised despite having the long instruments, because the laparoscopic instrument length is 45 centimeter, bariatric instruments, and the robotic instruments, they are 50 centimeter. So half a meter you can reach in the abdomen, you can reach anywhere. And the camera is stereoscopic, so that the 3D vision, it enhances your clarity of the anatomical structures. So here the gastroscopy is made using the help of the harmonic. We can use the robotic harmonic also. That is much cheaper than the Da Vinci, but still it cost 45,000 rupees for a single case. So the cost constraint is definitely there. So in this particular step, if I compare with laparoscopic surgery, sometimes the assistant is holding the small bowel. Again, due to the traction, sometimes there is entrotomy in the small bowel. So when you are using a robotic instruments, the pinch grip is very, very soft, and you can easily manipulate the stapler inside the small bowel without giving undue traction and causing trauma to the small bowel. So you can see how easily the stapler has been inserted. And again, with the help of the robotic arms, the pouch has been, you can see how easily it has for the gastrogenostomy. Now the stapler is being fired, the pouch is created, it is a type of long feeding jejunostomy, and the stapler is being fired. Now the main part comes, the suturing of the entrotomy. Whether you are doing an anastomosis or whether you are doing the entrotomy closure, the robotic suturing is far superior than laparoscopic suturing, because the laparoscopic suturing is done in a single manner. There is no articulation of the instrument. So your hands remain fixed, and believe me, when there is a 55 BMI patient or 60 BMI patient, or even in a Indian abdomen, the 46 BMI sometimes feel very difficult to maneuver the instruments, as there is a lot of torque. You are not able to perform the maneuvers you want to do in a laparoscopic surgery. But in robotic surgery, due to the 7 degrees of freedom, there are multiple angulations that you can perform while doing the surgery, and hence the superiority of the anastomosis is far better than laparoscopic surgery. Obviously, while laparoscopic surgery you can achieve anything, and it depends on the surgeon's perspective, but yes, these steps are much more duplicable compared to open surgery in robotic surgery than in laparoscopic surgery. So as you can see that the enterotomy is, I am using this 3-0 barb suture for the gastrogenostomy, and the mucosa and everything, it is going inside. There is no pouting of the mucosa. So first we so I'll just rush it a bit. So I'll show you the final picture. So it is an inline anastomosis. There is no twisting and turning. Few additional stitches are applied to support the anastomosis, to take the tension off the sutures, stitch line. And this is the hitch which is taken from the BP limb towards the pouch, so that it takes off the tension from the staple line. It is also from the vehicle 2-0. So this is the final picture. And the leak test will be performed in the end. Yeah, so this is the final anastomosis. One piece of surgicel is placed near the splenic hilum towards the angle of his, so that if there is some oozing, it will be taken care of. So okay. Okay, so the financial implications, the cost of robotic MGB, it costs approximately 4 to 4.5 lakhs in a non-corporate hospitals like mine. And in corporate hospitals, it will cost around 6 to 6.5 lakhs. Partial to full coverage in insurance, almost all insurance companies are covering it if the advanced treatment is covered. Consumables, vessel sealer, ultrasonic scalpel cost much less in SSI Mantra compared to Da Vinci, Hugo Ras, etc. Stapler cost is almost same as compared to laparoscopy in Da Vinci. Mantra staplers are under R&D. So till date, I have done 993 cases of bariatric surgeries. Out of that, roughly 45 cases I have done robotically. Rest I have done primarily in Meenakshi Hospital and rest of the hospitals across Delhi NCR and India. So earlier the past was to see the like having the open surgery without anesthesia. The present is we are doing robotic surgery, and the future will be that everything will be programmed. The patient will be placed in a chamber, and the surgery will be done by the robots, and there will be no surgeon interference. So take home message is, the journey of robotic surgery started in 2001, but slowly and steadily greater advancements we have witnessed over the past few years. It is here and will be here for good. The sooner you accept, the faster you will learn. Thank you very much.
Dr. Vikrant, very good presentation.
Thank you, sir.
And I just want to be asked only one question. When either you do a robotic assisted surgery, I'll you say कि Mantra is advanced. We are doing on Da Vinci, and we have done most of the general surgeries and few bariatric robotics, particularly sleeve, as you have mentioned in your slide. When you are doing the assisted surgery, as you know, stapler is fired by the assistant.
Yeah.
So what do you feel? Ki when you are firing the stapler and an assistant is firing the stapler, safety is the concern.
So the stapler fired is by the surgeon, not OT technician. So the surgeon has to be trained by the chief surgeon. So that is the definitely. So when the mantra, like I said, that they are under the R&D for the staplers, and shortly it is coming. So then it will be fully controlled by. Till that time, stapler has to be fired by a trained person.
We are firing the stapler
Sir,
by the...
Da Vinci has been in the market for last 30 years.
Yes.
So you have to give some time to mantra. In 3 years' time, they have
I
done exceptional
fully
job.
agree. Second is the cost of ligashore.
Sir,
vessel sealer
it should not be a matter of discussion.
Actually, it is not a debate about the platforms, and I think we can take questions at the end of the session.
Just I want to know which telescope you are using. It is 0 degree or 30 degree?
Sir, this is the FlexiTip 0 degree, but it can it's Olympus system in this platform, and it's 30 up, 30 down, left and right. So it's a FlexiTip.
Okay, now you have done a very good job. And we are beginning with the robotic surgery and doing the advanced procedure. It should be appreciable.
Yeah. Now mantra is also.
I initially trained on mantra. Then I shifted to a hospital who have the So this is an Indian made and we have a great future. And doctor who is invented it is our alumni of the first batch of the our medical college. We are proud of that.
Thank you.
Okay.
Thank you, sir.
Thank you, sir. Thanks for the patience with me.
Thank you very much, sir. Now I would like to invite Dr. Sachin Mittal to speak on robotics in general surgery in necessity. Dr. Sachin Mittal is a surgeon at QRG Maringo Asia Hospital, Faridabad. Dr. Sachin Mittal.
Sachin, before starting, I just want to share something. This is going to be a very good discussion and a very good topic. There are two swimmers. One is swim along the flow, and another is going to swim against the flow. So the swimmer who is against the flow is I think it's very keen to hear him instead of Sachin. Sachin is going to just with the technology, but the person who is going against the technology, it is very interesting to hear.
So he's not against.
Already a legend.
Yeah.
Surgeon.
And already a legend surgeon. All the Faridabad surgeon has witnessed that Dr. Paval has just improved the skill of the surgery from very bottom to a very higher level.
Yeah.
Yes.
Thank you so much, sir. Can I have my presentation? I will be speaking on a very important topic. So before that, at Maringo Asia Hospitals, now we have developed a Center of Excellence for Robotic Surgery, Department of Urology and General Surgery and Gynecology. So we have performed more than 50 robotic surgeries in last less than 3 months, which is a remarkable achievement, and we would like to continue this in future also. So robotics in general surgery a necessity. So it is a very important question nowadays, because now robotic is coming in a big way into the market, and now we are in a time when we are overlapping this with the laparoscopic surgery, and everybody thinks that when we are doing laparoscopy in such a good way, in such an economic way, then why we should go for a costlier option for like robotic surgery. So I would like to say robotic in general surgery is not about replacing the surgeon's skills. It is about magnifying it, and in surgery precision it not a luxury, it is a necessity. So the real question should be in which situations does robotic technology changes surgical quality, safety and reproducibility. Not is robotic better than laparoscopy. So this should not be in our mind when we are discussing this topic, that we can do this with laparoscopy in this way, and then why we require robotic for this similar procedure. So it is basically the scenarios where this technology can change our quality of surgery, our safety of surgery, and how can we achieve this in a better way. So evolution of surgery, its natural progression, it started from open surgery, Then laparoscopic surgery came, and now, we are in an era where we are seeing robotic surgery coming in a big way into general surgery. So it represents technological refinement. It is not the replacement of any technology. So robotic is not here to replace laparoscopy or open surgery. It has its own advantages for which, robotic will stay into the market. So this kind of resistance which we are witnessing in today's time, like we are now discussing this topic, whether it is a necessity or not. So there was a time when laparoscopy came into the market, and most of surgeons were doing open surgeries and were having good results and equivocal complications. So these questions I think arise that time also, that why we are going to laparoscopic surgery from open surgery. So whenever a new technology comes into the market, these kind of debates are very genuine. So why robotic, what advantages robotic is having over laparoscopy? So what we can add to the benefits of laparoscopy with robotic surgery? It's 3D vision with 10 to 15 time magnification. So one will say that in laparoscopy also we are having 3D systems, but the vision we will get in robot, it's different from that vision, and it is very stable vision. We are having wristed instruments with 7 degrees of freedom. You can move your instruments in any direction. You can, rotate them in any manner, like Dr. Vikrant showed in his presentation in a high BMI patient. So there is tremor filtration and, motion scaling. So your movements are, very refined. Whatever movements you want to do in any direction, in any angle, you can do with robotic surgery. Better suturing in confined spaces like pelvic surgeries. Pelvic surgeries, they are, it is just a boon to have a robot for pelvic surgeries. In urology, in gynecology, even in general surgical procedures like rectopexy, in hernia surgeries, doing hiatus hernias. Hiatus hernias, it's very good to have a robot because you can do suturing very nicely. You can place mesh around the hiatus in a very good way. Into deeper abdomens in high BMI patients, doing a procedure in a high BMI patient is just a luxury with robot. So it is having clinical relevance in complex hernias, recurrent hernias. Redo surgeries are, robot is very good because you can see the structures very nicely with 3D vision, and in obese patients. So precision and dexterity, these are not cosmetic upgrades. They fundamentally alter, they help us in doing fine dissection. With robot, with 3D visions, you can see each and every tissue fiber very nicely, and there is very minimal blood loss when you see the vessel so closely. Intercorporeal suturing is very good with robot because these are wristed instruments, they can move in any degree, any direction. So your suturing is very good. You don't have to change your, needle and, hold the needle every time. Mesh fixation in hernia repairs, like, we can avoid using tackers in hernia surgery. With robot, you can do suturing of the mesh in a very good way. In gallbladder surgeries, doing a difficult callot is, just a luxury. With robot, you can do a very good dissection with robotic instruments in a difficult callots. So we say in complex anatomy, millimeter matters. So ergonomics for surgeons, why robotic is physically very good for surgeons, like it reduces surgeon fatigue. You sit comfortably on a chair, like, nowadays telesurgery is going on. You can sit in your bedroom or your office and do the surgery in a very comfortable way without having any fatigue. Better posture, you are in a sitting posture, so lesser strain on your legs, on your spine, and it leads to longer career sustainability. It is important in high volume centers where there is a large volume of surgical cases and you have, robots, and you have very less fatigue and you can perform your procedures in a, very effective way. It is a seated console surgery, neutral wrist posture, reduce shoulder strain. So burnout reduction is an underrated advantage. It can lead to a longer career doing procedures in an effective way when you have a lesser fatigue. And you have a long procedure. So if we come procedure-wise, like in gallbladder surgery, everybody says when gallbladder, we do with laparoscopy, what change you bring with robot? Doing gallbladder surgery with laparoscopy is equally effective. Then why we should have a option, which take longer docking time and which is a costly option. But in doing difficult cholecystectomies, when you have a difficult gallbladder, when you are having a previous laparotomy, when you are having dense adhesions, and where you have a difficult callots, this doing with robotic vision is very good. You can avoid injuries, you can avoid bleeding by in a very effective way. ICG is very effective in robotic system. You can delineate anatomy very nicely and can reduce the injury. In acute cholecystitis, especially in obese patient, like in a higher BMI patient, if you want to do a gallbladder surgery, robotic is very effective. Like Dr. Vikrant showed in mini gastric bypass instrument, you are having a very less strain on your arms, and your reach is increased with longer robotic instruments. So doing this surgery in obese patients with robot is very effective. When you are having adhesions, doing adhesion lysis with robotic instruments and robotic vision is very good. So in hernia surgeries also, when you are doing complex hernias, doing TAR, bilateral hernias, so it improves ergonomics and suture accuracy. So it helps in extensive retrorectus dissection, sutured posterior sheet closure, larger mesh placement with precision. In GI surgeries, rectal surgeries, narrow pelvis, articulation improves, mesorectal dissection, fine nerve preservation. In bariatric surgeries, oncological resections, you can do lymph node dissections in a very effective way. So these are the advantages of robot, like improved outcome in complex procedure, enhanced visualization in precision, reduction in post-operative complications, ergonomic benefits, and growing role in emergency surgeries like appendectomies and cholecystectomies. So cost debate is the real question. There is a high initial capital cost, there is a high maintenance cost, disposable instruments, but the shorter stay reduces indirect cost, faster return to work, fewer complications, reduce long-term cost. So robotic surgery is not about doing the same operation in a more expensive way, it is about doing difficult operations in safer and more reproducible way. So learning curve, shorter learning curve for complex suturing than laparoscopy, structured training modules, and simulation-based training. So it may standardize complex surgeries across surgeons. Patient perception and demand. Patients nowadays are having increasing awareness, patient actively asking for robotic surgery, and it is seen as an advanced and safer option. So technology adoption is partly patient-driven. Future perspective, AI integration, image-guided surgery, cost reduction with complications. I will take 1 minute. Wider accessibility in India, and telesurgery may improve reach of specialized surgical care to remote areas with better training and supervision. Just as laparoscopy became standard over time, robotic is moving from luxury to necessity, especially in tertiary care settings. So these are some of the articles which says that these robotic procedures are coming in a big way. Like this is an article from US which is showing a rising number of general surgical procedure over last decade. So these are saying that they are having fewer complications, reduced conversion to open surgery, faster recovery, reduced blood loss, improved precision, and a shorter recovery by 3.3 days. So these are all evidence from literature. This is data from UK, in which you can see the robotic procedure in 2015 and 2024. So every general surgical procedure has grown up by at least 3 to 4 times as advancements are done in robotic surgery. So these are some of the graphs which I just show you that these robotic general surgical procedures, they are on rise. So market is now mainly captured by general surgery. So you can see 32.5% of robotic market is by general surgical procedures. So latest from AIMS, now AIMS is now equipped with all the robotic systems, and it is said that it lead to a 50% reduction in post-operative pain compared to traditional open surgeries. He had, like patients who are undergoing robotic procedure also experience 30% reduction and shorter hospital stay. So this is a data from AIMS from last 1 year, which is also saying that robotic procedures, these are advantage to the patient as well as to the surgeon also. So Indian context, rapid growth in tertiary robotic center, increasing patient awareness and insurance acceptance in metro cities. So robotic in general surgery is not about replacing surgeons, it's about enhancing surgical precision,
we are
improving
running
outcomes
short of time,
and
Dr.
future. So I would like to conclude my talk with this. Thank you so much. Okay.
थैंक यू डॉक्टर सचिन मित्तल. अब मैं मंच पर आसीन सभी हमारे
First, Dr. Prabal talk. Then we discuss.
सर एक्चुअली वी आर स्विचिंग ओवर आफ्टर 2 talks because we have 8 chairpersons per session.
No. Okay.
We have
Yes, sir.
made
Yeah.
brochure
It is
like
a-
this only.
Okay.
So थैंक यू वेरी मच सर. आप इतनी सुबह सुबह आए और आपने समय दिया. आप मंच के राइट साइड आ जाएं और डॉक्टर विक्रांत शर्मा और डॉक्टर सचिन मित्तल. इसके बाद आई वुड लाइक टू इनवाइट डॉक्टर मनु शंकर एज ए चेयरपर्सन ऑन द स्टेज अलॉन्ग विद डॉक्टर निखिल तलवार सर. और मंच पर आमंत्रित करना चाहूँगा शहर की बहुत ही जानी मानी हस्ती हमारे डॉक्टर प्रबल सर. प्रबल सर के साथ मैंने QRG मरिंगो एशिया में काम किया है और सर अभी अकॉर्ड में करता धरता हैं, चेयरपर्सन हैं. और प्रबल सर वेलकम. और आप इतनी सुबह सुबह आए, हम सब आपको धन्यवाद करते हैं. प्रबल सर.
And Ved sir and the same moderators can continue the discussion along with. It is just for the paucity of seats above.
There are 2 seats still available for chairpersons.
We would request Ved sir and Balkishan sir to please, we have 2 seats for the moderators. Please sir, if you could continue the discussion.
I'll give in a few seconds for the lovely photographs here. Can you put it on, please? Good morning, everybody. This topic suggests a little extremism. So I'm not an extremist, I must say, at the start. That's me, all of us. I am nobody without a team, so we are a team. And the robot is not a part of this team. And that's where I work. I work at Accord Hospital. I have no conflict of interest because I don't represent any of the robotic organizations, nor do I perform. So this is something that I want to start at the outset. You see, I stand against the motion doesn't mean that I stand against growth, technology, advancement, future. I have had this exciting surgical journey of 35 years. The only constant that I've seen is change. It's very interesting, I'll tell you, 2007, me and Dr. Ved, we attended a workshop in Delhi where a surgery was telecast from US of a total colectomy. In 3 days' time, we both performed a total colectomy. That was the rapidity with which technology could be taken up. So I'm sure we are at a cusp of something very interesting. I am here to balance the view. My job is not to go against, but just to balance the view. Historically speaking, when laparoscopic cholecystectomy came, the very surgeons who first said that it is useless, join all the 4 ports together and I'll do a cholecystectomy as good and as quickly and as nicely as a laparoscope does. It was the same set of surgeons in 2 years started saying, no, it is the gold standard. And today we believe that laparoscopy is a gold standard for many things. Again, it would feel that I'm going for the motion. No, I'm not yet. The wheel of time has changed again. Today I stand to defend something which is largely considered not very defensible. So let's see who wins. And I must tell you, I am the one with the moustache. Dr. Sachin didn't have. So let's see what happens. And I also probably stand for the weaker argument. So talking about general surgeons, we've had a very difficult time over the last 20-25 years, wherein subspecialties developed very hugely. And they took away a large part of what we had, and we were charitable heroes like Karan. और उसके साथ क्या हुआ आपने देखा बाद में बेचारे के साथ. तो general surgeons को they parted with organs over the last 50 years very rapidly to a very large number of people, and there's hardly anything left behind with them. This is the current breakup. Neck is about 5%, gallbladder is about 30%, ventral hernias. You see another challenge, laparoscopy came in, ventral hernias reduced. तो एक और bread थी जो चली गई हाथ से. Diaper area forms the larger part of, diaper and gallbladder forms the larger part of general surgical practice today. Wound care has also started coming up. It is also quite significant. But then, this penance that the surgeons went through, the general surgeons went through, saw some light. And whether we talk of any mythology, we finally got something, where a general surgeon could become a better surgeon. Mark my words, every word that I use with great caution. Better surgeons. So the robot came in, and I think this is something that we have to learn. All of us have been victim to this one thing. Insurance mis-selling. सबने अपने लाइफ टाइम में कभी ना कभी इंश्योरेंस खरीदी ऐसी जिसके फाइन स्क्रिप्ट को पढ़ा नहीं, and we came to realize at the end of it that probably it was not the best thing that we could have bought. This happens because of stress of selling. So while we stress to sell something new and interesting, at times we end up mis-selling. So this is a word of caution for all general surgeons to pick up and do the right thing, and not to mis-sell this fantastic Brahmastra that has come to us, which is going to give us longevity and life. So we must follow the experience of the thousands of people who have done it and walk ahead on the righteous path. The literature today, unfortunately, does not support unbridled use of robotics. I have a few, but there are so many that I can't tell you. All of them say that yes, it is a very good thing, it is feasible, it is possible, it has got equivalent results to laparoscopic surgery. Some say that there is less blood loss, but similar studies held by, conducted by different centers say it separately. They say that no, there is no great difference in this one complication against the other. So the results are pretty confusing for people who would pick and choose. So I thought I'll draw the attention to this one article, which is, taken up a more controlled view of all. It's taken up all meta-analysis. It has taken up a very large patient base. And it comes to this one conclusion that there is still time to consider this to be something that is the ultimate goal to achieve in surgery. So the review of this literature says that, there is total lack of any conclusive data, and nothing yet justifies the substantial increase in cost. So it takes something away, but also gives something very positive about this. There are certain very specific advantages. One quadrant surgery, cancer prostate and cancer cervix are the areas where probably this is going to be one of the best things to do. There are other areas also apart from this as more data and literature comes in. So again, as I said, I'm trying to balance it. The truth today is that it is a fantastic thing for the surgeon. He is seated, off pressure, he's not scrubbed, there is no strain, there are no hard lights on his head, and he performs the surgery comfortably while being seated. Great. Also, the truth is that we're talking about SSI Mantra, or we talk about Intuitive, the Da Vinci platform. They're making good progress. I have their financial data from public domain. They both are publicly listed somewhere or the other, therefore the data is available. They're growing at the rate of 20 to 40%. Their revenues as well as their margins are also pretty lofty. So that shows that this is something as a trend which is happening all over the world. So I think that's the truth today. So what is driving this industry? It is a very strong campaign from all the manufacturers. And another part of the problem is that I am yet to go to a surgeon's meet wherein 2 or more surgeons meet who do not talk about the robotic platform they have either used or they desire to buy. So there is a huge position statement when it comes to hospitals, wherein if you look at it, I belong to a hospital which is probably one of the very few in NCR that does not have a robot. Yet again, I must say that. It's the surgeon's FOMO. Every surgeon wants to be, in the race. So it's lovely to be there. These all increase the number of robots and the number of robotic surgeries, as Dr. Sachin Mittal showed in one of his last slides, but does not necessarily improve robotic surgery, really speaking. So the current status is that fundamentally this enables mediocre laparoscopic surgeons to become better laparoscopic surgeons. I must confess over here that in this audience, on the chair and as well as here, there are fantastic laparoscopic surgeons. So nothing takes it away from them if they desire to carry out more and more robotic surgeries. The robot does not perform a surgery. The best case scenario, as we've seen so far, is that it is either feasible, the outcomes are comparable, it is similar to laparoscopic surgery, but it's yet to come and say that it is better. But is there a light at the end of the tunnel? Must remember that tunnel is always an illusion. We are on a metamorphosis. The caterpillar becomes a pupa, becomes a butterfly. The pupa looks strange, ugly, and you can't make out what it is. We're probably somewhere there. And I'm sure we're going to metamorphose into something better. Generally, research requires a lot of patronage. All kings in India were great patrons of astronomy, medicine, engineering, metallurgy, everything. Right now, probably we require greater amount of support as patronage for us. And my last hope is that the advancement doesn't reach where it is going so far in my lifetime that I am going to be replaced. So that's something that is going to really hurt us. Technology is always known to leapfrog. We just might miss the middle step where the surgeon is getting trained to become a better robotic surgeon, and it is a machine that comes in and replaces us. So that is probably going to be one of my saddest moments in life as a surgeon. But I think more data, more time, and more evolution is required, more structured data. I must say more structured data. We must remember that somebody may say that a song is fantastic, provided we change the tune and the lyrics. So the current days, the music, the robotic concept is great, but probably whatever we are doing is still halfway, midway, or maybe somewhere there, but we're still not there on data as to say effectively. Yes, it can be done. There are wonderful people who are doing robotic surgery, but that it is the right thing to do, and it is the thing that has to be done in general surgery. It's probably yet a little too late, too early. As general surgeons, we must pick ourselves up. It is very important that we pick ourselves up, use this Brahmastra rightly, sell it right, so that it reaches the society with the right message. And again, as laparoscopy did great for itself, this also does great for the society and the surgeon. The surgical society also has to thrive and survive. Thank you for such a wonderful, patient hearing. Thank you.
Thank you, sir. Very nice presentation, and I must say very balanced. That you have agreed that I am not against any advanced technology that is coming into the field of surgery. But what I just say that if you are comparing the basic robotic work with the laparoscopy, so there must be some loophole is there, and the time will come when we can say that it is much better than the laparoscopy. This should not be a matter of discussion because we are just struggling with the basic robotic. Now the main point is that if you think about the uniformity of the training, you think about the comfort of the surgeon which is growing older and older, then what comfort he like to be. And the tele-robotic surgery, the programmed surgery, these all advancement can happen only if you are going to accept this technology right now. So this is very good matter of discussion, and I am very glad that you are not completely against this movement. You are just with this movement, but not up to a very strong belief. So very good discussion. And anyone would like to comment, and from the audience, any would like to comment? All are welcome.
There is just one point that I would like to make over here to what Dr. Ved said. It's very interesting to be part of the journey. It's very interesting, very nice, and I'm sure that I'm going to become a robotic surgeon sooner or later. You have to join the bandwagon. But then we have to be tempered in what we do. We have to be tempered in how we do. We should do it right. That's the basic, nothing beyond.
Sir, very good presentation. In my point of view, I am a laparoscopic surgeon, and I opted for 1 year I am doing robotics. Definitely robotics have the advantage, and it's a future is coming from the robotics. The most problem is that the difference of robotic, mainly insurance, which is different for other hospitals, Delhi hospitals, in Faridabad hospital and cities. It is different. If insurance will accept all the patients for robotics, so robotics have the great future, because financial is the main issue in Indian scenario.
So I said that there should be patronage.
Insurance, it should not be this financial burden to the
sir.
nation.
Sir,
Okay.
we have to conclude the session
have-
for want of time.
The
Sir.
chair is supreme. They have to relieve me of
Doctor,
that.
I will give you an answer. Uro-oncology, pelvic oncology insurance is covering very well, surgical oncology. But general procedures, general surgery procedures, they are denying.
Thank you so much. Thank you. This is a never-ending debate. Believe me, we can continue doing it till the cows come home. Thank you. Thank you, everybody. It was lovely. Thank you.
Chairpersons to come on the right side of the stage. So, so now, a very good session. Now we are starting with our next debate. I would like to invite chairpersons on the dais, Dr. Kamal Kataria, Dr. Sumit Chakravarti, Dr. Sujoy Negi, and Dr. Mohit Joshi. So I would request all the chairpersons to come on the stage. So we will be having debate on a very important topic, robotics in postgraduate training. So I would like to invite the next speaker, Dr. Hemant Tantri, who will speak in support of requirement of postgraduate training in robotic surgery. So Dr. Hemant Tantri.
थैंक यू वेरी मच सर। मेरा हमेशा से मानना है कि जब कच्चा घड़ा, मतलब मैं जैसे बड़ा हुआ जिस परवरिश में, मैं हरियाणा से आता हूँ, हरियाणा की माटी से आता हूँ, तो हमेशा ये सुना बड़ों से कि कच्चे घड़े को आप जैसा बनाओगे वो वैसा बन जाएगा। और मुझे लगता है कि जो ये डिबेट है, जब इस ब्रोशर की रचना हो रही थी तो मेरे गुरु डॉक्टर विवेक अग्रवाल सर से मैंने चर्चा की और मैंने कहा आपसे लड़ाई की जाए, क्योंकि विवेक अग्रवाल सर हमेशा ओपन को एडवोकेट करते हैं। और कहीं ना कहीं जब पैनलिस्ट की बात हुई तो हमें लगा कि इस पोस्ट ग्रेजुएट ट्रेनिंग वाले सेशन में हमें ऐसे लोगों को रखना चाहिए जो हार्ड कोर मेडिकल कॉलेज से आते हैं, जैसे कि कमल कटारिया सर एम्स से हैं, सुमित सर ESI में हमारे HOD हैं, और सुजॉय नेगी सर हैं और मोहित जोशी सर हैं। आपका बहुत बहुत धन्यवाद, स्वागत करता हूं और कच्चे घड़े को बनाना शुरू करते हैं, क्योंकि सर्जिकल ट्रेनिंग की शुरुआत जब होती है तो हम ओपन सर्जरीज करते हैं, नो डाउट उसकी नेसेसिटी विवेक सर बताएंगे, लेकिन आजकल पूरा तंत्र रोबोट की तरफ जा रहा है। और ये मैं रियलाइज़ भी कर रहा हूँ कि जब सरकारी हॉस्पिटल्स में पेशेंट्स आ रहे हैं वो दो चीज़ पूछते हैं, अच्छा ऑपरेशन लेज़र से होगा, दूरबीन से होगा, आजकल तो रोबोट भी कुछ चल रहा है, क्या रोबोट होता है, कहाँ होता है, कैसे होता है। उनका मतलब रोबोट ये होता है कि कोई शायद इंसान नहीं, कोई रोबोट है जो सर्जरी करता है, तो कहीं ना कहीं अवेयरनेस की भी कमी है। सो माई टॉपिक इज़ रोबोटिक्स इन पोस्ट ग्रेजुएट ट्रेनिंग। स्लाइड कैसे So in our ESIC medical college we have SS Mantra robotic system and we are doing surgeries on that. Why to discuss robotics in postgraduate training? मैंने बताया जैसे कि कच्चा घड़ा बन रहा होता है and surgical training is evolving rapidly. Robotic surgery is increasing worldwide. So residents must be trained in that technology and early exposure means हम जब कुछ सीख रहे होते हैं तो early exposure is mandatory. अगर शुरू से ही रोबोट की ट्रेनिंग मिलेगी तो रोबोटिक सर्जन और बनने में और स्किल को एक्वायर करने में बहुत आसानी होगी. सो देयर इज़ ए रैपिड एक्सपेंशन इन स्पेशली इन यूरो सर्जरी, GI सर्जरीज, thoracic सर्जरीज, इंक्रीजिंग नंबर ऑफ इंस्टॉलेशन ऑफ रोबोट्स इन इंडिया बिकॉज गवर्नमेंट ऑफ इंडिया भी प्रमोट कर रही है कि गवर्नमेंट सेटअप्स में रोबोट आएँ. And growing demand of robotic trained surgeons in country makes it necessary for the postgraduate training. So what are the advantages? Advantages 3D visualization है, magnified anatomy है, there are tremor filtration and precision. मतलब सर्जन जब बूढ़ा हो रहा होता है तब भी अगर ट्रेंड है, मैं ये कहूँगा कि जब SS मंत्रा पे ट्रेनिंग चल रही थी तो उन्होंने बताया कि आपकी जब एज के साथ ट्रेमर आएंगे तो इसमें ट्रेमर रिडक्शन होता है. तो मुझे लगता है कि सर्जन के लिए प्रिसीजन बहुत इंपॉर्टेंट होती है और it will improve ergonomics for a surgeon and better understanding of fine anatomical planes because it has various degree of movement. Because it is a simulation based training. Open training कभी simulation नहीं होती. Post graduate training में जब हम students को सिखा रहे होते हैं तो उसको demonstrate करना ही पड़ता है. But in robotic we have such provision of simulation training where there is no risk in early training and it helps in shorten the learning curve for a resident. So it is a stepwise module. Robotic training का एक module है in which we have a theoretical understanding, then simulator, then dry and skill modules, bedside assistance and even जब मैं भी अभी start कर रहा हूँ तो console के अंदर under supervision we have to do surgeries and then we can perform independently. What is the role of teaching institution? Teaching institutions, what I believe is गवर्नमेंट को एक करिकुलम लाना चाहिए. जैसे NMC के अंदर अभी गाइडलाइंस हैं कि रेजिडेंट मस्ट बी ट्रेंड इन द रोबोटिक्स एंड वी मस्ट एस्टेब्लिश रोबोटिक लेबोरेटरीज which will promote the skill and enhancement of the residents and along with the collaboration of the various industries, corporates and robotic platforms like SS, Da Vinci, whatever. Of course, cost is a challenging factor in government setup. However, government has lot of money as compared to corporates. अगर government setup में mandatory हो जाए तो robot लेना बहुत easy है, especially the Indian made robots. However, there is a limited availability of such robotic systems in our country in government institutions, make it very difficult for the postgraduates. We need some trained mentors. This is a very big challenge because मैं ESI में भी जब बैठ रहा था तो मेरे स्टार्टिंग में जब केस किया तो मेरे बॉस मेरे साथ बैठे थे, बोले यार ये क्या गेम सा वीडियो गेम खेल रहे हो आप. सो वी नीड ट्रेंड सर्जन्स एंड वी नीड स्ट्रक्चर ऑल्सो. what is the future vision for India? I believe there is a huge potential and we have indigenous robotic platforms. So this academic drive can be reached up to wherever we want. And early exposure during residency will produce better surgeons. What is the take-home message? I believe that robotic in postgraduate training should be an integral part of modern surgery. PG training must adopt technological advancement and structural exposure is mandatory for the postgraduate for this training. Now, this is the SS mantra system at ESIC, and we are doing robotic cholecystectomy. Along with me, my SR is assisting me, Dr. Jatin, and I would like to thank ESIC, my HOD sir, DMS sir, Sumit Chakravarti sir, and my head of the unit, Dr. Vivek, who allowed me to do robotic surgery at ESIC. Thank you very much. Thank you very much.
Very nice talk, Dr. Hemant. So, I would like to invite our next speaker, Dr. Professor Vivek Agrawal, sir. So, welcome, sir.
Good morning, everyone. At the onset, I would like to thank the organizers, mostly Dr. Hemant, Dr. Ritesh, and their entire team to have made this possible to make me stand before the august, reputed, talented robotic surgeons. And it's a pleasure to be here, sir. With the permission of the chair, sir, can I proceed with the talk? कैसे चलेगा? Just press this button. Okay. How does it move forward? इसी से चलाऊँ ना? Okay. नहीं चलता बेटा. हर बारी ग्रीन बटन दबाऊंगा बस. ओके. सो रोबोट्स, इसको पीछे करना पड़ेगा भाई. डजंट मूव. हाँ. My job, sir, has been multiply simplified by Dr. Prabal. And most of the things have been extrapolated through him. Nobody is against robots. I am also a surgeon. I am in the fraternity of surgeons. I would love technological developments. I would love technology to be there, and I always would like to touch, feel, and do something through robotics. No doubt about it. But PG training is a little different subject. That's where I have a little reservation of putting in one more aspect of surgical training into that short period of a PG resident. Exposure to assist a surgeon trained to perform robotic procedures is a nice opportunity, as I said, and we would welcome all postgraduates to be exposed if they are working in that institution where such a facility is available. Solely doing robotic assisted procedures will not make a PG a holistic surgeon, what he is supposed to become. So first he has to become a surgeon, then adopt the techniques to imply the techniques of technology into the practice so that the patients are benefited by that person. A PG teacher like me trains humans to become a surgeon and not mere surgery performing robots. A robotic surgeon must be capable also to revert back in case of difficulty to benefit the patient, for the benefit of life of that patient, not risk it. So he should be capable of being a surgeon. The human anatomy and other things do not change, but they have to be studied, and first surgery and then improvisation on techniques of their applications. So in the needs of PG education today, he should know the basic principles of surgery, know systemic organs function and their disease states, which have never changed, or rather we are understanding more and more. We should be able to diagnose, investigate, treat the dysfunctions and apply the surgical skills to relieve the agony of a patient. To be inquisitive and ever ambitious, as I said, to learn more techniques, more knowledge, to be enthusiastic, to be abreast with the recent developments which are occurring, and to disburse such benefits to the patients. So in short, to become a surgeon, that is, become a surgeon first rather than pursue robots and run after robots to perform surgeries, and understand that we have become surgeons. Do not get carried away by the glamour of robotics and technology. So robots today are a technological innovation and advanced instrumentation that can be effectively applied in areas wherever it is beneficial. Surgeons need orientation, constant training, persistent practice to effectively use that instrument in surgery. Robots are no replacement for open surgery. They can only increase the enhanced recovery after anesthesia, that is ERAS concept, with one of its arms of minimally invasive surgery. As with laparoscopy, the robots too are gaining momentum for use. Laparoscopy has established itself now. Recently, in the year 2019, lots of literature about medical education and robots has come in, but the crux is that it cannot be incorporated into the PG system because of crunch of time. But yes, the orientation, the working, the basics, the application, the touching of a robot, every PG must have it. We can recall the days from open surgery to laparoscopes, like Dr. Roy said, and now laparoscopy has become very well established. Why so? Because it is widespread accessibility, presence of various teaching and learning options and avenues available, direct instrument tissue handling of post-graduation can be done. All PGs can use surgery and a laparoscope to learn upon it. Maybe in future, today as we stand, robots will become like laparoscope, and every PG will like to go ahead, and it depends on what scenario will occur henceforth. All surgical procedures, like Dr. Sachin also said, do not use a robot. Only limited procedures are desirable, especially in constrained places. As I said, PG resident cannot be justifiably trained to become a surgeon from an institute where only robotic surgery is being done, because he will have a very limited, narrow viewpoint of a surgeon. No robot, no surgeon. That is a wrong concept. It is not to be. First, you have to become a surgeon and then accept robots to apply. I am dreading that day when this scenario may happen, that I am standing here and speaking to somebody and only robots are sitting there to listen to me. I would not like to have that. At least this I came across somewhere, so I thought I will share with you all. In my view, what I would say is a robotic surgeon is a person not being involved in it, a robot performing, machine performing the procedure without interference of a surgeon. That's what is a robotic surgeon, and not a true surgeon turned into a robot. So medical education today, just a scenario now to fortify my talk about education. An MBBS graduate is selected for a PG through merit, competition, MCQ based examinations. Thus, experimentations by our MCI and NBE and medical boards have definitely lowered the standards and percentiles of qualifying. You all know, I don't have to say. The choice of subject which is taken up by the candidate is dependent solely on the marks obtained and not by what he wanted, as we used to do it in early. If I wanted to become a surgeon, I would go in for surgical branch. If I wanted to become a physician, I would go into a medical branch. Many students are therefore pursue a PG qualification just because they want to have an MD, MS in their hand, and subject is of secondary choice. Not many avenues of settlement after PG. So many PGs then go ahead for further studies into MCH. And MCH has become a basic requirement for that. That trend to support specialized medical care specific, but it loses a surgeon for the society who could disperse routine care. Compartmental treatments are there by many specialists, but a holistic surgeon we will lose in due course if we continue like this. The students lack interest in understanding the medical subjects because they have come by force, by merit. Similar cycle is now started occurring in MCH course also. They can choose a subject, but they have never got it because their merit was not so. MS is now widely considered as a launch pad for MCH, and therefore no interest is there to get into a polished surgeon and for the benefit of the society which they can provide. Once selected, the senior resident or the surgery resident, he should be, I'm just trying to tell you a few criteria. They should be dedicated, truthful, determined, laborious, intelligent, conversant, and proudness they should be there to imbibe the surgical skills. They should read, remember, assist, work under the supervision, and then do independent execution. Surgery has become so vast, understanding is so vast that everything cannot be compiled and conciled into a small period of a PG graduate training. Many subjects are not touched upon by the surgeons nowadays in training because sub-specializations have occurred, MCH has occurred, CP and litigations. I'll take 2-3 more minutes, and therefore it will continue. Surgeon is being able to realize and acknowledge by force that he is not a specialist despite having a postgraduate degree. So, PG resident of today is a pure, freshly passed out MBBS with no mandatory requirement of non-academic residents not being there, so we do not choose. Trainers and teachers are given raw hands of residents who have to be molded into surgeons. A holistic surgeon is therefore to be made. Adding robots to a PG teaching would further narrow down the same, as I said, and this isn't good for learning surgery. There is and always be a need for multidisciplinary holistic approach for a trained surgeon who will be capable to provide all basic surgical needs for the society. The 3-year PG course is such with all those bifurcation thesis, understanding, DRP programs, rotational postings, appraisal evaluation, so much to do, and adding robot one more, क्या बच्चे को मारोगे क्या इस छोटे से period में? All this becomes a burden on the residents. Understandably, the results of such study will be detrimental and formation of a ill-performed surgeon will be there. I just propose on this platform a proposal that increase this course to 6 to 8 year course, abolish MS surgery, every person should be given an MCH degree. After a basic understanding of surgery, he should get an experience, and if he doesn't want to do a subject speciality, he can be given an MCH in general surgery. If he chooses a subject, after 3 years, he can take MCH in that subject. Robots training can come after this, wherever he is experienced in it, he can go into the training with extra 2 years certification, qualification, whatever, and apply his studies there. So result of the new proposal would be all surgeons with the basic same degree, no scope of inferiority complex, everyone is working to his or her liking. Government also currently says that every specialist should be there in every nook and corner of the country. This can evolve into that, but you have to develop that nook and corner also simultaneously, otherwise nobody can do justice to that. No robotic surgeons soon after PG, absolutely true. To summarize, I would say general surgeon is there to stay, and so is general surgery. Society needs them definitely. PG training must achieve goals of a holistic surgical development and to gain access to excel in caring all multidisciplinary disciplines. Interspeciality referrals must be used. Specialist surgeons to look after difficult subject diseases and have a high volume center operational areas. Robots are not essential in PG training curriculum. Yes, it would be good to know about this technical device given for use in medical field. Have a basic knowledge, and once you become a surgeon, go ahead and get trained in robotics and do the robotic applications. Thank you very much, sir.
Very well said, sir. I cannot agree more than what you already said. The house is open for questions.
Sir, an excellent talk, and I am being a pediatric surgeon. I can say that I train people who have done general surgery and come. So you are my teacher, but I would like to share a small incident which happened 2 months back. And you correctly said a general surgeon is a surgeon from probably head to toe. He must know a lot of things. In MAMC, we share a common OT with ENT. And the ENT professor comes running to me that there's a patient of angiofibroma which was bleeding. Patient has gone into shock in a matter of 10 minutes. And he asked me, requested me, he knows I'm a pediatric surgeon, he asked me to get a vivisection done. So I asked him that proper channel should be sending to the general surgeon, but he said, your OT is just next. So why don't you please quick, because last half an hour the surgery resident is doing a vivisection and is not finding. So I being trained under sir in UCMS, and we had an active burns ward. This is also general surgeon. This is a domain of general surgeon. The patient is bleeding profusely, he's been packed. I just went and peeped. I asked the resident, one is a third year resident and he's training a second year resident of MAMC, which is the premier institute. He has been given an incision of for vivisection long saphenous posterior to your medial malleolus, and he's searching and finding tendons and trying to do a vivisection. So with the most of his ego and most of his this thing, I just asked him to step back. It just took 5 minutes for me, less than 5 minutes, to find a long saphenous vein, and it was a life-saving procedure. And I should believe that robotic is a small part of the general surgery, which is abdomen and chest. And as you rightly said, I think the starting of that way should be introduced to them, but whether to take it or not is, and since there are many who are already in training of general surgeons, I think the whole of MBBS has gone just deciding to sit for an entrance exam. So they are not being trained in MBBS. So we have a very poor quality of postgraduates who are coming in. So robotic introduction, yes, but I believe, thank you so much.
So, very good talk, sir. Both Hemant and sir covered the topic very well. But my view about the robotics in postgraduate training is that wherever possible, we should introduce robots for our residents, because they are the future surgeons. And after 10-15 years, things will be different. Like when we were growing as a surgeons, we were practicing laparoscopy on the virtual models, which were introduced by the Johnson & Johnson. So similar things are available in robotics also. Da Vinci robots, they have a simulation facility. I think most of the robotics, they have facility of simulation facility. So whenever possible, we should introduce these robots to our residents, and it will be beneficial to them.
True, Dr. Kadra.
And no doubt, nobody can replace open surgery.
I too agree with this, but that is subject to availability, and the cost is prohibitive today, so it cannot be available to each and every institution, each and every department, where the PG can touch, feel, and do something on the robot. Yes, in due course of time, it is there. I would love all PGs to get aware of the new developments which are occurring, the robots which are covering, and the advanced robots which are next in line to come up. They would always love to be there.
Well, sir, and Dr. Hemant, both of you have put your thoughts very well, and our generation is intercepted between two kinds of technologies. We grown up while during our post-graduation, the open was going towards the laparoscopy, and now we have in the stage of training to our PGs, then we are going from laparoscopy to other advanced technologies. So technologies will definitely come, but basic knowledge of general surgery is definitely to be imparted to the postgraduate students, and your words are well taken up by the whole panelists, that it should be a holistic general surgical training before going in for specialized training.
Absolutely.
Thank you so much.
Thank you.
Both
Thank you.
Thank you very much, sir.
Thank you, sir.
Thank you.
I will request all chairpersons and speaker to come on the right side of stage. So the final conclusion of these two sessions, I think, if in future more and more data with robotic surgery comes and the systems get cheaper and more and more hospitals they acquire these systems. So robotic surgery is here to stay, and in US this phase is already over and now they are more inclined toward robotic surgery. So whenever a new technology comes, these kind of debates, they are good to see the pros and cons of the new technology, but there is a definitive advantage of robotic surgery nowadays. And as regarding this training part, I think robotic surgery has bring a charm to the general surgery, and more young doctors, they are inclined to take general surgery just because they are interested in robotic surgery, and they just want to have to include this technology in their armamentarium. So thank you so much for patience hearing, and I would like to invite chairpersons and the moderator for the next sessions. Thank you.
Before we move ahead, just a gentle reminder for everyone, there's running tea outside, so if at any point scientific discussions become intellectually stimulating, please feel free to step outside for a cup of tea. Okay. All the postgraduate students are requested to share their PDFs and meet Dr. Hemant Attri for the poster presentations. Please move towards meeting Dr. Hemant Attri. As robotic technology continues to evolve, its impact is being felt across multiple surgical specialties. Among them, cardiac surgery represents one of the most complex and demanding frontiers. The integration of robotics in cardiac procedures has opened new possibilities, offering enhanced precision, smaller incisions, and faster recovery. Our next session focuses on robotics in cardiac surgery, where we will explore how technology and surgical expertise is coming together to redefine the future of heart surgery. With that, let us move forward for this exciting news session.
Now, we would like to invite Dr. Brigadier Samir Kumar to kindly take over the proceedings.
Please welcome him with a round of applause. Thank you.
Morning, ladies and gentlemen. In fact, I disagree with the people who just said that it has moved on into cardiac surgery. For your information, it's been around in cardiac surgery for close to 1998. If you add up, it probably is close to 30 years. That is when Ellen Carpentier did the first mitral valve repair. So cardiac surgeons have always been interested in robotics, and in fact, it's not surprising that the pioneer of SSI Mantra is a cardiac surgeon. So let us start this session wherein we'll deliberate on how far we have come in cardiac surgery in the last 3 decades. Where are we standing now? So to invite the moderators, may I request Dr. Varun, Dr. Rajesh and Dr. Gajendra Goyal to please come. And along with, I'll request Dr. Lalit, one of the speakers, to kindly come on the stage. So this session, ladies and gentlemen, is all about role of robotics in cardiac surgery. As I just told you, cardiac surgeons were the first to start, and there have been a lot of modifications. And Dr. Varun, please. Oh, we are already 4 people. Come. I'm sorry. It's all right. So the first speaker today is the pioneer of the platform, SSI Mantra, Dr. Sudhir Srivastav himself, and we are honored to have him give a perspective on how far we have come. For those who do not know Dr. Sudhir that well, let me tell you that he is the person who has been pushing the envelope all over the world. After doing his medicine from India, he moved to US, where he became a board-certified surgeon and then a board-certified cardiothoracic surgeon. And it was his interest in minimally invasive surgery which pushed the envelope into robotic cardiac surgery, and where he trained many teams from all over the world. And when he came back to India, he realized that we are not able to perform the robotic surgery to that level as it was in United States, and that led to the development of this current SSI Mantra platform. Sir, it's an honor to have you here. May I request you to kindly proceed, sir. Thank you very much.
So thanks for the kind introduction, and my absolute apologies. I was going to come, and while I was in Bombay in the last ICTS cardiac meeting, I got this bug that's been going around, the latest mutated virus, which is very aggressive. And for the last week, and I was really hoping to be out there, but then I think one, that I didn't want to be in crowd and pass it to somebody else. And also, I felt that I think it'll be best that I do it from here, so I'm not coughing right in front of the whole bunch of people. So once again, thank you very much for this invitation. And I see a bunch of people from the crowd there, and my longtime good friend, Dr. Rajiv Singhal, I see him sitting there. So Rajiv, greetings to you. So let me go ahead and share my screen, and we'll get on to the topic here. So once again, thanks, and I'm really proud and happy that this particular meeting has been organized, and I've been listening to some very enthusiastic discussion. I think it's great to see how people look at where we are all heading. My disclosure, and I think there is an echo somewhere. So maybe if you could check, I think there is an echo coming back. As long as it's not in the hall, I'm okay. So I have started to put this as a disclosure because I think having initiated this effort to develop the system, but because it was much needed, everybody started to think I am an industry. So I still perform cardiac surgery, and so kind of a pun intended here. So when we look at the whole cardiac surgery part of this thing, why robotic cardiac surgery? So if you look at the global database, especially the Society of Thoracic Surgery, especially in Europe and United States, almost 18% of the mitrals today are done robotically. And especially in the mitral, you never get better exposure, especially if you are doing mitral repair or all kinds of other reconstructions. Patients recover very fast. In 2 to 4 weeks, they're back to pretty much their normal activities. And there's a huge success rate that has been documented over the period, and there are almost 40,000 peer-reviewed publications today. And again, because of the precision, the magnification, there is a reduced reduction, tremendous reduction of the tissue trauma. And complication rate remains pretty low still, and the hospital stay is again much better compared to other techniques. My personal evolution got interested in MICS back in '96. I think Dr. Subramaniam and others that time held a conference in Minneapolis, and I had attended that, and then got on to various techniques. And earlier on, heart port system was there, so I did whole bunch of coronary bypasses with that system, and then we developed an approach on a beating heart to do everything through thoracotomy, and did almost 800 or 1,000 cases, and we called it thoracab. And then I built a hospital at that time in West Texas, and then became part of the arrested heart TCAP trial with the Da Vinci system, and that was successfully done and subsequently approved. And then I realized that most people will not do the TCAP on a single vessel on an arrested heart, and so got permission from FDA, and then did beating heart TCAP under the physician IDE, and I did 20 cases, and this data was subsequently used by Intuitive to get the warning off in terms of the stabilizer and beating heart TCAP. and then really pushed the envelope, did all kinds of world's first cases, going on to double, triple, quadruple vessel, did simultaneous hybrid in the operating room, that was back in 2005, and then moved to India, as was mentioned earlier, in 2011, and started out at Escort. Very quickly realized, although purchased the Da Vinci system, but it was really unaffordable. So with challenges, I decided that, and I share a very quick story as to what got me from being a cardiac surgeon into the robotic technology world. So I had a patient, a 22-year-old female with ASD. The brother brought saying if she has a scar in front of the chest, probably will not get married for local and cultural reasons. And she was a perfect candidate for robotic, whereby through puncture holes literally on the right side of the chest, we will be able to repair that one and nobody will ever know. And except they didn't have money. And so the brother tried to raise money and he didn't succeed. So, and then I never heard from him. And that was really the turning point in my life, that because of money, patients cannot get the best possible care. So really got involved. I won't get into my personal, very tough journey in terms of financials and otherwise, but we persisted and we finally have created this Mantra robotic system. So my journey in the US, we built the hospital, and that's where with the first generation of the robotic system with Da Vinci, did 750 cases, did 250 TCAPs, and have developed a stabilizer with one of the engineers there with Intuitive. And really this became known as the robotic center globally at that time in 100,000 population in Odessa, Texas. Then got invited to the University of Chicago, joined the faculty, and launched the robotic program as the director of robotic cardiac surgery. And then moved to Atlanta, St. Joseph's Hospital, which is now part of Emory, and created this International College of Robotic Surgery for teaching and training as the founding president. And my charge was to only do revascularization. And so Dr. Doug Murphy was there. He was doing mitrals and intracardiac work. So I did a lot of TCAPs and created this teaching platform. And finally moved to India with the idea to launch 10 robotic programs under the Fortis umbrella. But as I mentioned, very quickly realized, and the cost was very prohibitive for patients, even though, and I had purchased the Da Vinci system myself, and then moved on to Vedanta. Dr. Trehan is a dear friend. And with the same problem, although we did a bunch of cardiac cases, but other specialty was really a challenge, because the laparoscopic options were there. And so when we look at the cardiac application, essentially everything that we do, either through MICS or open, can be done except some of the complex multiple procedures or complex redo cases. But everything else today that is listed here can be done and has been done once you achieve experience and skills. Just talking on the coronary bypass surgery, I think we are all familiar with hysterotomy, and most people still undergo hysterotomy. Unfortunately, India, in fact, is taking a lead on the MICS approaches. So we did develop this thoracare, whereby we were taking bilateral IMAs with the robot, and then through small incision do all arterial grafts. And then finally TCAP, of course, this was my first beating heart patient. Actually, this is a picture 6 months post-op, and you cannot really tell. So I don't show this for cosmetic reason, mainly to stress that there is no skeletal disruption. And this is what translates into less trauma, less blood loss, less complications, and very fast in and outside the hospital recovery. So it is a great thing for the patient. And of course, there is an associated learning curve. So I'm going to share this video. So this one is a double vessel TCAP that I did from the right side. So everybody kind of does not go into the throne one same side. So it was a Lima to LED. So we figured out to put a deep pericardial suture, rotated the heart, and place a stabilizer, and we were able to do from the right side Lima to LED graft, and then brought the stabilizer onto the right coronary. On the right side, we will routinely use shunts, and even now, of course, we use shunts routinely because some of the enabling technologies are gone, and because of the concerns of arrhythmia and ischemia. And those days I was using U-clips, and I probably was the largest user of the U-clips, and developed a technique whereby we will place 5 U-clips ahead of time and then just pass them through. So the anastomosis were very fast. It was interrupted anastomosis, and unfortunately, Medtronic purchased this company and they shut it down. So as you can see, this was possible from the right side. And this was again the early days of getting to the optis marginal, posterior pericardiomy, posterior to phrenic nerve, and again bring the stabilizer, and we were able to do this anastomosis. So I did a quadruple graft while at the University of Chicago using the Flex A automatic connector. And after dissecting bilateral IMAs, we measured it. So I was going to do a sequential graft with the left memory to OM1 and 2, and then the right to LED, and then a small piece of vein to the diagonal. This patient was unusual. So what you see here is the lima getting loaded onto the device. And again, unfortunately, we lost the device. The company went bankrupt, and because again, for the cost factors, and you know, not many people were doing TCAPs, and we are actually developing, and we'll talk about that. So the best part with the robotic was that you don't have to displace the heart, and this is OM2, and you can literally bring your camera and instrument to the vessel, and so there are no hemodynamic instabilities, etc. And a single thalastic suture is placed for temporary occlusion. And especially with this device, the anastomosis are very fast. So after making a puncture hole, I just use the black diamond to pre-dilate. And then the anvil of this device is placed inside. And then with literally push a button by the tableside team, the anastomosis gets done in 6 seconds, and absolutely reproducibly, because it's stapling fire. And so as you can see, it's done, and then the Gore-Tex suture is tied to close that puncture hole. And then previously the artery was prepared for a side-to-side anastomosis based on the measurement, and we did the second anastomosis in a sequential manner using the lima graft. And then the right IMA was anastomosed to the LED, and generally the rima skeletonized will reach even distal, junction of 2/3, 1/3 distally to the LED. And this patient, we had to use vein because this was an unusual case. She had a Hodgkin's radiation, and then both hands were missing. Otherwise, we would have used radial. So we took a little piece from the ankle area to do the 4th graft. So all the 4 grafts were done using this automatic device. And this is my old experience. We actually done more than 800 plus totally endoscopic bypass surgery. Total experience was 1,400 robotic cardiac cases, and almost 40% were multi-vessel cases, and then we combined with hybrid. And I think this was a great way to, especially you can cover the left-sided vessels with bilateral IMAs or single IMA, and then stent on the right side. And we had wonderful results actually. And then we started to combine these with valves as well. So in younger patients, instead of putting a stent, we'll do the lima to LED and then repair the mitral valve. These results were quite acceptable and includes all our early experience. And so there were some conversions, and I'll talk about that in a second about, so we had presented a paper back in, I think 2011 at the Society of Thoracic meeting, where I reported 164 consecutive cases with no intraoperative conversion. So we figured out, and initially there used to be conversion, as it's been pointed out here, but then we figured out how to deal with very acceptable results actually in a large series here. And this is a paper, if you guys are interested, read this one, and you'll find a lot of information in relation to how to evolve, whereby you can minimize conversion. One thing I did say at the end of the presentation, that conversion is not a failure. but failure to convert when required is an absolute failure. And one should not wait for emergency to occur. One should electively convert, and it is perfectly fine. Even if you have 2, 5% or 10% conversion, at least 90% or more patients will have closed chest surgery, and then surgeons will evolve. And we used to do CTAs on before discharge, and mainly again because we were developing all of these procedures to make sure that we are achieving the required graft patency. So this was a triple vessel graft that we did. Now, why there is a low adoption? I think, of course, a steep learning curve, the anastomotic challenges. Now, a lot of these devices have gone away. So currently, we are using 7.0 Pronova or 7.0 Prolene short length suture. I think the compromise of the graft can have serious consequences. Arrested heart really is not a desirable way of doing these procedures. And again, very few in the world are doing so. There is a lack of mentorship. Isolated LADs are not available because our cardiologist colleagues have been doing. But we have shown that if you come up with a less invasive approach, or especially a closed chest approach, then you will get the cases. Cardiologists also know lima to LAD is the best thing, better than stents in the long run. And bilateral IMAs are better than any of these vein grafts. So I think once we do, then patients will come. I think the biggest issue was the cost factor of the system, and only 7% of the population in the world was benefiting, mainly United States, Europe, and Japan, and 7 billion people really did not have access. And then, of course, Da Vinci, as you know, stopped supporting cardiac completely, and they stopped the stabilizer. And now, of course, because of, I guess, our existence, they've decided to go back into this thing. But that also is only for the Da Vinci 5, which is quite expensive, actually. So intracardiac side, and this is also, I show this one. In 2002, we did the first case at Escorts. Dr. Trehan is there, and President Abdul Kalam was there. So I show this one mainly to show that over 22 or 23 years, the robotics in India and for the cardiac has been pretty dismal, actually. So we have a very small number of robotic systems, 430, including almost 170 of Mantra systems today. And the main reason has been cost of acquisition and implementation. And so what is our goal regarding the cardiac surgery is to really create a very friendly and have enabling technologies. And it must be applicable for the entire spectrum of cardiac surgery, and that means, including closed chest, bypass surgery, and all intracardiac procedures, tumors, etc., and congenital ASD, BSD. So this all can be achieved, actually, and really have a structured teaching and training program, which I'll talk about in a second. We hope to launch next month. So this is really our Indian cardiac scene. It is pretty dismal, in fact, when you look at the numbers here. But what it translates also, there's a great opportunity to be able to revive the cardiac bill in India, and maybe India can become a leader over the years by adoption, because I see tremendous enthusiasm, and I saw that while in this meeting in Bombay. So the vision for me was to really create a technologically advanced system, and not to copy Da Vinci as many others have done, and to create which will be most importantly cost effective. Otherwise, it will not benefit most patients around the world. So very quickly, I think people are aware of our system. It is different. It's a modular design. Each arm is mounted separately, and we can use 3, 4, or up to 5 arms. The 5th arm will be used for some of these automated connector that we are developing for its deployment. And we give 3D vision actually to the entire team, both surgeon as well as the tableside team. So the accidents are avoided. I was operating in South Korea back in 2008. Nurse put a knife right to the heart. I asked her what happened, and she said, I couldn't tell how deep I was going. So what we have done, it really achieves efficiency as well as safety. So accidents don't occur. And the surgeon console is very different. Again, it's an open-faced console with magnetic sensor-based control. And then there are 2 toggle paddles to be able to control 5 arms from there. Another thing is we have a large 2D monitor. You can pull any of these images, either angio, CT, MRI, and what our team has developed through proprietary software, convert these DICOM images on the fly into 3D model that surgeon can manipulate. And it's just like if you're worried about an intramuscular LED, you can get the CT up there, convert it, and then cut right through. You will know exactly where it is sitting. And this is our latest thing that we have also developed for telesurgery. And in fact, it might be replacing the console. Is a chair, we are calling it Mantrasan. Trying to use all Indian words because it's an Indian system. And it's really remarkable. We have done cases now using this chair. In fact, back in November of last year, I operated from my living room and did a case at Dr. Lalit's patient there in Jaipur, 300 kilometers away. It has all the features, and these glasses give you beautiful 3D view. So you get rid of the monitor, the foot tray is retractable, and it has all those five, ability to control 5 arms, and everything else is there. It is very comfortable, and you can literally sit in the chair without having to bend at all, and then to be able to perform surgeries. Initially, we have been using endoscope that was done by Olympus, but now we have advanced to 3D, 4K endoscopic rigid scope, 30 degree and 0 with built-in ICG. Beautiful 4K resolution actually, and currently nobody has this, and the length is 400 millimeter, which is desirable for robotic applications. More than 20 different types of multi-specialty instrument. In fact, we have more than 40 different multi-specialty instruments, but these are cardiac specific, 20 different kinds. And everything is there for all kinds of cardiac procedures that are required, ports, fine black diamonds, spatula, etc. And also we have the stabilizer, as you can see on the right side, and a whole bunch of TCAPs have been done, and I know Dr. Lalit will talk about it. There are 2 types of atrial retractor, one for the right atrium and one for the left atrium, which is deeper blade. And then we are developing this both multi-file clip applier as well as automated connector reality. And so this is a little quick animation of the connector that we are working on. Once the artery is loaded, anvil is put in, it comes down. It's very different than what you saw earlier. And literally in 6 seconds, you are done with the reproducible anastomosis. So this will absolutely revolutionize actually, because this has been the biggest challenge, and this is why TCAP failed. And this is part of a robotic side whereby we mount this thing on the robotic instrument, completely surgeon controlled. A couple cases here. So Dr. Nitin Rajput was our earlier thing, and so this is in fact a video that I worked with him, and so this video is from Dr. Nitin Rajput, who did this mitral, and using core knots actually makes it much easier in the robotic world. It saves almost 20 minutes of cross clamp time, and also you can drop the valve inside, so you don't have to do all suture management except the first 4, and then this cardioplegia is generally single shot, depending on how long, or you can always give another dose. And so this was another sinus venosus, and this was actually done telesurgically. And this was done double patch, one to close the defect and then enlarge the SVC, as mainly to really show that everything literally can be done with the system. It responds very precisely, and we've done literally telesurgically also TCAP while I was here. Dr. Lalit's place patient, and again, and this one is this is a continuation of this sinus venosus defect. We place these atrial retraction sutures, so you get a beautiful exposure actually, and the best part is you can bring the camera very close, so you see everything in a very magnified way. So first the sinus venosus defect was done, and then the patch enlargement of SVC was done. So this has been we have now done more than 450 cardiac cases. between mantra 2 and 3. All the recent 300 plus cases are now with mantra 3. And as you can see, IMA, of course, created the bulk because you get past the learning curve, and then a whole bunch of ASDs, bilateral IMAs, mitral, TCAPs. So all these things are done with wonderful results, actually, that we have experienced. Training is very different, and I think we are going to be pushing more and more teleproctoring and telesurgery, because it's not easy to fly people here and there. We go through a very formal training, and some of the results that you see is really with the proper training and formal mentorship. So I am guiding a surgeon literally sitting in my office in Ahmedabad and then also Bangalore. So I didn't have to leave my place. And so basically, you can guide the surgeons without having to travel. And telesurgery is the next step, and because you are aware that originally the robot actually were being developed by NASA or DARPA in US, but the technology was not there, bandwidth didn't exist, and it was shelved. And so basically we have come now, and this was the Lindbergh that they did from New York to France, using the computer motion as a platform. Mainly it was shown that yes, you can do this thing, and this was done almost 24 years ago. So when we talk of telesurgery, and I'll spend a few minutes, I think it's very important that this is really what is going to push, and particularly in India, and not only a launching program, but literally helping patients wherever. And so three things are needed. You need robotics, of course, you need telecommunication, and then information system. And so even in the operating room, robotic surgery is a teleoperation. So the only thing various is now you take that from the surgeon console to the remote location using any of these communication channels. And what we have done, we have used fiber optic point-to-point communication with literally no loss of frames. It's very cyber secure. Nobody can get into it because it is secure leased line. And in fact, this is the latency. Up to that point, it is acceptable, because beyond this, brain starts to get confused a little bit. You can still manage, but in our telesurgery cases, mostly the latencies have been 35 to 45, 50 milliseconds. And I think this is really going to be very helpful, because right now, most of the care is urban centric. And patients have to travel to receive care, and then consequences of limited access, either delay in diagnosis or poor outcomes. And current telemedicine is mostly hyped up, WhatsApp video call or Zoom calls. So essentially, the real telesurgery will be very helpful in terms of expanding reach for the patient to the expertise, and great for launching, teaching, and training of the new programs. And then also people who have networks, and I know Morengo has got multiple hospitals, so once the surgeons become very good at it, these surgeons who are champions now, they can extend their actually ability to other peripheral hospitals. And it really will help in the long run by increasing the volumes. Patient will stay wherever, and so I think it will be very helpful. And again, you help retain actually surgeons. Because otherwise people keep moving around these days. And of course, it's a great market in terms of reputation side, that you have this ability that you can tap into the wonderful expertise and optimize actually specialist resources without having to travel. So other thing is this whole hub and spoke model, and Apollo is really very aggressively moving forward with this one. And so basically the expert surgeon sits down, and take example on the cardiac side, 3 hospitals, each surgeon is taking the intermemory down, staggered, and then the surgeon who is expert, who can do the anastomosis, can help each patient without having to leave the office. So this will be a great thing, I think, as we move forward to extend the care for the patients while helping launch these programs, and also giving guidance to your new programs, and build the confidence that somebody is there to help you, and the next time they can try and you can watch. So this will become very popular actually, and we are already seeing its effect. Back in, I remember November actually last year, no, I'm sorry, it was December 23rd, we did 24 telesurgeries from our office. So 24 patients benefited literally around the country, and this was done in 12 hours between 9 surgeons and from our office in Gurgaon. And then again, hospitals are collaborating with each other. And also February 14th, Valentine's Day, Dr. Mohit Bhandari and Dr. Priya Bhave, they did 19 cases. So Dr. Bhandari traveled to Dr. Bhave's hospital and vice versa, and then cases were done literally sitting in this chair. So in terms of the whole risk mitigation, one must actually have good telecommunication. You must have a remote surgical team, so the patient outcomes are never affected. So it's very important that we don't take it lightly. Firstly, expertise is needed, then reliable telecommunication, and third, a team that can take over in any eventual. So far, we have had zero conversion in almost 150 plus cases. I think I'll skip some of these movies. We have done now from 5 kilometers to 10,000 kilometers. I personally operated from France, in Strasbourg to Indore. I did a ASD, 10,000 kilometers of communication distance with very acceptable latency. And so this is our telesurgery. We have now done more than 152 cases, and in various specialties. I think Dr. Mohit Bhandari is a champion because of his volume of bariatric surgery. 18 cardiac surgeries now have been done of all kinds literally at this point. But you can see that all this is feasible, I think, once we become comfortable and we can extend the care to wherever required. This is the chair that we have already talked about. We have a bus which has a system also. It is called the Mantra M. And this has made tour all over the country literally at this time. One is for teaching and training and conferences. Secondly, also create awareness. So in one village, almost 400 students went through seeing this thing, or villagers coming and seeing. So mainly then they become aware that there is option available for them, because many of these people are not even aware of robotic option. So I think this is a great service. Now, what we are looking into future, and in fact, we are going to invite you all to this, our third global SMRSC conference, whereby this mobile operating room will be revealed. And this is really going to be the future, whereby on a truck this will be mounted, and it can travel, and one can do from wherever. And as you can see, there are no cables at all on the floor. And it's a very different customized design that our team has developed. And we will be showcasing this in April 9th, 10th, and 11th at our conference at Bharat Mandapam. And again, for people who do want to implement this one, if you're building a new operating room, I think it's a great concept, very different than everything else that exists today. We are also working for Army and creating a drone-based whereby in a real life-threatening emergency, remotely this can be controlled, and one can deal with the emergency and then airlift the patient. Because we were approached by Army brigadier, and they're saying that many of these patients don't make it even for the airlift because they have lead. And so we are working towards this one, and again, a prototype will be showcased at our conference actually. So we are launching this SSICRS, is the International College Center for Robotic Surgery. It will be a very organized teaching and training program, and people who have been to our facility in Gurgaon, we have a phenomenal teaching center where there's a full digital wall. We can bring live cases right there instead of people going into the operating room. My plan is to do 5 days of intensive course in every specialty, and I will be starting out with cardiac, and then there are a whole bunch of faculty members, both nationally and internationally. They will be participating. So I've been hoping to get this started next month. I think when we talk of the cardiac surgery, we have already covered, and these are the things that will actually help to continue to push envelope for robotic cardiac surgery adoption. So, in conclusion, I think patients do want less invasive options today, and hysterectomy is only good for the surgeon. And of course, yeah, there are some cases one will have to do sternotomy for the sake of the complexity and not compromise. And ultimately, robotics will help achieve the least invasive option for these patients. This will be the future. Broad spectrum cardiac surgery is feasible, as we have demonstrated. There is learning curve, and one must actually go step by step. India has a tremendous opportunity because of the number of procedures India does, and biggest factor was the cost, which we have addressed actually. So we, as a country, have an opportunity to become a global leader and really to focus on decentralizing and democratizing access with tele capabilities and really become patient-centric, because ultimately, take India, almost 60% of our people live in rural areas, etc. So the goal is really to be able to give the best possible care to everyone without consideration for money, and this will be a model for rest of the world. So this I show what has been driving me personally in robotic cardiac surgery. This is an 82-year-old farmer from Haryana that I operated back, I think it was 2012, of course, using the Da Vinci system then. And he went home after 2 days. A week later, he was back on his farm. So this is, I think, huge, and we can, as surgeons, contribute to this evolution. Very grateful to our young team of Indian engineers and all support people. And we took this picture on a Diwali day. And I say that if it wasn't for them, we will not have what we have today. So very proud that we have created this thing in India. This is the invitation, and hopefully you will all get this thing. Please join. This will be a wonderful, with national and international faculty, all kinds of live cases, and you will see a lot of our future development plans during this meeting. So with that, thank you, and Jai Hind.
Dr. Srivastav, thank you so much for taking us through the journey of robotics in cardiac surgery, your personal journey, and how you have moved on and what challenges you have faced and what is the future in our country. And we really need to thank you for the vision which you have and how you are going to take the things forward. Being a cardiac surgeon and primarily a person who's worked in the army for 35 years, I was very fascinated to see that how the spectrum of warfare has changed with a lot of drones coming in and casualties are not being able to be evacuated. I think that was an excellent solution which you came up with, offering robotic surgery forward and stabilizing those people. So thank you very much, sir, for your insights. And I think a round of applause is very much in order. Thank you once again.
Thank you very much for the opportunity. Thanks.
So since we are running a little behind time, we are going to split this session here. The rest of the session will be after the inaugural function. I'd like to thank the moderators for their presence. Thank you very much. Dr. Lalit will have your talk after the inaugural function. Thank you so much.
Good afternoon, everyone. Ladies and gentlemen, in keeping with the rich tradition of the country, we now begin this conference with a ceremonial lighting of the lamp, symbolizing the triumph of knowledge over ignorance and beginning of an auspicious evening. May I now request our esteemed dignitaries to kindly come forward and grace the stage for lamp lighting ceremony, marking the formal inauguration of this conference. May I have the honor to please invite our founding member, Group CEO, Managing Director, Group CEO, Maringo Asia Hospitals, Dr. Rajiv Singhal. Chairman and Managing Director, Dr. Rakesh Gupta, Sarvodaya Hospital. Chairman and Managing Director, SS Group of Hospitals, Dr. SS Bansal. CEO, SSI Innovations, Dr. Vishwa Srivastav. IMA President, Dr. Rajiv Gumba. DMS ESIC Hospitals, Dr. Sumit Chakravarti. HMC Registrar, Dr. Mandeep Sachdeva. Program Clinical Director, Robotic Uro-Oncology and Renal Transplant, Dr. Ritesh Munga. DCP, Mr. Abhishek Jorwal. And Dr. Hemant Atri, ESIC Hospitals, Faridabad. May I have a please round of applause for the dignitaries. And Dr. Navneet Chabra, of course, to please assist. Now I would please like to request our organizing chairman, Dr. Ritesh Munga sir, Dr. Ritesh Monga has been at the forefront of robotics in urology, bringing advanced technology and redefining surgical expertise together to improve patient outcomes. Please join me in warmly welcome Dr. Ritesh Monga.
Thank you very much, Dr. Amrita. I thank you everyone who has taken out time to be part of Robo Fest 2026. All the dignitaries, Dr. Vishwa, Dr. Singhal sir, Dr. Gupta sir, Dr. Bansal sir, IMA President Dr. Gambhir sir, Gumbar sir, Dr. Chakravarti, Dr. Mandeep sir, who has travelled from Panchkula for the conference, the Registrar Haryana Medical Council, Hemant, who has been my strength throughout the conference. So it's wonderful that we are having such a gathering for Robo Fest. It's like I started my robotic journey around 2 years back. I'm so thankful to Mantra, which supported me for my initial training. Then we did the first robotic transplant of the country outside of Da Vinci. So they supported for everything. And now today we are conducting a conference where I have completed around 200 robotic surgeries. So now we are at Robo Fest, and very soon we have a major robotic conference coming up in the next month. And very heartful thanks to all the dignitaries on the dais. Thank you.
Thank you, Ritesh sir, for those wonderful insights. Ladies and gentlemen, it is my distinct honor to introduce a visionary leader whose commitment to transforming healthcare continues to shape the future of our institution. Dr. Rajiv Singhal, founding member, managing director, and group CEO of Marengo Asia Hospitals, has been instrumental in building a healthcare ecosystem grounded in the philosophy of patient first. Under his excellent leadership, Marengo Asia Hospitals has rapidly grown into a network committed to clinical excellence, innovation, and global collaboration, establishing centers of excellence and strengthening international clinical partnerships. His vision of advancing healthcare through the principles of teach, train, and treat continue to inspire us and elevate standards of patient care. Ladies and gentlemen, please join me in warmly welcome Dr. Rajiv Singhal sir.
Very good afternoon to you all. Thanks, Amrita, for being so gracious and using kind words. Thank you very much. My friends, colleagues on the dais, all the faculty members who have decided to dedicate 2 days for this Robo Fest, I welcome you all. On behalf of Marengo Asia, I would just want to add a few things. When I look at passion and people actually accomplishing passion, there is an example which I have seen in Dr. Sudhir Srivastava sir. Met him in 2011 when I was heading a Scots Heart Institute. He had come from US. That's the place where I could see the passion, and today what man's passion and dream can actually create a company which is standing tall and strong in front of people like Da Vinci and Intuitive. I think kudos to him that he has put India on the world map. A round of applause for Dr. Sudhir Srivastava, I would say. And I think lesson for all of us, if we have passion and if we have the courage to drive that, I think we should not sit back. And age is just a number. And I don't want to tell you guys how young he is, but he is too passionate and he still wants to continue to drive this with passion. So great work done. Similarly, I have said this multiple times, science and art of medicine is a combination of man and machine. In 1979 was a time when Ferrari had won the first world championship. It took them 21 years more to get a Michael Schumacher for them to come back to become the champion again. Michael left. 2006 was the last time when they won the world championship again. It's 19 years since they have actually again brought Ferrari into the winning stable. So whenever you do not have, you have one combination, the brand is strong, there's nothing to beat Ferrari. The amount of money they spent on that brand is beyond anybody's calculation. What is missing is man behind the machine. Robotic is a similar situation. I heard a lot of deliberations, discussions about people talking about what is good, what is bad, what is ugly. But I think at the end of the day, a combination of man and machine is something which anything can elevate the standard of care for the patient. We should not have any doubts in our minds. The boundaries and the brackets are drawn by us. We have surgeon like Dr. Ritesh. Last week only he operated a case sitting from Faridabad to Kolkata. Fortis Kolkata, the robotic prostatectomy was done, sitting from Faridabad, putting Faridabad on India's map. That is what passion can do. So I think I want to appreciate Dr. Ritesh for doing this with passion. You meet him, he's literally super passionate about what he wants to do. So I think as we move forward in our science, there will be a space for technology. It is changing much faster than when we can think about it. AI is talk of yesterday. Things are moving at a much different pace. And trust me, if we do not adopt to technology, we can continue to be the naysayers. But if we really want to progress, I think we need to adopt technology. Faster technology boots us out. So I think that will be my message to everyone, whosoever has come here. Please adopt technology in whatever form and shape this thing. And being a Fauji, this thing I have always said that I would love whatever is being made in India, for India, and for ruling the world. And I'm very firm believer, and when we decided, we bought 3 Mantra robots at one time. And I said, I want to take the plunge and I really want to sign off on saying, guys, I trust what Indians make more than anybody else. And I would actually work on that. And I think the belief what we had today when we are sitting here demonstrating the Indian robotics system to the world is testament, is basically proof that yes, we can do it. We have arrived. This century belongs to India, and we should not only be subjected to the multinationals, and we should actually drive India to a much bigger and a better platform. Once again, thank you all for spending time on Sunday afternoon, but I am 100% sure the sessions which you are going to attend, there will be a lot of stuff which you can take back and drive your institutions and organizations to elevate the patient care. Thank you once again.
Thank you so much, sir, for those encouraging words and sharing the vision that continues to drive Maringo Asia hospitals towards clinical excellence and innovation. Now, I would request Paras to please give the mic to our registrar, sir, for giving us a few words of motivation.
Good afternoon to all. I would like to congratulate Dr. Ritesh, Dr. Hemant Attri, and SS Mantra and their team for organizing Robo Fest here. Actually, this is just beginning or start in Haryana. It was, as told in previous lecture, 24 years back, some robotic surgery was done. But in Haryana, it needs to be started and cover whole Haryana. I would like to request Dr. Ritesh to go to civil hospitals also, government infrastructure also need robotic surgeries so that it can spread to whole of the people. Thank you. Thank you so much.
Thank you so much, sir, and point taken. And now, please, we would like to request Dr. Bansal, sir, to share a few words.
First of all, I would like to congratulate Dr. Rajiv Singhal, Dr. Ritesh and their team for organizing such a beautiful meeting. And I'm so excited to, I was also not aware that, Indian company, SSI Mantra has made a robot which is like not less than Da Vinci, a robot which is so expensive. And the other important thing is that a word of caution for everybody, I would say that it requires a very big learning curve. It is not easy to shift your practice from open surgery to laparoscopic. It requires a lot of training. Again, from laparoscopic to, robotic surgery, it again requires a very good training. And I'm sure the SSI Mantra the company will be able to provide that kind of training, and I want that every surgeon who wants to go to robotic surgery should first learn it properly so that no harm is done to the patient while you are adopting a new technology. You should not harm the patient. Thank you.
Thank you so much, sir. Wonderful insights. Now I would request Paras to please hand over the mic to Dr. Gupta, sir.
Good afternoon. I must congratulate Kiwaji Hospital, Dr. Rajiv Singhal, Ritesh in person, and Hemant as a support, who have organized this conference at a very big level. I've been through some of the sessions by Srivastava, sir. Mr. Srivastava is a first generation entrepreneur, and he believes in Make in India. It is a tough challenge to develop a technology against multinational giants. And after years of perseverance, he's been able to achieve it. So today we are witnessing the SSI mantra here in this conference, and I'm sure I wish him all the best for his bright future. I also appreciate that science is ever evolving. See, we evolved from open surgeries to laparoscopy, and from laparoscopy now we are evolving to robotic. Robotic may not be replacing the entire laparoscopic world, which we emphasize today, but I'm very sure that in certain select segments, robot is going to help the dexterity of the surgeon to a large extent. As a physician, I primarily understand that robots help the surgeon to reach the places where he cannot himself reach. For example, pelvic surgeries. But as a learning curve, we do perform certain things which give us a chance to do dexterity exercises. For example, cholecystectomies, which can be done in an open way as well. I still appreciate that, okay, in the interest of the learning curve, we can still do it. My word of caution against Dr. Bansal said that let us be justified in using the machine for the right purpose, for the right patients, in the right spirit. Things are here to come. The future is with us with the robotic surgery. I wish all the robotic surgeons a very bright future. Thank you.
Thank you so much, sir. Also, we have Dr. Vishwa Srivastav, who is the CEO from SSI Mantra. Sir,
thank you, everyone. So firstly, I'd really like to thank Dr. Rajiv Singhal and Dr. Ritesh for cordially including us in this very important event. But more importantly, I'd really like to thank Dr. Singhal for actually aligning his vision, his predisposed vision of the country with our vision for the country, and then collaborating and joining hands, long back when many people were still on the fence, whether or not we would even be around today or not. So because of, he was willing to take this chance, this risk on us, we took a risk on him, and together now we're, with doctors like Dr. Monga and others, from the Marengo family, the results and more patients are being, treated on a daily basis. So for that, we're very grateful at SS Innovations for providing this opportunity to help you help more patients. And then the one thing I will say that, when we first started this journey, a lot of people were skeptic that this could actually be achieved in India. See, there's no reason why this could not be achieved in India. The biggest problem historically was opportunity, for technology, opportunity to learn, opportunity to displace the existing, technologies that we import into the country. So I think that, we've demonstrated, through many challenges that this can be achieved with perseverance and vision. And we would encourage, as Dr. Singhal had mentioned, encourage all others sitting in the audience, if you have an idea, please chase it. And if you don't chase it, I can guarantee you someone else will. So please, make us all proud, just as we hope that we've made the country proud. Thank you.
Thank you, sir. Very motivational words. Now I would request Dr. Rajiv Kumbar, IMA President, Faridabad. Sir, please.
Good afternoon, everyone. All the luminaries, all stalwarts of the corporate world, Dr. Rajiv Singhal, Dr. Ritesh Monga, Dr. Hemant Attri, Dr. Mandeep Sachdeva, and all the delegates who have come there from far off distances. It is indeed a matter of great pride that Robo Fest 2026 is being organized. This is a conference dedicated to the advances in robotics. It is being organized in our city. It is our good fortune that it is giving a good name to Faridabad throughout Haryana and rest of the country. On behalf of IMA Faridabad, I extend my heartfelt congratulations to entire organizing team for successfully hosting such an important academic event. I convey my special appreciation to the chairman, Dr. Ritesh Monga, secretary, Dr. Hemant Tatri, Dr. Rajiv Singhal, and Dr. Navneet Chabra, along with SS Innovations. It is a remarkable effort in conducting this conference and providing hands-on exposure to the delegates. This is really remarkable, bringing the van here and giving the hands-on exposure to all those who are willing to go in for robotics from laparoscopic surgery. I heard the lecture of Dr. Prabal Roy. I think he was given this topic far and against. He was not, heart of heart, he was not against it, but he enumerated few points that should be always kept in mind while going in for robotic surgery. For few special cases, definitely robotics is advantageous. Maybe rest of the time, surgeon can go in for laparoscopy for its benefits and for the expertise gained by all the surgeons throughout these years. I am confident that all the delegates will greatly benefit from the insights and experience shared by eminent faculty. Moreover, this event is going to highlight Faridabad as an emerging hub of advanced medical care and technological excellence. I extend my best wishes for the grand success. Already I see it is a grand success of the conference and congratulate the entire team once again for this commendable initiative. IMA फरीदाबाद की तरफ से पूरी टीम को शुभकामनाएं और धन्यवाद. Thank you.
Thank you, sir, for the inspiring words. And now, Dr. Sumit Chakravarti from ESIC Hospitals, Faridabad.
Well, good morning, all the dignitaries on the dais and all the eminent faculties and students who have come from all the Delhi NCR region to be part of this well thought plan of expanding the mantra of going from less invasive to robotic. So I congratulate the whole team of Meringo Asia, SS Mantra, and all the collaborating hospitals to have a very well organized conference. And I hope that the whole Delhi NCR region will get the benefit out of it. Thank you.
Thank you so much, sir. And now one more dignitary, Mr. Abhishek Jorwal, who is the DIG and DCP from Faridabad. If you could please share some words.
I congratulate Dr. Ritesh Monga and Hemant Tatri and Dr. Rajiv Singhal who are organizing this conference. And it is just for me, it is that first time, just a new thing for me to get, I got introduced from that. Now medical science has progressed so much that doctors are doing surgeries at far off places. And apart from doing surgeries from far off places, as Dr. Ritesh Monga, when he came to invite me, he told me that the robots can do surgery more efficiently because the movements which they do, which doctors can't do, and the cut which they make during surgery, that are also small and patient recover very soon. So I congratulate all of them by doing all these innovative surgeries, and all the best to the team of doctors. Thank you.
Thank you, sir. And now to honor the distinguished experts who have joined us today and contributed to this remarkable gathering, may I please request our Dr. Colonel Navneet Chabra, our respected medical director, to kindly felicitate our esteemed guests. May I also request Dr. Ritesh to join him. Thank you, everyone. Can I have a please round of applause for all the dignitaries? And thank you, sir.
Doctor, I'll just want all dignitaries to wait for a minute. Let's have a national anthem and then, yeah. Dr. Vishwa, let's have one national anthem and then we'll disperse, please. Yeah, let's be in front. Dr. Lalit.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
बस स्टार्ट कर रहे हैं. The lunch is open for the want of time. It will be a working lunch, and we are starting the academic session as Dr. Lalit has a flight to catch. So, Dr. Lalit, you start your presentation because you have a flight to catch, and you can moderate they can moderate from there only till we change over the chairs.
Yeah, since Dr. Lalit has a flight to catch. So the cardiac session was interrupted because of the inaugural function. So let me introduce my esteemed colleague here. We all heard Dr. Sudhir Srivastava talk about what all is possible. Now the gentleman standing next to me is one of the leaders in robotic cardiac surgery in the country. I keep following him and his messages in the national group. So Dr. Lalit Malik has come all the way from Jaipur, and he's heading the robotic cardiac surgery team in Manipal hospitals. And now he's going to show us what all is possible in robotic surgery with the help, in cardiac surgery with the help of a robo. Dr. Malik.
Thank you so much, sir. First of all, I would like to thank Dr. Ritesh and all organizing secretary give me this opportunity. And today my talk is my experience about 100 plus robotic cases, cardiac cases with mantra system. So to execute successive robotic program, we need actual structured training program. So we have to go through a continuous learning program through like initially open surgery, then go for MICS surgery, then to robotic surgery. And definitely you need a mentor. In my case, I am lucky I have a Dr. Sudhir sir. He teach me lots, and another thing is the patient selection and the teamwork. Teamwork is very, very important in robotic surgery. So in your left, Dr. Y.K. Misra sir, he teach me about everything about MICS surgery in my training time, and he gave me idea about robotic surgery 2 years back. And last in 2024 December, I met Dr. Sudhir Srivastava sir, and he gave me all tips about from basic to advanced, from ASD to TCAB. And he teach me come to Jaipur and sometime by telesurgery and teleproctoring to me for simple or sometime in difficult cases. And then after a few cases, I transmission my knowledge to some center in India, like in Hyderabad, proctoring some robotic cases there. And we did last month telesurgery in Bangalore from the SSI Mantra office, and we did 3 cases, 2 Lima down and 1 ASD by this Mantra Asan, and teleproctoring Chennai this by this VR system. So this is my journey. I have a 16-year experience through this sternotomy case, and then 8 year through MICS. So it's very easy to convert MICS or endoscopic surgeon to robotic surgery. And we did 100 plus cardiac cases that include ASD, pericard window, myxoma, PAPVC, MVR repair, and AVR and TCAB. So on your left, this is our first case, and on your right, this is when we completed our 100 cases. So if you, on your left side, this is MICS ASD cases, and then this is ASD, this is peroneal incision. But here we have to retract, so there is a scar and sometimes lots of pain to the patient. On your right side, this is a robotic ASD. So there were 8 mm port incision, and there was no pain at all. So this is the advantage of robotic surgery over MICS or endoscopic surgery. So this is a small video after peripheral cannulation. After peripheral cannulation, we go on pump, and after this pericardotomy, same stage suture like endoscopic ASD, and we loop SVC, IVC in PVC cases, and okay. So this is next is MVR. This is on your left. This is a transaxillary MVR, and on your right, this is a robotic mitral valve replacement. And this is a patient of MR patient, and the same peripheral cannulation. Sorry. Basically, exposure through the robotic is very nice, and so each and every corner of the mitral valve, and we did. One minute. This is a mitral valve repair, and in here, in this case, after a peripheral cannulation, cardioplasia, we can do this cardioplasia, and this chit-put clamp, we open LA, and here the technique, we took some stage suture to expose the this mitral valve. Oh, this is replacement, yeah. And we measure the size, and by this suture is same like a endoscopic mitral valve replacement, and we put any valve, tissue valve or mechanical valve. It's very easy, and this is mitral valve repair. This is a P2 prolapse case, and it with this this ring, the new ring is 3D memo ring. It's very easy to do this repair, and this is 3D memo ring, and this is P2 prolapse. So you don't have to measure the Cody length, and it's very easy to put this ring, and we fix here the P2 part, and it's very easy to do this through robotic system mitral valve repair. This is aortic valve. We did 2 aortic valve cases. So aortic valve is little tricky, because in severe AS case it's little difficult to remove all calcium. But the trick is you use cautery more and cut. Then you remove slowly all this calcium, and after removing this calcium, exposure was very nice, and the suture technique is same, and the this incision is from the same incision, working port is same like a mitral valve. And this is T-cap, and this is the one thing we have in mantra system, because in Da Vinci we don't have a stabilizer, and in this T-cap procedure we normally harvest pedicle lima, because we have to stabilize, we have to fix some point, and this is a stabilizer in mantra system, and this is LED, and is by this stabilizer is very easy to do anastomosis, and for anastomosis we use 7O Pranova suture, and sometime we make this 7O big size suture to make 10 centimeter suture. The movement was very smooth. This is black diamond in both hand, and anastomosis initially it will take time, nearly 3 to 4 hours, but after some time time will reduce. So we did near about 10 TCAB, and we did 2 AVR and lots of MVR, ASD in my center. And so in conclusion, robotic surgery is not difficult for MICS or endoscopic surgeon, and always start with the simple case, choose the best case initially, and proper planning, evaluation of the patient is very, very important in initial time. And that I learn from my Dr. Srivastav sir, never prioritize access over outcome. Thank you so much. Yeah.
That is a lot of labor, a lot of precision. It has its learning curve, but one can get there with persistence. That is the message, and anything is possible. So, any questions from the house? Dr. Lalit will be happy to take that.
Hello.
Surgery, and you would prefer to do the patient as MICS or an open case?
After a basic investigation for every patient, we go for CT scan to check everything. And initial, we select for initial ASD for straightforward for every case. And mitral, initially we choose moderate MR with MS case, not purely MS case, but after some mitral valve, then we go for this mitral any MS patient. AVR we choose more AR patient, and in CBG we choose less calcification or straightforward lima to LED case in initial cases, and we are more choose cylindrical patient initially, not small or small female patient in initial cases. You choose good patient initially, depend upon CT finding, X-ray, and basic investigation.
Thank you.
I'm Dr. Dijna Goyal. I'm intervention cardiologist.
Yes, sir.
So I just want to ask how much hybrid procedures you are doing, and if you are planning for hybrid procedure, robotic surgery plus angioplasty, how many days you wait after robotic surgery to do angioplasty in these patients?
Yeah, basically most of the patient they are going after 3 months they are going for angioplasty. Sometime on right side graft, sometime OM or right side graft. So basic, this is the actually future of coronary surgery. I think maybe cardiac surgeon will do 1 or 2 graft, and the rest of the graft right side, or maybe OM3 by cardiologist.
So we routinely do hybrid procedures. We have done close to 80 procedures, 80 hybrid revascularization surgery between Delhi and Chennai. So we do angioplasties within 48 hours. As soon as the risk of bleeding is over, in the same admission, we'll put a stent to RCA or OM wherever is required. In the same hospital stay, yes. We don't discharge the patient with the incomplete revascularization.
We also did, but in only in that case, the stenosis, tight stenosis in that case. Otherwise, we wait for at least 1 month.
Any further questions or inputs? So I think a very important takeaway which Dr. Lalit mentioned is patient, and Dr. Varun also brought out, is patient selection. They have been selecting their patients, they have been choosing them, especially in the early part of the program. So like I could make out, it was mainly regurgitant lesions, so that you don't have problems in cutting the valve. And you are not doing right side because you're leaving it for hybrid, you're probably making a Y and doing LAD and OM. Those are technical issues, but the message is that you have to select your patient. That's the point I wanted to drive home. Thank you so much, Dr. Lalit. Really appreciate you coming all the way. Thank you. Can I request you to accept a memento from the organizer? And all the moderators, sir, can I request you to join here, please?
Thank you very much, Dr. Lalit. So now we are moving to the urology session. Me and Dr. Lokendra, we are convening the same. As we are running late, so I would first like Dr. Lokendra to come and to call the moderators. And there is a small change that the first session is the tele session by Dr. Vaddi, as he is ready in Hyderabad for his talk. So his will be the first session, and then the next of the moments talks will be accordingly.
Good afternoon. Before starting this urology session, I request chairpersons of this session, please come to the stage. Dr. Sanjay Agrawal sir, Dr. Alok Jha sir, Dr. Rajiv Sethia sir, and Dr. Anup Gulati sir. Next session would be live from Preeti Hospital, Hyderabad by Dr. Chandramohan Vaddi. Dr. Chandramohan Vaddi is a highly respected urologist and robotic surgeon. He is the chairman of Preeti Group of Hospitals, Hyderabad. Sir, welcome.
Hello.
Yes, sir. Good
Am I
afternoon.
audible?
Yes, sir. You are audible.
Yeah.
Can I start?
Yes, sir.
Yeah. Very good afternoon, everybody. First of all, I congratulate the organizing team of Robo Fest, Dr. Ritesh, Dr. Hemant, for this unique program on Sunday. And also thank you for giving the opportunity to present online, not to travel such a long distance, and saved my Sunday. And respected speakers, Dr. Sanjay, Dr. Alok, Dr. Rajiv, and Dr. Anup Gulati, with your permission, I thank you once again and I will share my screen. Time is short, already late, so I will stick to my time. Dear friends, surgeons particularly, I have been asked to talk about the initial experience of miniaturized robotic platforms in India. So, basically, this is my CV already mentioned. Laparoscopic surgery is getting replaced by robotic technology even for simple surgeries like gallbladder surgery, nephrectomy, and hernia. Constant observation in endourology and robotics is decreasing the size of the instrument. In urology, we see flexible scope has gone down to 6.3 French, nephroscope has gone to 7.5 French, and in all these lead to less pain, early recovery, daycare possible. This slide I might have repeatedly told it is boring. Same, scar is less. In children particularly, I will mention that. So early robotic systems used large ports. Standard robotic instruments became 8 mm. Newer systems exploring 5 mm and even 3 mm ports. So normally camera port will be 10 to 12 mm. Robotic working instrument will be 8 mm. Assistant ports will be 5 to 12 mm. Obviously, when you reduce the size, you have to maintain instrument strength, maintain articulation and dexterity, and reduce surgical trauma. Otherwise, it will break. There is no use. So initially, no conflicts of interest. It's the history. Intuitive surgical, most widely used platform in the world. In India now, SSI Mantra is picking up like anything with more than 150 already established systems. Intuitive uses 8 mm, camera port 8 to 12 mm. So DaVinci SS platform, single port robotic system uses 25 mm. Not much appreciated this. Surgery is complicated, but some people promoting it in Western countries. SSA Mantra has innovations. Definitely they are in India, they got the permissions. Indian surgeons are willing to do the surgeries with their innovations. Indian engineers are in regular touch with me. Indigenous robotic system, introduced miniaturized 5 mm robotic instruments. Definitely I am doing more pediatric robotic surgery like ureteric reimplantation, pyeloplasty, detrusorrhaphy. These are my 3 commonly done surgeries. So definitely what happens in children, if you put 12 mm, at the end of the thing when you remove it, because of the lack of the subcutaneous fat, intestine props out. You have to put 1 or 2 stitches. In 5 mm in a thick rectus muscle, it is not required. It is as simple as it in the entire talk. But I came to know when I was searching ChatGPT and Gemini that is it me the first person who is reporting? Partly yes, partly no, because I came to know that CMS versus is using only 5 mm instruments, truly disadvantaged to them because myomectomy, hernia surgeries, wherever the rectus sheath has to be held, they are weak. In children pediatric, the tissues are small, you can use it. Medtronic Hugo RAS system is using 8 mm and 11 to 12 mm ports. This is truth. And Sahan's robotic system also using 5 mm and 3 mm sometimes they tried but not heard of. So in comparison, 12 mm is little bigger, 8 mm is acceptable, 5 mm is good, 3 mm is very small. This is a picture again, there is no new thing. So engineering challenges are you have to use a slightly stronger material, precision engineering is required, reliable articulation and durability is required. The surgeries you can do whatever you want with the 5 mm also, you can do with the 8 mm also. But 8 mm has strength, 5 mm has less strength. I already mentioned pediatric robotic surgery, only 3 surgeries I have done. In future 3 mm robotic instruments may come. So to conclude, miniaturization is shaping the future of robotic surgery. Multiple developing, one company develops, other company will get competitiveness, and they develop this small instrument. These are the SSA mantra system, as you all know. Now I have two SSA mantra system, SSA mantra 2 and SSA mantra 3, and both are functional. This is the standard operation theater room. This is, everybody knows, open console system. This is the foot control, and these foot controls have improved over a period of time. As you mentioned, not only the arms, these modular robotic carts are decreased in size. I am not going into the height and breadth. Basically, these small ones are very useful for accommodating to a small abdomen of 12 centimeters length in vertical direction. So they made a huge difference now, and they are selling only mantra 3 now. That is a good thing. The monitors also in future may disappear because my talk is miniaturization. I have used these goggles which are difficult to initially adapt. After 3 cases I was comfortable. You can move the neck here and there, and that is the future. But some people argue that the screen gives much better comfort to the surgeon eyes than the goggles. So these systems definitely will become smaller in size. Way back 1 GB pen drive used to come in a big truck. Now you imagine we are carrying 40 GB in our purse. That will happen 100%. That miniaturization is happening. These are the 3 instruments I have used. They have not yet given me the scissors honestly. Bipolar forceps is very good. Hook is good but not stable. Micro monopolar cautery is very good spatula but not for the fine dissection. And these needle driver is very good, as same as 8 mm port. Micro grasping forceps is definitely weak and it needs to be strengthened. They purposefully say that for pediatric and small tissues they are making it. If you use the same thing like in CMR for a fibroid or anything, it will break. So this is the size when you compare by the side. The tip of the instrument also you can easily identify. The length is small, the breadth is small, everything is small. There is no doubt about it. These are the tips. I have taken photos at the end. See, you can closely see way smaller, no doubt about it. And these are the 5 mm projects. Now they came out with Caesar. A month back this development has happened that the engineers have come. While I am playing the 3 videos, which is only 2-3 minutes, I will close my talk because there is nothing new here. It is already done. First, my aim is that what were we doing in laparoscopy? This is a pyeloplasty. We use 10 mm, 5 mm, 5 mm. But in this I fast forward because I am just showing what is done routinely by pediatric surgeons. There is nothing like one person is doing well or one person is not doing well, one has to do it. Pediatric surgeons also do lot of laparoscopy. They use 5 mm and 3 mm ports also. Here I am regularly using 10 mm camera because I use 10 mm. I have 5 mm also, but our mindset is slightly different. So if you see here, this 10 mm port normal camera we can use, but this is big, I must say. This is very big for 1 or 2 years babies. At the end you will see a big hole. Now coming to the once a camera is inserted, and on either side we put 5 mm ports which are very comfortable. This is laparoscopy I am sharing. I am comparing. See, 2 instruments are put, 5 mm port is kept. They are all disposable ports, and this is the picture. You proceed. Then what is next in robotics? This is a 6-year male child. The SSA Mantra engineers have come to me. They told that you pose the case. We wanted to do it. That is the way to do it. So this is my initial video. This video only I will play. After that I will not play. This I enthusiastically have ports with instruments of 5 mm caliber. Previously we used to use 9 mm ports and the 9 mm caliber instruments. That was little more for a child. In laparoscopy we use either 5 or 3 mm. Now in robotic also 5 mm port they are giving. The case we are demonstrating today is the baby. We are planning for pyeloplasty. A 6 years baby with a small abdomen. We wanted to show the difference between the instrument size. If you compare like this, See, this is heavy instruments of 9 mm. This is very small. They made 2-3 instruments like Maryland, bipolar, the hook and bipolar grasper and normal grasper. And these are the ports. Normally, we use this port and they are providing this type of port now. Definitely, it is very small. We were not very happy with this type of large port in small children. With this introduction, we will start with this. So these are the port position with 5 mm. Now I am using the hook. And these are the instruments I am using 5 mm. You will not find any difference except that the grip is less. So naturally the tissues are small. You should not expect a very good grip. So I tried two things for the grip. One is the one which is shown here is Maryland. Another one is the bipolar grasper. Maryland one was very good, but they say that it has serrations and it may cause tissue damage. See, the needle holder you observe, it is a very small needle holder. The suture is 5 0 Vicryl, and absolutely I did not have any problem. You also will not have any problem. In sooner, I don't know, I feel that if you are dealing with tissues like partial nephrectomy or urethrovesical anastomosis, they are very small and they go deep into the peritoneal cavity. Their tip is small, length is same. See, this is all done entire thing with 5 mm as first case. Everything recorded and I have edited. It came out nicely. No doubt it came out nicely. That means immediately I have taken, see these instruments, we celebrated every small thing we should be celebrating. Next I have gone for 12 years baby. There is nothing new. One minute I will finish the talk. 12 years female, left loin pain, on and off, CTKUB, dilated renal pelvis. So we have gone inside. This is a good case. Why? Because see, it was, I expected very large pelvis. It was not there. Then I have given Lasix. Then it was little inflamed. See how my hook has done. But the problem is hook is not very strengthy in SSA mantra. We should not say everything best. Hook is a poor instrument. See the crossing vessels. A big artery and vein crossing was there. With hook only, I first dissected pelvis. My basic principle is pelvis. Don't see the ureter. Straight away cut the pelvis and bring the ureter up. There is no need to dissect the crossing vessels because they can be pulled afterwards. See, with hook when you do like this, it is broken. So hook is limited for limited tissues like, see, with hook only I am cutting clearly. With low current, cutting current, stretch. When you stretch it, the coagulation effect will go off so that you need not worry about the suturing. So now I have removed the ureter from below in 1 minute, and now I am holding with 2 instruments. After that spatulation done, and the rest of the thing is same. You can see 2 instruments are very small. Another thing is this was we were doing on 4th Saturday workshop. People wanted laparoscopy. After doing the primary part, I used laparoscopy for suturing. There is no gas leak. That is the main. So anytime 9 mm ports, converting into the laparoscopy is very difficult. You have to either put puts or gauge piece for gas leak, or you have to use the reducer. Now Indian companies are producing reducers for the mantra also. But once you keep the reducer, you feel something load is added to your instrument. You won't be so smooth in handling. But here, you watch this. This is the last bite. Apex. After that redundant pelvis, they told, sir, we wanted to see the laparoscopy. See, now I have taken laparoscopy. These are laparoscopic instrument. Same ports, camera is same mantra camera, the Olympus camera. You can use for normal laparoscopy also. That also will save nearly 60-70 lakhs if you want to do laparoscopy for low cost. And these ports, whatever mantra is using, nearly 3 years, the port is not damaged. So very useful this point. Coming to the last case, 9 years male, just we have done ureteric reimplantation with tapering, grade 5 reflex. This is technically demanding. You can't do very fast and screw up the patient. So this is the hook again. See over the ureter in the pelvis. In the pelvis, SSA mantra surgery is so easy, I must tell, because I am still using the old camera, that is 0 degree. But even these instruments are used with 20 old this one. I haven't yet used in the 30, but that should be more easy. See, you are holding and there are no grip there are no marks on the ureter. You cannot hold the ureter left and right with this instrument. See, UVJ I am reaching without any bleeding. See, I am holding it. Now, entire UVJ is identified. VAS is dissected with 5 mm instruments. VAS is so nicely dissected. Now we are taking the VAS ureter. Now I have taken stay stitch with instrument, and by 20 vicryl you cannot put it in the through the port. So I have changed it to 9 mm. You can observe the long length of the needle holder. Now the right side is 9 mm, left side is 5 mm. Let it be truthful. According to the case, you have to adjust. This is a scissor, and you cut vertically down. Technique part I am not discussing today. I am just saying that left hand 3 mm has nicely helped me to finish the case of an advanced pediatric ureteric tapering. See, this took around 2.5 hours time. So now I finished my time of 8 minutes. So this is the last case. Then I drop the bladder and I re-implant with a tunnel. Nice tunnel has come with this instrument. See the bladder, such a big bladder, and you can mobilize. See, so as stitch is taken, and then I will fast forward a little bit. This is the tunnel. You can see how nicely the scissors is cutting with 5 mm. The tunnel is made, then anastomosis is made, and then you see nice 5:1 tunnel. So these are the 3 cases we have done with the 3-0. They are still in the evolution of the Caesar. They are in still evolution of the other instrument. They told that within 1 month we can tell. So with this, I finished my 8 minutes of presentation. I thank you once again for giving this opportunity, and I am happy to take the questions. Thank you very much. I am not able to hear, sir. Is it possible I can hear?
Am I audible, sir?
Yes, sir. Yes, sir.
Sir, it was a very nice presentation. Everybody enjoyed it. And very nicely you explained the advantage of smaller instrument in pediatric population.
Yes.
Sir, this is Dr. Rajiv Setia here. We are using CMR system regularly for our pediatric cases. So I have few queries, sir. In case of conversion from robotic to lab, how are you able to use the 8 mm port without reducer?
Yes, sir. I mentioned already, it is very difficult. Gas leaks. I will put one gauge piece, make a small hole through which I will put the gauge piece in the lumen of the 8 mm. That is the cheapest technique. Or else I will put a rubber cap. We will have in urology rubber caps. That is the second cheapest. Third thing is, I will put another 5 mm port by the side of 10 mm, which is invasive to the baby. I am telling you, this even if I don't use 5 mm instruments in SSI Mantra, I am very happy with the SSI Mantra 5 mm steel port, which can be used multiple times. Otherwise, 8 mm port laparoscopy karna is difficult, sir. It's difficult. Gas leaks, and in children, small gas leak, it collapses and you cannot do the surgery well. I put another port because in Mantra or any robotic, ports will be horizontal. I will go little forward, making a baseball concept of laparoscopy, and even sometimes 3 mm ports. I have Caesar pyeloplasty. I use 3 mm. After that, suturing 3 mm needle holder I can use, so that I can convince. This is the biggest challenge between the laparoscopic surgeon and robotic in pediatric. The day 5 mm camera comes, 5 mm port comes, it's done. It will come. Sooner it will come.
Yeah, we are able to do the same thing with the 5 mm port because we are using the 5 mm port in all the cases. Second question is, sir, these 8 mm ports are metallic ports, and in pediatric patient, the abdominal wall is quite thin. So there is difficulty in holding the 8 mm metallic port because it can slip easily while taking out the movements. So do you take any extra measures? Because I have seen you have taken some extra measure to hold the port in place.
Yes, yes.
So what is that?
Yes, yes. That's a very important question, sir. In laparoscopy, we use 2 things. One is not to go the port inside. One is not to come outside. Both are dangerous. So not to go inside, we put the gloves cap through the 5 mm. Not to go outside, we put a stitch. So a stitch will not allow it to come out. A rubber cap will not allow it to go in. Whereas in robotic, the major advantage is once you dock, there will not be any pressure at the entry point of the entry point of the robotic instrument, and there is a black mark. That's why in children, subcostal region we put the ports for ureteric reimplantation, whereas midline, sharp in the midline for pyeloplasty. We wanted to keep that 3 to 4 centimeters port black line inside. It will never come out, so we don't fix even. But when you are doubt, same thing you apply. One gloves, you cut the tip, wrap it and enter it so that it snugly fits. At the level of the skin, it won't allow to go in. Coming out is a problem. When you come out, you have to undock that arm and then reinsert. It takes time, it's frustrating. So not coming out is simply by putting a silk stitch and tie it so that it won't come out. This many pediatric surgeons does.
And how old the youngest pediatric patient in which you have done the robotic?
I have done 6 months baby, the youngest pyeloplasty with SSI Mantra Robo. But otherwise, laparoscopy, that's a different issue. 1 month also everybody does. But robotic 6 months, that is also main reason anesthetist says that avoid less than 5 to 6 kg babies. But there should not be any difference between robotic and laparoscopy. I'm just waiting for a case less than 3 months to do it. The point is, in robotic, minimum 8 centimeter gap should be there for pyeloplasty or ureteric reimplantation. So the smallest baby I have seen, the vertical length of the abdomen is approximately 15 centimeters. So you have to go port at the xiphisternum, and you have to port at the suprapubic region in the midline, and one at the umbilicus. You don't have choice. You don't have choice at all. That way, the small abdomen looks like adult, ultimately 8 to 10 centimeters, adult or children. If you don't have 8 to 10 centimeters, then it is a problem. Breadth of the abdomen is a problem. Extremely lateral you have to go. Extremely superior you have to go. Otherwise it will clash. Oh, that clashing is the main problem with CMR. That's why CMR has two problems. I was discussing with Srinivas Juluri 1 hour back. He used CMR and converted to Mantra. Pediatric surgeons also, why when I searched literature, no case report is reported with 5 mm. I am planning to report that, because in the literature CMR, because they have rules and regulations very strict in London, they have not permitted early in the pediatric cases to use 5 mm. But in adults they have not permitted with hernia also. This is not what unofficial information. Then they slowed down. Whereas in India, we have permission from the CDSCO. SSA Mantra is doing innovative trials on animal lab as well as this thing. For example, whatever cases I have done, they are incorporating and putting for the research work. 2 big engineers have come for that. So that looks logical. We are growing in that way in India.
Thank you, sir. Thank you.
Thank you, sir. Wonderful presentation.
Ritesh here, sir.
Thank you.
Thanks for being with us. Sir, before you leave us, I have 2 questions for you. So one is, sir, like this pediatric robot, because you are the only one who has the experience, can we use, because the length is the same as you showed us, so can we use the same for adults also, maybe for females who need better scars?
Very well. I am telling you, these 2 instruments I am waiting for radical prostatectomy. वो 15 दिन के बाद केस नहीं आया. Urethrovesical anastomosis I wanted to do with this 5 mm because they have used Chandramohan till they are getting damaged. So I am using them carefully. It is not damaged. 3 cases. So another 7 cases I will definitely use in children. But one thing is for sure, rectus sheath, large tissue for burning, you cannot do. Myomectomy you cannot do. Bladder holding is weak in adults. But urethrovesical anastomosis of prostate, we can do very well.
And sir, the last question before you leave, sir, whether spatulating the urethra, as you do a lot of reconstructives, is it difficult or easier than the standard robotic instrument, sir?
Easy because it goes easy. A small instrument enters into the ureteric lumen easy. No doubt it is easy. No doubt.
Thank you very much, sir, for your time, taking our time on Sunday afternoon, sir. Thank you very much.
Thank you very much.
It was a wonderful presentation by Dr. Vaddi. Now it is my great pleasure to invite Dr. Ritesh Monga on stage. Dr. Ritesh Monga is a fantastic robotic surgeon who has performed more than 100 advanced robotic urological surgeries with exceptional skills and dedication. I have had a privilege of working with him for past 7 years. Thank you, sir. Thank you for so supportive. And please welcome Dr. Ritesh Monga to the stage.
Thank you very much. Thank you, Dr. Kendra. I'll keep my presentation very short because it's a general, and then we have very nice faculties talking on different malignancies in urology. So I started my journey December 24 on the Mantra 3.0 first, and now we have the Mantra 3.0 Advanced, which has 0 and 30-degree lenses both. What all we can do, we all know we can do a radical prostatectomy, nephrectomies, partial nephrectomies, cystectomies, wheel surgeries, and all these surgeries. We all know these standard things. We all know that what precision the robot gives to us, a greater precision, better visualization, and ability to do surgery in limited spaces like prostate. Main advantage of robot is the patient. As long as I was doing all lap, I used to do lap radical prostates, lap radical cystectomy. I used to think, why I need the robot? But now I know it. The same robotic ports give lesser pain to the patient. There is definitely reduced blood loss. We are not even keeping blood now for prostates. Smaller scars and very good recovery. For the want of time, I would be almost rushing through. It was a big lower polar partial where the ureter was closed. So what this is one surgery where a robot has brought a big difference. Radical prostate and kidney tumors. Like we are able to save more renal units than we were doing with lap, as it was a large tumor. So we are including both artery and the vein. And not coming to upper polar partial, I'd like to go with this patient. This patient had a level 2 thrombus where IVC, the thrombus was reaching till the lower border of the liver. We have gone intrahepatic aortocable. We have clipped the right renal artery. Now we are dissecting the IVC. So now this precision, what robot gives us our laparoscopy, this is the IVC dissected. So IVC, we are taking control above and below the thrombus. We are going till the level of the thrombus, and we are taking a control above and below the thrombus. We are taking control on the opposite renal vein. And now you see that IVC is being dissected, and see how the thrombus is popping out. So it's not that these surgeries are not possible to be done laparoscopically, but by the comfort what robot gives us, especially in vision, in the perception of depth, and most importantly in suturing later on. Like then we have sutured the whole IVC, and now after the removal of the clamps, this is 1 or 2 sutures which we are taking here and there. So we have done almost close to, I think now 4 IVC level 1, level 2 thrombus, and none we had to convert. Radical prostate, we have Dr. Manav speaking over it. So radical cystectomies, which used to be so much blood has to be kept and everything. Now we can do these procedures with hardly any blood loss, and it makes a big recovery patient, and the early feeding can be there to the patient. For the want of time, I'm running it because we are already running very late. So I think I have to take the responsibility. So in prostates as well as in bladders, what is the most important? The length of the urethra which we get with the robot. In prostate also, I would say, though I have omitted it for the later presenter, the length of urethra which we get, usually I get at least a few millimeters, I would say half a centimeter more than what I used to get in laparoscopy, and which I think becomes one of the major determinants, though there are many, for the post-op continence, which is definitely got better than what we used to do lap. So these are certain things which have changed in my own view. So adrenal masses, they are one of the best to do. So In uro-oncology, robots have almost changed everything from the bigger epic scars. We are coming so less that the robot and the surgeon together, they are becoming good for the patient. Telesurgery, we have a talk by ma'am. This is recently we did a telesurgery from here where we had a surgeon from NHS, Dr. Charu sir from US, they were in the OT, and we did a long segment ureteric stricture pyloureterostomy from here to Kolkata. So thanks to Dr. Srinivas boss, and then he did a very good partial nephrectomy, maybe he would share. So thanks for the patient hearing, and we moved forward in the session, and we can take maybe any questions now or later. Thank you.
Wonderful presentation, Dr. Ritesh. I think there's a long list of the procedure which we can do with robot, but at least in the 4, outcome has been dramatically changed. That is radical prostate, radical cystectomy, partial and PUG obstruction pyeloplasty.
I will add one more to it. That is the inguinal lymph node dissection in CAPNS. So, because there used to be so ugly scars that also I think coming up of wheel has changed.
Wheel, robotic wheel, I think that is also coming up. But in these 4, it has become almost standard of care because outcome has been dramatically changed after the introduction of robot.
Definitely.
Wonderful.
May I please invite Dr. Srinivas sir to make his talk on robotic partial nephrectomies.
Please, sir, Dr. Srinivas, sir, please come to the stage. Dr. Srinivas Narayan is a highly respected urologist working as a director of urology and kidney transplant at Fortis Hospital, Kolkata. Please welcome Dr. Srinivas.
Thank you, and very good afternoon to everybody. I must thank at the outset to Ritesh Monga for inviting me for this talk. And I was given a topic to talk about saving kidney in kidney cancer. Kidney cancer, as we know, it's almost like 2 to 3%, but there has been steady rise in incidence among people in their 20s, 30s and 40s. And our own Indian registry shows there is 15 to 20% rise in kidney cancer in patients under 50 years of age, thanks to routine investigations. Mostly it is silent, and few patients present with hematuria. There are no definite risk factor, but if you are a guy more than 55 years of age, if you smoke, overweight, the chances increases. And the routine investigation like ultrasonography and CCT, QB is enough to diagnose the cases. We will be discussing about the surgical treatment. There are 2 options in front of us. One is partial nephrectomy and radical nephrectomy. And the question arises why we should doing partial nephrectomy when other kidney is good enough and healthy. Because of the fact this chronic kidney disease is the important consideration in how we manage renal carcinoma. As you know, renal function is quite important, and CKD is actually much more prevalent than what we think. And it is a baseline GFR that is associated with long-term survival. And standard surgical treatment like radical nephrectomy increases the risk of developing CKD. And as we know, the stage 3 CKD is associated with 40% increase in cardiac event and 20% increase in mortality. So saving kidney function is more likely to impact survival apart from cancer control. This is a wonderful article from American Journal of Nephrology, whereby they studied incidence of chronic kidney disease following radical or partial nephrectomy. After partial nephrectomy, the risk of stage 4 CKD goes down by 66%, resulting in 45% decrease in mortality. And if you compare the CKD after partial nephrectomy versus radical nephrectomy, the after partial nephrectomy is just 3.7% as compared to 20% after radical nephrectomy. Hence the motto is, you should cure the cancer, but at the time, save as much kidney as possible. What is the goal of partial nephrectomy? The goal of partial nephrectomy to have an ideal surgical outcome, that is achieving a partial nephrectomy trifecta. That includes negative surgical margin, warm ischemia time less than 25 minutes, and there should be no major complication. And if you are able to achieve, you can have a good cancer control plus good amount of residual kidney that is saved. All guidelines say that you should prioritize partial nephrectomy as and where it is possible to achieve partial nephrectomy trifecta. Size is not a criterion nowadays. So robotic partial nephrectomy has come in a big way, which helps in saving kidney.
There are multiple advantages which has been discussed in detail by Ritesh also and previous. So can we say that robotic partial nephrectomy is a new gold standard in treatment of small renal masses? It is there. The first robotic partial nephrectomy was done by Getman et al. In 2005, and thereafter it has revolutionized the way we do urological surgery, and almost all guidelines says that we should be doing partial nephrectomy in all T1 cases as far as possible. Laparoscopy has been there for last three decades, but to do a laparoscopic partial nephrectomy, it requires a great steep learning curve. It is very difficult to master the technique. And this technical limitation of laparoscopic partial nephrectomy has made trifecta attainable for only highly experienced laparoscopic surgeon. Here comes the robotic partial nephrectomy. It has not only shortened the learning curve, it has facilitated greater uptake of the partial nephrectomy in otherwise complex renal case which traditionally underwent radical nephrectomy. This robotic partial nephrectomy has made robotic surgeon bigger and bolder. Now more and more robotic surgeons are taking T2 and T3 lesions, and this was further enhanced by addition of this SD robotic ultrasound capability, 3D imaging reconstruction, and vascular and margin assessment with ICG using Firefly. This is one example how the ICG helps. So after giving 1 milligram of this ICG, we have seen there is 86 to 92% concurrence between the tumor appearance during the intraoperative and final histology. So it helps you to marginalize the tumor accurately. Second, the robotic surgeon has become even more bolder. They are now doing robotic surgery sutureless, where the tumor bed was generally hemostasis was achieved using monopolar and bipolar, and it was supplemented by hemostatic agent. Most of the people are now using Veristat to control the bleeding without putting any suture. This is a wonderful article that came in World Journal of Surgery in 2023, where they compared the oncological outcome and complication after partial and radical nephrectomy in complex renal masses which are larger tumors, T3 tumors. There they have seen the overall survival and 5-year cancer-free survival was almost equal in both radical nephrectomy as well as robotic partial nephrectomy. Hence confirming that this partial nephrectomy trifecta is feasible with this robotic partial nephrectomy even for this advanced T3 tumor. This is one of the video which I wanted to share. This was a 28-year-old first year MS resident came to me with incidentally detected left renal SOL, which was a type 3 cyst, and his only request was, sir, please don't do radical nephrectomy, please anyhow do partial nephrectomy. As you can see the complex tumor, this was mid-polar posterior hilar. This is a small video I am showing. Yeah. After taking vascular control, we first, since it was a posterior hilar, we reflected the kidney as posteriorly as possible. The entire kidney was flipped medially, and thereafter, after flipping, we demarcated the tumor. The tumor was 50% exophytic, so it was not a very difficult case to diagnose where this tumor was. And after once we have demarcated it, we tried this ICG. And you can see once we have given the ICG, after a few seconds, within a minute sort of thing, you can see it is clearly demarcating. The normal parenchyma is getting colored, and the tumor is not coloring, it is blanching. And that has given us an idea. We marked it. I couldn't show the posterior one because it was very important for us to mark on the posterior side, which was shadowing the hilum. Thereafter, the only mistake which I did in this case, since it was a hilar tumor, I should have clamped the vein also, but I went ahead. Initially, there was not much of bleeding, but once I started dissecting near the hilum, the small venous bleeder started coming out. Then there was a surprise also. We thought we are dealing with single artery only, but at the last part, when I was taking it out, I could find there was an artery, additional artery, which was not there in the CT angio also, and we couldn't find one. It started bleeding. That's not a trouble, since suture was inside. We do standard two-layer suturing The first is the inner layer that control the bleeding. And suturing, as everybody is told, suturing is the best part of robotic surgery. The ease with which you can suture the things, it's remarkable. So first we did the inner layer, and thereafter the outer layer with an Hemolock application so as to compress it. So this, despite not knowing that there is a second artery and there was a bleeding, since the suturing is quite easy, we were able to come out of that situation with the last suture being placed. After that, it was artery was unclamped and there was no bleeding after. Yeah, we place an surgicel there, and thereafter, since the kidney was reflected, we again repositioned it. And back the specimen. So total duration was, in this case, was 105 minutes with a clamp time of 20 minutes. Patient was discharged on post of day 2, and the histopathology came out to be clear cell carcinoma grade 2, margins were negative. And this is a case which we did only 1 week back, and it was a robotic telesurgery done from Calcutta to a patient, Ritesh patient in Faridabad. This is a 70-year-old man, and you can see the size of tumor. This is a big 9 into 8 centimeter heterogeneously enhancing mid and lower polar SOL, which was predominantly exophatic. Initially, I agreed just because of two facts. One, the tumor was exophatic. Second, I was having much faith on Ritesh and his team to help him out if there is any trouble. You see the humongous size of the tumor. And while I was doing it telerobotically from Calcutta, I never felt that the patient was not there in my OT. So first we dissected the hilum. The only problem with this case was, since it was a big case and the tumor was looking at you, we were not able to put the fourth port, but still because of the very good assistant we were having on that very side, we were able to tackle the thing. This is a tumor, how it looks. We reflected it posteriorly so that we can take full control of the tumor on all sides. Then the upper margin was defined so that we can have a normal renal parenchyma above the tumor. The operation went smoothly. I was astonished to see that there was no lag anywhere. That is the lower margin which is being enucleated. It was a predominantly 80% exophatic tumor, but the size itself was humongous. Thereafter, we clamped the artery and the vein both. Since we are working with the both tumor, we are working remotely also. We don't want any bleeding to happen. And the difficult most part was to handle the tumor while it was being cut. Just because there is no retraction and this humongous size of the tumor never allowed to do a good retraction, but with help of brilliant assistant which we are having at the time, we were able to take it out. And I must thank Dr. Ritesh to providing me a new Caesar at this very time, because most of the time, if the Caesar is old, it won't cut so easily. So we went ahead and it took us time, but we were able to do it. Since we have clamped both artery and vein, so it was almost bloodless. This is the last part that is being cut. Thereafter, we clamped with the normal saline, there was no bleeding, and we started the same way of rhinography using 2 layers. First the inner layer followed by the outer layer. And we usually use this V-lock 30 centimeter, which gives enough length to do the both layers in one go without using the second one. The best part of this thing is the suturing. As I told you, you can go at any angle from any place and you can complete the procedure. The laparoscopy, the suturing requires a training sort of thing, experience also. But robotic suturing is quite easy. Anybody can master. It doesn't take much time before you start doing it very well in every case. This is the last bite that is coming on. So thereafter we remove this, both the arterial and venous clamp. There was absolutely no bleeding. We put a surgery cell over it and we covered with the zero TAS. The next difficult part was to put the entire tumor into a bag, but to my utter surprise, the assistant was so smart that they put it in no time. So this was the final picture. So it was very pleasing surgery for me because it was first intra-hospital telex robotic surgery done from Calcutta on a patient in Faridabad. Total duration of the surgery was 110 minutes with a clamp time of only 22 minutes. And I was told as the patient was discharged on day 3. So at the end, take-home message is saving kidney function is more likely to impact survival in patient with kidney cancer apart from cancer control. Robotic partial nephrectomy is easier than partial nephrectomy to learn and master. Robotic partial nephrectomy is now gold standard treatment for small renal masses and it has increased the kidney saving in renal cell carcinoma. Thank you.
Wonderful presentation, sir. One quick question. Yeah. So do you use laparoscopic ultrasound intraoperatively to decide the incision or the depth of the incision?
See, there, if the tumor is exophytic, ICG will help you out. If the tumor is endophytic, there you require it. We are having laparoscopic ultrasound at one center, but not at the center where mantra is there.
So do you think as in case of renal cell cancer, kidney cancer, the partial nephrectomy has become now almost standard of care? Do you think similarly partial prostatectomy will become standard of care for prostate cancer in the future?
They have come up with very different names, radius sparing, some are bladder neck sparing, some are doing this seminal vesicle sparing surgeries, but it hasn't stood the test of oncological cancer.
Histology is almost same, in both cases there are adenocarcinoma. So I think in future you might see.
See, RCC we are dealing with partial nephrectomy more nowadays because most are detected incidentally during routine investigation. This guy is 28-year-old. He underwent an ultrasonography, found that he was having cancer. And this has become a routine because most of the companies are now forcing employees to undergo this annual health checkup and they are coming with 2 or 3 centimeter tumor. And nobody wants an active surveillance at 20 years of age. They want to, sir, remove it as quickly as possible.
How far are we away from self-operating robots?
See, this can be a, we never thought that a robot will be doing surgery in our MBBS days sort of thing, but this has become a reality sort of thing. AI is coming in a big way, but at least I understand that in my lifetime I won't see that scenario where I am nowhere in scene and robot is doing surgery.
Can I give a comment on it?
Yeah. Sir. Yeah.
I think the self-assembly, so we are already working on
excellent presentation, Dr. Srinivasan.
Thank you, sir.
I'm surprised that how largest tumor you have excised so far did the partial nephrectomy and could still save some functioning kidney, because they are now talking saving not kidney but saving the nephrons.
Yes, sir.
So what is your experience about it?
See, this was the, as far as the partial nephrectomy goes, this was the largest partial nephrectomy I did because 8 centimeters is not a usual case to get. But this case, the uniqueness was 70% of kidney was still saved because it was a predominantly exophytic tumor with only 2 centimeters being endophytic. So we were able to remove and we were able to save 70% of the kidney. The size is not a criteria, nowhere in the recommendation they say that this is the size beyond which you cannot do partial nephrectomy. It's whether you are able to achieve this partial nephrectomy trifecta. In any case, if you are able to achieve good cancer control, negative margin, less than 25 minute of warm ischemia, you can do it without increasing complication.
Thank you,
Thank you, sir.
Srinivas, sir.
Thank you.
Now I request Srinivas, sir, and the chairpersons of this session kindly come towards the right side of the stage to collect the memento, please. वो है सर अभी नेक्स्ट वाला भाई Now I request next set of chairpersons to honor the stage. I request Dr. Rajneesh Gupta, Dr. Kinjal Banerjee, Dr. Mridul Garg, Dr. Manish Chaudhary come to the stage. Dr. Manish Chaudhary, sir. I also request Dr. Amitabh Singh to come to the stage, please. Please, sir. Next, there will be a panel discussion about what is the management of benign prostate larger than 150 cc. In that, HOLAP is a very commonly used technique, but robotic simple prostatectomy also gaining popularity. So, I would like to invite Dr. Sandeep Gupta to the stage. Dr. Sandeep Gupta is a well-known urologist and kidney transplant surgeon working at Fortis Hospital, Jaipur. Please welcome Dr. Sandeep Gupta.
Good afternoon, everyone. I thank Dr. Ritesh Munga for providing me this opportunity to enter into a debate or fight with one of my very dear friend, Dr. Tanuj Pal Bhatia. Actually, Dr. Ritesh called me and said that there is a guy who keeps blabbering about lasers, that he can use laser in a 100-gram prostate, 1,000-gram prostate, even 10,000 grams of prostate. So I said, who's this guy? Let's tackle him in a US-Israel way. So I asked him, who's the guy? He said, it's Dr. Tanuj Pal Bhatia. Then I said, no, yaar, we have to tackle him gently and let's do it in a debate rather than a fight. So a disclaimer is only that whatever I say, मैं जो कहूँगा सच कहूँगा, most of it is evidence-based or logically, and I'll be speaking in favor of robotic-assisted simple prostatectomies. So traditionally speaking, there are multiple treatment options for benign prostatic enlargement. TURP, the old and the gold standard. HOLAP, which is the proposed gold standard. Then there are newer kits on the block, MIST, minimal invasive surgical treatment, Urolift, RESM, iTind, etc. Then there is further miniaturization of the instrument leading to a new terminology, MILAP, which is HOLAP with a smaller instruments. Then comes robot-assisted simple prostatectomy, and finally open simple prostatectomy, Freyers or Mellens. So when we look at the history of both these procedures, HOLAP was first described by Dr. Peter Gilling in 1998, and robotic-assisted simple prostatectomy by Dr. Renny Sotelo in 2008. But I think the debates end at this slide only, before it has even started. Both the surgeons are happy getting their picture clicked with robot, not with the laser. But still, for the sake of presentation, I'll give few literature evidences. So what do the guidelines say? The AUA, according to the AUA, for prostates more than 80 grams or 80 ml of size, HOLAP, thulium vapor enucleation, or simple prostatectomy, open, laparoscopic or robotic, they should be preferred according to surgeon's expertise and discretion. So robotic prostatectomy has found its way into the guidelines, while EAU states that the first line options are HOLAP, bipolar enucleation, and open simple prostatectomy. However, laparoscopic and robotic prostatectomy are still regarded as feasible only. But there is a catch in this guidelines. The guidelines talk about prostates more than 80 grams of size, while here we are fighting about prostates which are more than 150 grams of size. So it was difficult to find literature evidence about prostatectomy in more than 150 grams of prostate, but there are certain challenges which are faced by the HOLAP. The salient points being skill or the learning curve, the electrolyte disturbance and the blood loss, the instrumentation time and the urethral trauma, incontinence rates, sometimes staging of the procedure, and the presence of associated disease like large bladder diverticulum or a large bladder stone, where a robotic assisted simple prostatectomy scores over the HOLAP, and let us see how. So there have been studies on the learning curve, and there is a study which says that to master the art of HOLAP, a surgeon requires at least 20 and 60 cases, while for a surgeon who's trained in robotic surgeries, only 10 to 12 cases are needed to master the art. And the effect of learning curve was established according to the time period a surgeon has done these surgeries, and it was seen that during the first 3 years of performing HOLAP, the result were not as good as when the surgeons has already done 3 years of HOLAP surgeries, and this was statistically significant. So I have scored 1. So RASP is 1, HOLAP is 0. The next point, electrolyte and blood losses. So these are few cartoons which were made by one of our colleagues in Maharashtra, Dr. Ganesh Chaudhary, who is an anesthetist. And you can see here that it's nearly a drowning situation when you are dealing with large prostates in the OT. There is blood, there is fluid everywhere in the OT. Everybody is sitting or standing there with their pants up, and sometimes it's an exaggeration that the anesthetist is standing in a scuba gear. But here, the studies are little divided. The blood loss is little less with HOLAP, but it is still acceptable with robotic assisted simple prostatectomy. So both have scored the goal, but still the score is 1-0. Now the main thing, the stricture urethra. The post-operative stricture urethra rate has been reported to be as high as 11 to 12% in various studies. I hope all the urologists would tell by their personal experience that this is still underreported. We have seen patients who land up in bad stricture after urethral instrumentation. However, after the robotic assisted prostatectomy, the stricture rate is very, very rare. There are not many studies which have studied this rates of stricture after the robotic prostatectomy, but in certain series it has been reported to near about 1%. So there is a logic behind this, even if there is no literature evidence, because robotic prostatectomy is not performed through the urethra, so the risk of urethral injury or stricture is lower. The transurethral procedure, especially in case of huge prostate, they require hours of manipulation of the urethra with sometimes very large instruments, which probably have not been designed for Indian urethra. And along with that, the robotic prostatectomy can be done in patients who cannot be placed in the lithotomy position or in patients with the narrow meatus. So what would you like? Would you like a patient in your follow-up OPD who is sitting with 5 band-aids on his abdomen, or a patient who is sitting with this kind of RGU and MCU picture where the doctor has done a wonderful job in the prostate? You can see that the prostatic fossa is wide open, but whole of the urethra is crying with pain and it's too narrow. Urethra, it's not a simple tube which is passing the urine. It's a silent conduit. The poet said that it must be respected and spared, and the reduced instrumentation time and size is very, very important. So here we score another goal and the score is 2-0. The third point is incontinence. So how does the two procedure fare when it comes to continence rates? So the stress urinary incontinence rates post holmium laser enucleation of prostate, a single surgeon's experience, they say approximately 10% of SUI, and out of that 1.5% of these SUIs have continued beyond 6 months. And the most important point which has been noticed here is prostate size more than 100 gram and catheter dependency are associated with increased risk of SUI. Larger prostate volume is an independent predictor of any SUI after the HOLAP. Another meta-analysis, this also showed that the age of the patient and a high prostate volume were significant risk factor for incontinence. While there is this trial from 42 patients who underwent robotic simple prostatectomy, and in this case series there was not even a single case of incontinence after the catheter removal. So this is another area where we have scored a goal. Now what happens in a large prostate? Sometimes we have to stage the procedures. In HOLAP, almost everybody knows that it's easier to do a morcellation after 24 to 48 hours of the resection of the enucleation. So in larger prostate, sometimes staging is done. So that staging that increases the cost, that increases the length of stay in the hospital. There is a repeated anesthesia complication chances. So the overall morbidity increases. And again, repeated instrumentation time, more urethral time of instruments, and probably the patient and the family, they develop a distrust into the surgeon that they fear that there is a complication which has developed, that the surgery has not been completed in. I'll finish, don't worry. Just let me score all my goals. So we are here also, we have 4:1. Now another condition, large intravesical calculi and large bladder diverticula, they can be tackled very easily with the prostatic robotic, not with the HOLAP. The score is 5-0. And final frontier, the sexual functions. There have been various modifications for the robotic prostatectomy wherein the retrograde ejaculation can be prevented. And I give a food for thought for Dr. Tanuj Pal Bhatia. Are there any modifications where retrograde ejaculation can be prevented in HOLAP? Why should a patient trade off between urinary function and sexual function? So this sexual function makes it a 10-0 because I consider this to be very important, and probably 4 goals should be awarded to this parameter. Cost analysis, let's leave the cost analysis to finance guy, corporate managers, TPAs, etc. Still a passing thought. If we exclude the initial investment and maintenance cost, studies have showed conflicting results regarding the cost effectiveness of robotic prostatectomy. There have been no direct cost comparison or specific cost analysis for very large prostate glands. So there is a consolation goal for the robotic, for the HOLAP, wherein probably it is more cost effective. So this is a large multi-single center experiences comparison where they clearly said that the trifecta composite outcome, which is post-operative good uroflowmetry, Qmax more than 15, low IPSS and absence of complications were used to define surgical quality, and the two groups were compared accordingly. So surgical approach was the only independent predictor of trifecta achievement, which was significantly higher in the robotic prostatectomy group compared to HOLAP. So with this last slide, I rest my case. Thank you very much for the patient hearing. Over to you, Dr. Tanuj.
Very insightful presentation, Sandeep sir, and many points in favor of simple prostatectomy. And now I would like to invite Dr. Tanuj Pal Bhatia to the stage. Dr. Tanuj is a renowned urologist and working as a chairman of Institute of Laser and Stone Surgery, Faridabad. He has been actively involved in teaching endourological procedures to the young surgeons. Please welcome Dr. Tanuj.
Thank you for this opportunity, and Sandeep sir, thank you for such a interesting presentation. धो दिया आपने मुझे. Let me also try something. So about the background, BPH continues to increase with the increasing aging population. Large glands that were traditionally managed by open simple prostatectomy and staged or rather incomplete TURPs, as we know. However, HOLEP has emerged as a size-independent endoscopic alternative. This is, a lot of data is there on this, and we will talk about it. Why do large prostates matter? Large glands lead to severe LUTs, recurrent retention of urine, bladder dysfunction, recurrent UTI, hematuria, and renal dysfunction in the end. What should the treatment goal be? There should be complete adenoma removal with durable relief of obstruction and minimal morbidity. The treatment options available are TURP, which is the traditional gold standard, but it has a size limitation. HOLEP is now considered as the new gold standard, and there is no size limitation. Simple prostatectomy is the original technique. It was done by open and lap and now by robotic technology, and there is no upper size limitation. That is the advantage of robotic as well. So what are we comparing? First thing is the HOLEP. Can we have sound? Sound, please. Sound.
Do you believe in magic?
So we have the evergreen actor, which can fit any role. We use laser for so many things, and it suits very well when we are doing a laser prostate. And then we have this guy who's not such a great actor, but just waiting to dig holes into everyone's abdomen. More volume, please.
कि कंफ्यूज हो जाओगे कि सांस कहां से ले.
Look at the patient, worried about the holes we are going to dig in his abdomen, sir. Anyways, so the principle of HOLEP is anatomical enucleation of adenoma, laser dissection all along the surgical capsule with morcellation in the bladder. Advantages being complete adenoma removal, endoscopic treatment instead of the small scar ones, and it is size independent as we discussed. Holmium laser is made of multiple cavities which produce a laser beam of short penetration depth with wavelength of 2140 nanometer. It is a time-tested modality. There is no paucity of data on this. First reports were from Dr. Peter Gilling in 1995, and then in 1998. There has been an ever-growing interest. Just see by 2026, there are more than 1,000 published papers, and there are more than 100 meta-analysis on HOLEP itself. There are many papers. HOLEP gives excellent results, be it regarding improvement in IPSS scores, improvement in the flow rates, and decrease in the post-void residual urine. And these are not just good results, they are consistent results which they improve with time. There are studies as long as 10 years, and data has shown that it's excellent results which improve with time. And with a low retreatment rate, which was one of the problems which we were facing with TURP, as high as 10% in 5 years was the retreatment rate with TURP. With HOLEP, it's practically 0 to 1.4%. Coming to complications also, compared to the traditional treatment, the complications with HOLEP, most of the complications are less except stress incontinence, which is more with HOLEP accepted. The incidence of stricture is equivalent to TURP. Post-HOLEP incontinence, sir also spoke about it. The incidence was 4.9 to 12.5%, but most recover within 1 year. The risk factors were mentioned by this paper by Dr. Sandeep: diabetes, long-term diabetes mellitus, longer operative time, older age, and surgeon's experience. But what has changed this is this technique, which is called as early apical release. With earlier apical release, the incidence has come down to as low as 0.67%. Some of the slides are not coming completely. Okay. So now this is how Dr. Sandeep is feeling.
बहुत सुनी तुम्हारी बकवास, बहुत सुनी तुम्हारी बकवास. तुम्हें कॉम्प्लेक्स है, तुम छिछोरा हो. मैं छिछोरा हूँ. कॉम्प्लेक्स है तू. मैं छिछोरा हूँ. छिछोरा है तू. छिछोरा हूँ मैं. छिछोरा हूँ. छिछोरा है तू. चुप चुप चुप. छिछोरा बोलता है मेरे को. और अभी नहीं मालूम पड़ेगा तेरे को. अभी नहीं मालूम पड़ेगा.
No problem, sir. We can understand the frustration. So let's look at the data which you said it's not there for large prostate. Now look at this study on HOLEP for more than 150 gram prostate. 450 patients. Just see, I don't know when robotic surgery will reach that number. 450 patients They conclude that HOLEP is a safe, highly efficacious, size-independent procedure, which is why it has become the new gold standard for treatment of extremely large prostates. Another paper, more than 150 ml prostate, 326 patients. They conclude HOLEP remains preferred choice for the BPH and should be performed in experienced high-volume centers. This is a systematic review, again, for more than 175 ml size prostate, and the number of the patients is also very high in this, of 6 studies, and they also conclude that it is efficient, it is safe, it is feasible for very large prostate with good functional outcome, low perioperative complication and low retreatment rate. So when the data speaks for itself,
के माहौल में शब्द थोड़े से इधर के उधर हो जाते हैं, मात्रा और पंक्चुएशन का फर्क होता है, रोको कॉमा मत जाने दो, रोको मत कॉमा जाने दो, पूरा मतलब बदल जाता है सर.
so when data speaks for itself, there is no room for excuses or poems. So coming to our experience at ILSS, we have a 150 watt Jenna surgical holmium laser, which was the first of North India, second in India. It is the only laser which allows you to operate at EPS, which is a special setting with a 140 watt with a special EPS setting. It allows quick enucleation backed by a very fast morcellator. Most of our HOLEPs are less than 1 hour at our center. This includes morcellation as well. So far, in last 2.5 years, we have done more than 300 HOLEPs with this laser. We have conducted about 27 trainings for urologists, and we run a fellowship also. We have trained more than 10 Professor Roy Chelly endourology fellows at ILSS. Seeing is believing, and these are not created yesterday. You can see my LinkedIn profile. I post regularly about this. Just look at this image. 200 gram prostate, enucleation time, 23 minutes, morcellation time. So total procedure time for that one is 52 minutes. On the right side is 150 gram prostate, operated in 56 minutes. Another case, 200 gram prostate, operated in 51 minutes, including morcellation. This is not just enucleation, this is enucleation plus morcellation. The other one is 120 gram prostate, enucleation time 26 minutes, total procedure time 42 minutes. So many are there, and these are there on my, majorly on my Twitter and LinkedIn profile. We do it routinely. You can see the jars full of tissue. You can see the timer there. We time all our procedures. The largest prostate, sir, I have not done is 10,000, but I have done a 350 gram prostate, and we could do it in 90 minutes, and patient's catheter was removed next day itself, not by choice, but he was not tolerating it. We could remove it. Patient was fine. So our experience with more than 150 gram prostate, we have done about 52 cases. Average time taken was 51 minutes. There was no blood transfusion required. Catheterization time was 1 to 5 days. Hospital stay was less than 24 hours in almost all patients. One patient had secondary hematuria. Transient stress incontinence was there in some patients, but it recovered. And after 6 months, only one patient had stress incontinence. Stricture urethra we did have in 2 patients. And none of our patients had a bladder neck stenosis.
हमारा जिक्र तो हर पल हुआ फसाने में, तो क्या हुआ जो थोड़ी देर हुई आने में.
So now coming to HOLEP versus RASP data, which sir presented one paper, but I will dig more into that. So that's what everyone has been waiting for, the real fight, and मेरे करण अर्जुन आएंगे, वो अब लड़ेंगे data में. So this is the paper that sir quoted, but he did not dig deep into it. Please look into it. Even in this, the operative time of robotic surgery is much more. It's about 111 minutes mean compared to 70 minutes for HOLEP. And the incidence of stress incontinence is same in both the techniques. But I have some issue with this paper. Why I am questioning it is, the length of hospital stay for HOLEP, they have shown an average of 7 days. There is no reason why a HOLEP patient should stay for 7 days in a hospital. So that we leave it at that. Again, within this paper, regarding the need for stopping anticoagulation, antiplatelets, they did have to stop for 1 week for robotic prostatectomy, and they could do HOLEP in all patients while on anticoagulation. They didn't have to stop the anticoagulation or antiplatelets for that. So that's the advantage of laser. This is another paper from Korea, and they also they have compared robotic versus laser, and they said that the catheter removal time, length of stay, and hemoglobin changes were more favorable in HOLEP. One advantage they mentioned in robotic was that the stress incontinence was lesser. But if you look at the data, their patients also did have stress incontinence, although it came down with time. So to conclude, HOLEP scores over robotic prostatectomy in duration of surgery, duration of stay, duration of catheterization, lesser invasion, no incisions, cost, major factor. Availability, everywhere robot is not available, and there is no need to stop anticoagulation. Some claim robotic prostatectomy to be urethra sparing, but with latest lasers, HOLEP is much faster. The in-urethra times are much shorter. That's why the incidence of stricture is also lesser. And the real urethra sparing surgery would be when you are not putting a catheter at all. The moment a patient needs a catheter, the urethra has been violated, he is at a risk for stricture. So it's important to have the right tool in right hands. As Steve Jobs said, technology is nothing. What is important is that you have faith in people, that they are basically good and smart, and if you give them the tools, they will do wonderful things with them, like Dr. Ritesh is doing with the robot, we are trying to do with the lasers. And at the end of the day, it is the patient that matters. Whatever is best in our hands, we should offer that to the patient, because then only we can do justice to them. Thank you. No scoring by me.
Hi, Dr. Dhanuj. Nice presentation, both of you. I just want to ask one question. Is there any level evidence or a randomized trial comparing head-to-head between HOLAP and robotic simple?
It's too early for that.
Yeah. I think that will give the final answer, which one is the winner.
True.
So far, it depends on the surgical skills, availability of the technique. Some people are good in HOLAP, some people are good in robotic simple. There are very few who are good in both of them.
Yes.
And definitely HOLAP has a long learning curve. We have to accept that. There are a few
Sir,
people like you and
Sir
Dr.
said
Ritesh who
20
can
to
do.
60, the data says around 50. So that's there.
The only benefit I see with robotic simple, all those who are doing good robotic surgery, they can easily switch to robotic simple. But all those who are doing TURPs, it is difficult to learn and master HOLAP and have that kind of result.
It's not so difficult, sir.
For you,
you're doing, not just for me, all of you are also doing it. There is a, I don't know, हिंदी में हवा बोलते हैं कि एक हवा है कि इसमें दिक्कत है, इतना मुश्किल नहीं है. It's like any other surgery, the more you do, you get better at it.
So I think we should wait for the randomized trial to get the final answer. Till that, both are the winners.
Thank you.
Thank you, Dr. Sandeep and Dr. Tanuj. I think for today's film, both of you are heroes. There is no fighting between both of you. I feel HOLAP is still going to stay for some time to come. Robotic is coming up, but today we will clap for robotics because Dr. Ritesh, he is the flag bearer of robotics in Faridabad. And I am very happy that he has chosen a system which is purely made in India and by one of our colleagues. So I want clappings for Dr. Ritesh Monga, please.
Sir, can I add a comment to what you said? Robotic will definitely have a role, especially in prostates which are larger than 350 grams. Because that is where definitely robotic simple prostatectomy will have a role.
Because we can approach Dr. Tanuj Pal Bhatia very easily. Dr. Sandeep we have to travel to, but Dr. Ritesh Monga, he will share his experience, what is his experience in robotic simple prostate.
Laser prostates for all us urologists for the country. So he's doing a wonderful work. And two quick questions. One from Dr. Manish, like you have the US experience now. So where does equablation stands now? Because it is being done in US. Does it make a difference in size, and would it be the answer in coming times? And second, I have a question from Dr. Amitabh. The thing which worries me most with robotic simple prostatectomy, if the biopsy comes out to be malignancy, then what? Because with bigger prostates, you sometimes have larger PSAs. We have done a biopsy before, but if it later would come out to be malignancy, then what to be done?
So in that case, I think we have done almost 15 simple robotic prostatectomy, and every patient underwent biopsy because our center is cancer center. So they come for high PSA. We do MP, MRI, we do biopsy. If it comes negative, then we do robotic simple prostatectomy. But now there is some technical modification. So we do trigonalization to the apex of the this up to the urethra, but we don't do complete like the mobilization of the bladder mucosa to the apex. We leave the capsule intact actually. So we just do trigonalization. So if something happens later on, the prostatectomy will be much easier compared to if you just move everything like mucosa of the bladder complete to the prostate apex. So that we do, that's it. But I think that is a very valid question. So even if if you get the 3+3 score, then like most of the patient, they don't require any invasive therapy later on. And even if they require, then now we have a focal therapy also. We have reduced the prostate like almost 20 gram, 30 gram only we can do focal therapy also later on.
So, first, before that, let me add to the comment about the robotic simple. The place where I worked, had the chance to do a lot of robotic simples, and in fact, we presented the data of robotic simple versus HOLAP in 2024 in Journal of Neurology. That included almost 80 cases of robotic simple compared to 260 of HOLAP, because the way Tanuj said that HOLAP is much more commonly done as compared to robotic simple. So our protocol is, if the PSA is high, we do MRI, and if there is any lesion suspicious in the MRI, then only we go for a biopsy. Otherwise, we go directly for robotic simple. And the incidence of finding a cancer in the biopsy after robotic simple is very, very low. But to operate on those cases is very, very challenging, to be very frank. I feel like the better approach is to start with the posterior approach first in those cases, because that plane is still naive. For robotic simple, you are going only with the anterior approach. You are not touching the posterior planes of the seminal vesicle and in between the adenoviruses and the seminal vesicle. Dissection becomes difficult, and incontinence is much more higher as compared to a standard robotic radical prostatectomy if you are doing first simple and then going for a RALP after that. And like you said very well, Gleason 6 you can just observe, 7 favorable you can observe. It is only if it is 7 unfavorable or a higher score, then you'll have to think of definitive therapy. Giving a focal therapy after simple is also challenging because the planes are disturbed. You cannot target or focus that area to give a focal therapy. So either do active surveillance or go for a surgery and remove the residual gland or the capsule. Then coming to the question of aquablation, so far the guidelines or the FDA approval for aquablation is only for the size of up to 150 grams. You cannot do it for gland which are more than 150. It has been calculated because the aquablation has a depth of penetration of around 2.4 centimeter. It cannot go beyond that. So for a very large gland, you cannot run multiple paths to ablate that gland in one sitting. So the question of very large prostate, aquablation is not a choice. It has to be between HOLAP and robotic simple. The only advantage of aquablation which I see is mainly for the glands which are 100 to 150 size, and the patient is relatively young or wants to preserve the ejaculation. Aquablation has a different setting in which it preserves the apical part of the posterior part of the apex of the prostate close to the verumontanum. That is said to give some obstruction while the ejaculate is coming out and prevent retrograde ejaculation. But the quoted success rate is like almost around 70 to 80% patients have their preserved ejaculation after aquablation.
Thank you, Dr. Manish. Any questions from the floor?
Can I ask you one question? Although it's not related to it, what is your take on Roko sutures for radical prostatectomy? Whether it helps in continence or it create a problem?
It definitely helps in continence, and there are two ways of doing it. Some people just take 2 or 3 sutures between the posterior rhabdosphincter and the posterior wall or the detrusor layer behind the posterior edge of the bladder neck. And if you see the technique of Dr. Alex Motri, he take a continuous suture. Initial 3 stitches are Roko, and the same stitch is taken inside, and he uses the same stitch to do one side of the anastomosis between the urethra and the bladder.
First, we have one full talk by Dr. Manav sir on the same, and we're discussing it in detail.
Sure.
So I'll request the moderators to be on the right side of the stage. So
Thank you.
For the photograph. Thank you very much.
Thank you, Dr. Tanuj Paul Bhatia, Dr. Sandeep Gupta, for this insightful session. Thank you, Dr. Ritesh. Thank you, Dr. Lokendra, for convening this session. Also, just a reminder, I hope all of you are having a delightful lunch, but for those who have not had a chance to go out and refresh themselves, the lunch is open only till 3 p.m. We will now gently transition from culinary excellence to clinical excellence as we continue with the afternoon sessions. Going forward, as we know, robotic platforms continue to redefine surgical precision, offer enhanced visualization, dexterity, and improved outcomes in complex GI and HPB procedures.
Our next session will highlight the evolving role of robotic in managing some of the most challenging surgical conditions. For that, we would like to invite Dr. Manu Shankar to kindly convene this session.
Good afternoon, everyone. This is a post-lunch session, and we have a wonderful speakers right now who will keep you away from the postprandial slumber. So I would like to invite to chair Dr. Azhar Parvesh, Dr. Lalwani, Dr. Prem, and Dr. Ajay Kapoor. Dr. Lalwani is not there. Dr. Sandeep, I would like to invite you. Please come on the dais and take the chairs. And the first speaker is Dr. Neeraj Chaudhary, who is a GI robotic surgeon at Fortis Vasant Kunj, who would be talking on GI HPB cancers. Is robotic surgery the way forward? Dr. Birbal, Dr. Puran Agarwal, I would like you to join on the stage.
Greetings from Fortis Hospital, Vasant Kunj. I would like to thank the organizers for giving me an opportunity to speak on GI HPB cancers. Is robotic surgery the way forward? We'd like to cover the topic under the following headings: a bit of introduction, then data of robotic cancer surgery in GI HPB segment, the challenges and future of robotic surgery, and our experience and conclusions. The great Sushrut in Sushrut Samhita said that a great surgeon is the one who possesses courage and presence of mind, a hand free from perspiration, tremorless grip of sharp and good instruments. These lines hold true in today's era also, albeit the fact that the hands of the surgeon are slowly being replaced by the tremorless grip of the robotic arms. There are advantages of robotic surgery, as we all know, in terms of 3D vision, tremor filtration, wristed instruments. In terms of oncologic safety, it provides better lymphadenectomy, vascular control. There is reduced blood loss, shorter hospital stay, and faster recovery, resulting in better patient outcomes. Surgeon ergonomics is better, resulting in less fatigue and more control in complex resections. Here we were in 2007 when a paper came that robotic surgery India is not ready yet. To the last year, 2025, we completed approximately 60,000 robotic procedures all over across India, and there is definitely a rise of robotics and AI assisted surgery in modern healthcare. The journals are flooded with such articles. We'll try to see the evidence. Is there any evidence? Because without evidence, we are nowhere. In terms of robotic surgery in rectal and colon cancers, pancreatic cancers, gastric cancers, and liver cancers. The most important thing in any cancer surgery is whether we have good oncologic outcomes, and second, whether we have good quality of life. So this paper published in JAMA last year tried to evaluate that for middle and low rectal adenocancers. Around 1,171 patients were there. It showed that 3-year loco-regional recurrence and 3-year disease-free survival was significantly better in the robotic group as compared to the laparoscopic group. And the functional outcomes in terms of better urinary function, male and female sexual function, and defecation functions were also better at 3, 6, and 12 months after surgery. An article from India, a review article, tried to compile the data related to laparoscopic and robotic colorectal cancer resections. And as we are seeing that newer and newer data, last 7, 8 years, if we see, we have seen better functional outcomes in TME with robotic surgery. Robotic proficiency is also better with just 20 to 40 cases in comparison to laparoscopy, which requires 50 to 100 cases. Better short-term outcomes have also been reported in recent studies. Only cost remains a problematic factor. Most of these studies tried to evaluate the left-sided cancers. A systematic review of retrospective study, 46 studies were there for right colonic cancers, more than 36,000 patients. They found out that the robotic surgery had higher lymph node harvest, the conversion to open were low, and complete mesorectal excision groups, there were lower readmission costs. And they concluded that robotics offers advantages in oncologic resection. A small specific group of cohort was evaluated in a study published last year, and they tried to evaluate the high-risk colorectal patients like male patients, obese, more than 30 BMI, and low rectal cancers, and they found out that robotic-assisted surgery should be considered as a preferred modality in these patients because of equivalent or superior outcomes in relation to conversion to open and length of hospital stay. Coming on to the pancreatic cancer is the pancreatic fistula, the pancreatic leak, that is reconstruction, is the Achilles heel for any Whipple surgery. A randomized trial, Europa trial, tried to evaluate and compare the two, robotic and the open Whipple's procedure, and they found out that the complications were similar, the survival was similar, and this was basically a non-inferiority trial, and it proved that robotic surgery is equal to open surgery in high volume centers. There was a systematic review and meta-analysis which tried to compare robotic and laparoscopic pancreaticoduodenectomy, where 70% of the procedures were laparoscopy and 30% were robotic. It was a large number of patients were there in this study, more than 3,700 patients. They found out that robotic surgery was associated with less blood loss, less conversion to open, less vascular resections, and more retrieved lymph nodes in the robotic group. Similarly, oncologic outcomes have also been studied and compared between robotics and open pancreaticoduodenectomy for pancreatic cancer. A retrospective study, a propensity trial, 1:2 ratio was studied, and last year the results were published, and it showed that robotic pancreaticoduodenectomy showed better overall survival and disease-free survival as compared to the open group. The resection rates, R0 resection rates, and the harvested lymph nodes were similar. The robotic group had shorter post-operative recovery time, which is very significant in these patients because pancreatic cancer is now believed to be a systemic disease rather than local disease, and adjuvant therapy post-surgery is vital to avoid recurrence and better overall survival. So these patients could get adjuvant therapy better. So it was considered a feasible alternative with potential advantages of early recovery without compromising long-term outcomes. Coming on to the gastric cancers, there was a study, 15 studies were there in which one RCT was there. This was a meta-analysis. More than 5,000 patients compared robotic and laparoscopic gastrectomy. They found out that the robotic group was better in every sense. There was reduced blood loss, short hospital stay, less conversions, less complications, higher number of harvested lymph nodes. The only problem was the longer operating time. A RCT was there which tried to compare the robotic and lap distal gastrectomy, and they found out that the short-term surgical outcomes were similar in both the groups. A similar oncologic outcome study was done, RCT, of 300 patients found out that the 3-year disease-free survival and 3-year cumulative recurrence was better in robotic group as compared to the laparoscopic one. Quality of life is an important factor, and this was studied for liver resections in HCCs, and it found out that robotic surgery versus laparoscopic hepatectomy, if it was evaluated, and they found out that the robotic hepatectomy yielded comparable quality of life parameters as laparoscopic one and should be a safe alternative approach in experienced centers. 5 high-volume centers were included in a study from 2010 to 2020 in Italy. Robotic surgery resulted in better post-operative outcomes in terms of less morbidity, less ICU stay, less hospital stay, less post-hepatectomy liver failures, even though the survival was similar in both the groups. So what are the challenges? Yes, cost is a challenge, learning curve is a challenge, access in resource-limited settings is a challenge. Future will be integration with AI, augmented reality, haptic feedback, and telesurgery. This telesurgery may be the future where a surgeon is sitting in a remote area performing surgery at long distances. In conclusion, the robotic surgery is not the future, but it is the present. It is a safe and reliable option. Laparoscopy will soon be a thing of the past. Complex case handling has been made easier. Oncologic outcomes are similar and better in certain studies. The quality of life parameters are also saying that that robotic groups are better. Problems like cost will determine the increase in adoption. It is wisely said that it is less about the robot operating and more about the surgeon adapting, which will decide the future of robotics. A great entrepreneur once said, Chris Grosser once said that opportunities don't happen, you create them. And I think that robotic platform is an opportunity to overcome the challenges which were posed by open and laparoscopic surgery. We should also thank the Indian robotic company, the SSI Robotic System, for providing us a superb platform. This is a video which we did, a central pancreatectomy, a very complex procedure 2 years back on Da Vinci, and we could do the same procedure around with the same dexterity, same results with the SSI robotic system, and this proves that the Indian robots are equivalent to the Western ones. This is a Whipples which we performed around 5 months back on this system, the SSI platform, rather technical challenging operation, especially this patient, because this patient also had replaced right hepatic artery, and we had to be very cautious while doing a resection of the uncinate. I'll just go fast through this. This is the bile duct resection which is going on. We have made a tunnel, and just a minute or so, and the jejunum is being transected. I wanted to show the important thing in this is, one second, why it is not coming. The resection part is much easier. The reconstruction part is much more easier with robotic surgery. This is the classical Blumgart pancreaticojejunostomy which we do. We have to do all the steps as we follow in an open surgery, and we should not try to change the method related to the robotic surgery. That will give you better results in long term. This is a robotic APR. A patient came from Amritsar after getting chemoradiotherapy and referred to us, and we did complete resection, complete TME, and a permanent stoma because it was a low rectal cancer invading into the anal canal. This is a patient with sigmoid cancer and low rectal cancer, synchronous malignancies. A large resection was done, and everything was completed, and the patient was discharged in 4 days. And he is my mentor, Dr. Nandi. And this is our celebration of 300 robotic procedures. Thank you for your patient hearing.
Thank you, Dr. Neeraj, for that wonderful presentation and insight on robotic GI oncology. Anyone has a question? And I invite Dr. Neeraj, please join on the right of the dais for your memento. And I also invite the moderators to receive their mementos on the right side of the dais. The next set of moderators are Dr. Vaibhav, Dr. Lalit, Dr. Sunil Parashar, and Dr. Ankita. Can you please come on the dais and take the chairs? Dr. Arun Prasad is a bit stuck up. He would be taking around half an hour to be here. So I invite our next speaker, Dr. Anil Gulwani, who is an oncosurgeon at Kolhapur. Dr. Nikhil, can I have you on the stage, please? He would be talking on indigenous robotic surgery, and experience with extralevator APR and combined colorectal and hepatic resections. Dr. Nikhil.
Shall I start? So, first of all, thank you for inviting me for this wonderful conference. Today, I will be talking upon the rectal surgeries only because of the want of time, hepatic resection I will not cover. But just to complete the talk, I will be discussing about few steps what we routinely do for rectal cancers, and I am not talking much about evidence because it has been already covered in the previous talk. So as we all know, robotic surgery has transformed the field of minimally invasive colorectal surgery by improving precision, and procedures such as LAR and extra levator APR are, as we all know, they require meticulous dissection to achieve oncological clearance, and many critical structures in the pelvis have to be preserved. So, why robotic surgery? We all know precise dissection, nerve preservation, robotic advantages as we have been discussing since morning, superior ergonomics, and we are Aster group of hospitals at 2-tier city at Kolhapur, Maharashtra. So, whenever we do this surgery, even if for laparoscopic or robotic surgery, the steps are more or less same: initial abdominal survey, identification and isolation of IMA, IV, high ligation of autonomic nerve, high ligation of artery and autonomic nerve preservation, medial to lateral dissection, identification and protection of the ureters and gonadal vessels, then left colon mobilization, pelvic dissection, TME, distal transection of the rectum, adequate distal margins to be ensured before transection. Then as per the case, coloanal colorectal anastomosis, and in case of APR, it is a permanent stoma. So this is the position which we give usually for the robotic strip Trendelenburg position with Lloyd Davis arms tucked, pressure points protected, and these are the port placements. Usually, this is a multi-quadrant surgery, double docking is usually required with this SSI Mantra robotic surgical system. Especially for the rectosigmoids, we can get away with only pelvic docking, but for LAR we need this double docking strategy. For the abdominal phase is centroside docking, and for the pelvic phase is only the central docking. Regular steps: pneumoperitoneum created, small bowel is packed, then all the steps which I have told are done, and I will show the video actually before, without going much into details of anatomy and everything. But these are the hypogastric plexuses at superior as well as inferior plexus as well as pelvic area. We have to consider saving nervia regentis, and sharp dissection is required. These three tubular structures need to be preserved: left gonadals, ureters, left common iliac artery, and I will go directly with the video, which this was actually I will be demonstrating mostly the extralevator APR and a short video of low colorectal anastomosis for ultra low ARs. So this was 62-year male with low-lying distal rectal adenocarcinoma who presented to us with the malignant fistula in NO, and the FDG avid anorectal lesion was extending into the anal verge. There was small inguinal lymph node with the FNAC of which was negative, no metastasis. After multidisciplinary management discussion, we decided to go ahead with neoadjuvant chemoradiation therapy and targeting both rectal tumor as well as malignant fistulous tracts. 8 weeks post NSA-TRT, response evaluation scans were suggestive of partial response, and inguinal node reassessment was again negative. So, so this is the video. This is, as I was discussing about the port placement, abdominal phase, camera 2 centimeters above and slightly on the right of the umbilicus, and this R1, R2, R3 are the ports for abdominal phase. The position, the steep Tenenbaum position is required with little left up around 15 degrees, and carbon dioxide insufflation in the peritoneal cavity is up to 14 mm of mercury. These are the images of abdominal phase, centroside docking and pelvic docking in eventual phase. And instruments which are used are 10 mm Olympus camera with robotic camera and monopolar curve scissors. These are the steps which are used for, as I have discussed, low anterior resection steps routinely for all patients as well as for APR depending upon the growth. So this is a modified Lloyd Davis with port insertions placed, modified lithotomy position is given, centroside docking is done, and after abdominal survey, the surgery started. The 45-degree angle is maintained here, right common iliac is visualized, and this is the right arm, right instrument which is going in the grasper through the third port. This retraction from the left hand is actually very important to give a good insufflation going through this peritoneal cut. The carbon dioxide itself does a lot of our job easier in initial steps. Up to the sacral promontory, this cut is extended, and then the inferior mesenteric artery is stented with the third instrument, that is a grasping forceps, and from the root of inferior mesenteric artery, dissection is continued, and hypogastric superior plexus is noted and identified and secured safe. D3 lymphadenectomy is done. Skeletonization of the IMA, IMV is done. Inferior mesenteric vein as well as IMA dissection needs to be very meticulous to prevent any injury to the hypogastric superior plexus so as to prevent any sexual and urinary dysfunctions in the post-op. So when we do medial to lateral dissection, the ureter is preserved. This IMA nodal clearance is done, and left colic artery is preserved in most of the cases where low anterior section as well as APR is required, and depending upon the length of bowel which has to be taken down. Very rarely left colic artery we take. So left colic artery preservation is going on with nodal clearance in surrounding area, and inferior mesenteric vein there is popping up to be preserved. So inferior mesenteric vein goes along the ligament of Treats at the inferior border of pancreas, as we all know, and the superior plexus of hypogastric plexus is again noted here and safeguarded before we go ahead with ligation of clipping of the inferior mesenteric artery. So this is the avascular plane. You can identify the color of the fat. The retroabdominal fat is usually golden yellow, and the colonic fat is usually pale yellow. The inferior mesenteric artery is skeletonized beyond the origin of left colic artery, and clipping is done. So once this IMA clipping and division is done, half of the job of abdominal phase is over with this. So this is what I was talking about, the color of the fat, golden yellow fat will be towards the retroperitoneum, and you can see the pale colored fat belonging to colon or mesorectum. And this is actually the layer separating the peritoneal fascias, pelvic and the parietal and visceral fascias in the avascular embryological plane. So once that is completed, we go into the pelvis, go beyond the sacral promontory, again identifying all the nerves. This is the presacral plane of dissection, the holy plane of held, what we call as. And here also inferior hypogastric plexus has to be safeguarded, otherwise there is no point in preserving superior plexus. And with this kind of 3D visualization, this becomes very easy. And the key is to just remain between the visceral and parietal layer of pelvic fascias, so that we don't go on and injure the plexuses. So this is going beyond the sacral promontory. The dissection is continued along the TME plane. Some remnant retroperitoneal attachments are being taken, and then we start with the lateral to medial dissection. So medial to lateral is over. Now we go ahead with lateral to medial dissection, and mobilization of sigmoid colon is done as per the need, descending colon. And in case of APR, we don't have to release the splenic flexure or mobilize the splenic flexure. But in case of colorectal or coloanal anastomosis after ultra low or low anterior sections, we have to mobilize the splenic flexure as well. So here there is a plane between the gyrotas fascia or gyrotas fat and the colonic fat, and this is also the avascular plane which is being dealt with before completing the lateral dissection. So these remaining attachments are again being taken down, and we are entering to the pelvis again. So these all things are done through the abdominal phase of docking, that is centroside docking. The instruments will not reach beyond into the pelvic floor. So these are the plexuses which have been safeguarded. As we go distally, the instruments don't reach there, so we have to do the pelvic docking. And if we remain in the holy plane of held, there is no chance of injury to autonomic nerve plexus. So then pelvic phase central docking is done, and we start the procedure. This is the most important step, that is a urinary bladder suspended by hitch, and umbilical tape is used to help the assistants to hold it during dissection. It's a very important step. Otherwise it becomes, the pelvic dissection becomes very difficult. So the plane of that TME is continued again with safeguarding of the plexuses as we discuss again and again, and the pelvic splanchnic nerves in the lateral dissection also need to be protected. As we all know, here the S2, S3, S4 nerves exit and form the pelvic splanchnic nerve. This is the baby buttock sign when we go beyond. So posterior dissection is the first step. We have to go up to the pelvic floor while doing the APR or ultra low ARs. And once we see the sphincters, we stop the posterior dissection and start with the lateral dissection. Here most important thing which we have to take and safeguard is the pelvic splanchnic nerves which originate from S2, S3, S4, and inferior they go and form the inferior hypogastric plexus. So inferior hypogastric plexus is sympathetic and pelvic is parasympathetic, as we all know. And here the middle rectal artery needs to be taken care of, and it is exactly at the anatomical landmark of visceral layer of pelvic fascia and parietal layer of pelvic fascia. So as we all go beyond and reach the pelvic floor, this is the extralevator dissection going on, and once we complete on one side, we similarly complete on the other side. Similar steps on the other side, and then we start anteriorly. So this bladder stitch helps literally to separate the planes easily in this avascular plane, and anterior TME is being completed. So here some periprostatic plexus needs to be taken care of if they come into picture. Otherwise, if we follow the plane, it will not injure anything. And as this was a malignant fistula in ano, we had to go a little more laterally for extralevator dissection and to take care of the fistulous tract as well. So once this, you can see the pelvic floor there now. On the opposite side again, the similar things are completed. And then the sigmoidal division is carried out after completion of the pelvic dissection. This happens with the help of pelvic docking to take care of all the lymph nodes which you have taken along the IMA pedicle. Those lymph nodes are taken with the IMA pedicle. Just one more minute, I will finish. So this is divided with the endo-GIS staplers. So colonic division by endo-GIS staplers is done. So once this is done, with the help of needle holder from the assistant port, we just keep the resected specimen down into the pelvis, and the perineal dissection is completed. The specimen is delivered, and this is the thing. There is no incision, big incision, and perineal viviplasty was done for this case because we had to excise the sinus tract, the fistulous tracts also. So this is just a half a minute video of sorry for the smoky field, but for robotic low entry resections going deep into the pelvis, the smoke usually gives a lot of problem. This saving the sphincters here, and distal resection or transection is done. At the this was the case where ultra low was required, and levator ani muscles are usually identified. The sphincter preservation is done, and transection is done again with the help of endo-GIS staplers. And especially in these kind of surgeries where anastomosis with the help of circular staplers, robotic instruments play a big role in suturing, and we usually take the second layer over this circular staple to safeguard the anastomosis, and always we do the leak test to confirm there is no intraoperative leakage. So these robotic instruments, as we all know, in so deep pelvis, the suturing is very easy. Thank you so much.
Hello. Hello. Yeah, Dr. Nikhil very well explained every step and beautiful dissection by the robot. Just one very small question. How did you manage to keep the small bowel away during your abdominal phase?
So what we do is usually steep Trendelenburg position, almost head touching the ground, and left up 15 degrees. So what happens is automatically with the help of gravity it goes down, and whatever remains is taken into the right right hypochondriac area, and over that we put a gauze so that it doesn't slip during dissection.
I thought you hitched the small bowel.
No, we have not hitched.
No. Okay. Thank you. Very well done.
Thank you so much.
Thank you, Dr. Nikhil. Now I would, sir, you are here. Dr. Arun Prasad is here. So I invite him to talk on lap to robotic journey. And he is amongst the pioneer of robotic surgery in India. He started it at Apollo Hospital and is one of the most renowned robotic surgeons in the country. Sir, please take.
Thank you for the kind introduction. I think my files are being copied, and while it's being copied, I would like to say that firstly, congratulations for organizing this meeting on such a themed topic, that is of robotic surgery. And we started robotic surgery in 2012, and now it's become quite popular among NCR and many two-tier cities as well. And basically what is happening is the acceptance is increasing as the cost of robotics. See, even the intuitive, which was quite expensive relative to inflation, relatively the cost has gone down. Plus there has been a lot of competition, and newer robots coming into the markets have also helped in promoting. And lastly, the most important thing is that insurance companies now are accepting, and I would say about 1/3 of my patients are able to get insurance coverage, which also makes a lot of difference. So combining all these would be something that will take us to the future. And while this slide is getting copied, I'll just talk about one of the slides which I have, and that is about why is there a demand in India. So the demand in India is for many reasons. Why should hospitals take up the robotic surgery? So one reason is that when we talk about, say, medical tourism, people coming from abroad for treatment, they are looking for advanced technology, and many patients would want robotic surgery, and your hospital wants to be known as a hospital which has advanced technology. Then we have the government sector also, because the government also, the politicians, the bureaucrats, everybody has to show to the public how they are doing good things for health. So by promoting robotic surgery, people are in the government are also able to say that, okay, by getting robotic surgery into this government hospital or in this place, we are matching global standards. So I think my presentation is ready. I'll just start. So yeah, can show on the slide. So this is an interesting topic which was given to me, and I said that why are you giving me this topic? I could have shown some videos about some surgery. So I think this just is my journey, laparoscopic to robotic surgery. So whenever anything new comes, there is always a protest, and people are not very happy with new technology or new things coming. And I was in London in 1992. This is Charing Cross Hospital, and at that time we started laparoscopic surgery in my hospital there. And these were the kind of articles which we used to see in the journal about laparoscopic cholecystectomy, threat, is it a dangerous innovation, and we all know how now it's become such a gold standard for this surgery. So at that time, when doing complex laparoscopic surgery, I used to wish that I had 4 arms, because I wanted to control the camera also, the assistant arm also. So if I ask you a question, can you manage a machine which has 4 control by hand, 3 by foot, 3 places to look around, and when you are doing this, you are also chatting? So many people would say that, no, this sounds a little difficult, but I'm not talking about robotic surgery, I'm talking about driving a car. And this is just an example why I mentioned this example, why God has given us brains and capability to learn things so fast that after you have learned driving, you don't think that why I've got 2 feet and 3 places to press my 3 pedals. It happens automatically. You don't even realize when you go from home to hospital. So just a quick video, and this is a robotic bariatric surgery, and this is being done on an intuitive XI on a 275 kg patient. Now surgeon sits at a console, and in Da Vinci we are able to sit at this console and plan the settings according to what we want. So personal settings are there. There is a view box here. So we have 2 types of robotics. One is where you have a view box, and another is where you have an open platform of a television style. So this one has a view box which gives you a 3D vision because it's a binocular vision. The instruments are controlled through your fingers, and it makes it wristed movement. Foot pedals are there. I think most robots these days have foot pedals except the CMR, which has got control all over only by your hands. So foot pedals can control your energy, so you can see right and left instruments both cutting cautery, and the left foot controls the camera. The 4 arms of the robot are there. This is a robotic cannula which is very similar to our laparoscopic cannula. However, the instruments which go inside are a little different, and these instruments can move in 360 degrees, which is something our fingers can't move. So it's quite a unique thing which we have there. And once the instrument is inside, this gets attached and the control takes place from the surgeon's console. So that's the cannula inside, and we are creating a pneumoperitoneum. The telescope is an 8 millimeter telescope, and it's actually got 2 channels in it. This is a robot which gets wheeled in, and what you're seeing is the wheeling in of the robot. The robotic arms are covered with sterile drapes. And this moves over the table to the desired position, after which the robotic arms will get connected to the cannula. And this connection is what is known as a docking of the robot. So here you are getting a docking of the robot which is taking place. And the surgery progresses there. Then we have this illusion. So this is from a Star Trek movie. What you can see, people are hanging from the ship, but the same movement can be also considered as standing. It all depends upon how you look at it. So similarly, like this is an anterior abdominal wall which has been dissected. You can see the 2 recti muscle and a divarication in the center. The telescope is turned by 180 degrees. And we are going from automatic to manual control. And by turning it, you get the feeling as if you are operating on the floor rather than on the roof, which makes it that much simpler to suture. So you can see how the suturing is taking place on the floor, and it makes suturing that much easier when you have a long line to suture. At the end of the procedure, you just turn it back upside down. Then we can do single port robotics by, just like we have sills for laparoscopy, here the cannulas have been inserted all together through a gel port, and the trocars have been docked, and we can proceed with the surgery. So this is a single port robotic which we are doing. Then the future also has what is known as automatic suturing. So here what can be done is, like, we keep the 2 ends of the intestine together and give instructions to the robot that, okay, I want my stitch 3 millimeters from the edge and 5 millimeter gap or whatever you want, and it will suture accordingly. So this will make the suturing that much more accurate, and it will become the same, like 2 surgeons doing the suturing would give you same results. Augmented reality, where we can superimpose the scans onto the actual tissue. There are certain criticisms. One is that is of cost, that it's expensive for patients. Hospitals have a hard time recovering the cost, and this is the Intuitive, which costs about 18 crores. We have newer robots which are coming in. This is a Hugo, and all these new robots which come in are going to actually be cheaper and will change the scenario in the near future. So if I am not wrong, there are about 15 or 17 robots in the pipeline to be introduced. So they all competition is going to be good for us as well as for our patients. This is an SSI Mantra robot, which is made in India, and this is about 1/4 the cost of a Intuitive. It has some futuristic things as well, whereby you know the augmented reality part is easily covered. So this is an open platform where you wear dark glasses and you are able to operate while looking at the 3D screen. There are ways to break the capital barriers, because traditional obstacle was there of the cost, but there are now lease solutions in India where you get the equipment on lease and there is a flexible term for payments. So it reminds me in 1997 when I came back from UK, the mobile phone, this was a large one, it used to fill half of it was out of the pocket, and we used to pay 14 rupees even for incoming calls. And now things have changed. Now this vegetable vendor and my maid who are, benefited most from these technology. Then second criticism is I can do everything laparoscopic. Why do I need to do robotic surgery? So many surgeons could be what we call as super surgeons. But what happens is that the robot, it actually raises the standard of an average surgeon to so-called super surgeon. So many surgeons are able to do complex surgeries which they would have otherwise not attempted, because robot makes it easier. So it raises their standard. And these, because of accelerated learning curve, complex case masteries, so complex surgeries by robotic is learnt much faster than by open or laparoscopic. Then this is an example of an end-to-side anastomosis being done in a mini gastric bypass. Now, an end-to-side anastomosis is quite difficult otherwise to do laparoscopic, and usually you end up doing a side-to-side, which people who do MGB would remember that if you do a side-to-side, you are actually reducing the pouch size by those many centimeters. By doing an end-to-side, the pouch size remains large. So I think time is running out, I'll not go through. So I'm very happy to share that July 2013 did the world's first robotic mini gastric bypass, and since then it's being done at many places, not only in India but across the world. Then time taken is another criticism. Now this is a small clip. Now this is a very old clip. This is from my learning curve days. This is 2013 or 2014. This is the old SI robot, and you can see there is a clock there, and it is showing how much time it takes to dock, because a lot of people have this myth about docking taking hours. You can see arm 1, arm 2 have been docked. Then in those days, as the stapler we didn't have any separate cannula for stapler, so we used to put a 12 mm cannula and put what is known as a cannula in cannula to put in our staplers. And that is the fourth. So all the 4 arms have got docked, and you can see it has taken about 45 seconds. Then time taken for surgery. Now this is 2012. This is a bariatric gastric bypass. I'm just going to conclude soon. Gastric bypass, you can see I was taking 214 minutes. So my anesthetist, operation theatre staff, everybody was very unhappy that, sir, you can do a laparoscopic bypass in 1.5 hours. Why are you taking over 3 hours to do this? And this is 2012. This is from my Intuitive app, the data which is there globally available. 4 years later, you can see the time has reduced to 33 minutes. Now, laparoscopically, I still can't do a gastric bypass surgery in less than 1 hour. So all I'm trying to say, after you cross the learning curve, complex surgeries, you are able to do it much faster than you would be able to do it by open or laparoscopic surgery. Training is there. For training, we have this dual console, and dual console is an excellent thing. It's like training a pilot, where I have control on one side. The left video is of AIMS New Delhi. The right one is of SMS Jaipur, both places where I've been. And it's really wonderful to be teaching someone with this. It really reduces the learning curve. And of course, we have cadaveric workshop of our society, which takes place. This is happening in Chennai a few years ago. where in the cadaver people are getting trained. Now, this I have already mentioned earlier that we have a high burden. So medical tourism, government and private sector push, all these are the drivers which will lead to more robotic surgery coming to our country. So to conclude, new technology is here to stay. We should not be left behind. Priority of the country remains preventive and primary care, but we need few centers with robot where a rational and effective utilization of this technology is done. So when I said I wish I had 4 arms way back then, the wish has been fulfilled, and now we do have robots where you can control all 4 arms. So change is inevitable, growth is optional. We have the robot here. On the left you can see you can use the robot to do puja, or you can open a beer bottle and empty the beer without a single drop being dropped outside. So choice is ours, how we take up robotic surgery. Thank you very much for listening. If there are any questions, I'll be happy to answer.
Wonderful presentation, sir. Thank you so much and for this insight, because yes, the initial hesitation is definitely there in centers who are starting or surgeons who are starting, and they will improve by your guidance, of course, and it will take time, because from 214 minutes to 33 minutes is absolutely remarkable, sir. Thank you. Thank you, sir.
Thank you.
Thank you, sir. I invite our speakers to the right side of the dais to collect the mementos, and even also the moderators for the session to come to the right side and collect their moderators. I now hand over to Dr. Lokendra to conduct the next session.
Good evening again. Before starting the new session, I request chairpersons of this session, please come to the stage. Dr. Neeraj Sharma, Dr. Anustup De, Dr. Ashish Gupta, and Dr. Rajiv Kumar from Surgery, General Surgery. Now, I also would like to invite Dr. Vikas Jain to the stage. Dr. Vikas Jain is a well-known surgical oncologist and working as a head of the department at Service Health City, Hisar. Dr. Vikas is a very good friend of mine. We have worked together at Akash Healthcare Hospital. Please welcome Dr. Vikas Jain.
Hi, good evening everyone. First of all, I would like to thank Maringo Asia team and SSI Mantra to give me an opportunity to speak on the surgical video presentation for robotic radical esophagectomy, which we specifically mentioned the azagus preserving, because many people used to divide azagus to give the lymph node clearance, which is actually not required. So today, I will not discuss about the full esophagectomy because of the time of the duration of the surgery, which is a long-standing surgery, and I'll discuss about only the thoracic part and esophagus mobilization, transthoracic. For the radical esophagectomy, we give under general anesthesia with central and access single lung ventilation. We always use double lumen tube, why people are doing with the single lumen also. Well-hydrated patient in left lateral semi-decubitus position, as I have shown in the figure. This is our port position. Previously I was using other systems, and now switched to the SSI Mantra, but on and off used to keep the same port positionings with SSI Mantra also. 2 working port in the posterior axial line in the 7th and the 3rd space, and 1 camera port in the 5th intercostal space in anterior axial line, and assistant port in 9th intercostal space. Most of the surgery we finished by the only 2 instruments. One is the bipolar grasper and the monopolar Caesar. Rarely we require any vessel sealing devices or the hemoclips. I will not discuss the detail about the lymph node dissections, but most of the cases for us is the lower esophagus. So we do the lymph node dissections and I will explain the lymph node stations, what we are doing in the esophagectomy. So this is a case of lower esophageal growth post NSCT and RT, and we do the salvage esophagectomy after neoadjuvant therapy. The first steps goes for the inferior ligament division, and along the inferior ligament we have to remove the station 109 lymph node, which is along the inferior ligament and along the right bronchus. Then we proceed from cranial to caudal and keep on dissecting along the paraesophageal tissues. We remove all the lymph nodes along the mid-esophagus, that is station 108 lymph nodes in the paraesophageal mid-esophagus. The lymph node dissections along the esophagus is mainly the paraesophageal. We don't need to remove the extensive mediastinal node, but it is the paraesophageal which remains along along the pericardial tissues. This pericardium is being cleared off, and this lymph node station, what we are leaving behind, that is the last part of the surgery, what we used to remove at the last step, that is subcarinal lymph node. This is the right bronchus. Sorry, the marking has been little bit moved with the movement. So this is the subcarinal nodes which we will going to remove at last, and we are removing all paraesophageal lymph nodes. Then slowly we progress cranially towards the azygus, the arch of azygus, and after finishing this step, then we go, we give a posterior pleural cut. This is about 1 centimeter away from the azygus, because if we remain very close to the azygus, the risk of thoracic duct injury is quite high. So 1 centimeter gap difference from the azygus vein is quite good. These are the small blood vessels which previously we used to clips, but with the robotic surgery and the good coagulation devices, we don't need to ligate this esophageal supply. This is the segmental blood supplies comes from the aorta. So these used to be coagulated by bipolar. Posteriorly, this is aorta. Then we have to dissect the esophagus circumferentially so that we can make a sling, we can make a space and sling the esophagus. So this is a window. As soon as we get that window, we can put a gauze behind the esophagus along the pericardium, and we make a space around the esophagus. This is the opposite side of the lung and the pleura, which has to be preserved so that there should not be any rent in that pleura. Otherwise, we have to put an additional tube on the opposite side thoracic cavity if it is a big rent. Sorry. Okay. So the next step is along that window, we have to use a sling which can be used from this our 15 by 15 mop sling that is sufficient to loop the esophagus. And with that window, an assistant from the accessory port can retract the esophagus, anterior, posterior, whatever dissections we want to go. And now we will proceed towards the crus of the diaphragm, which is the station 110 lymph node, that is the lower paraesophageal lymph node, and 111 is along the diaphragm. So this is the crus of the diaphragm, and all the lymphatic tissues along the diaphragm is being cleared off. This stomach mobilization was done as a first step, so we can see the stomach was being pulled up in the thoracic cavity. Then we proceed again cranially. And the lymph nodes are being taken towards the esophagus as a specimen, and these small blood vessels will get coagulated. Now we can find out the well-defined planes where the lymph nodes is being with the esophagus, and we will not damage the opposite pleura as well. So this plane will get opened. The subcarinal node we will remove separately, and esophagus is being mobilized. Now we have reached up to the azygus. Why we want to preserve the azagus? The main function, main reason of being preservation of azagus is that in this region where I am dissecting here, the bronchial vessels travels just beneath the azagus vein. If we are preserving the azagus vein, we can preserve the bronchial vessel. So that this is very important for the preservation of bronchial function. This is again a critical area where the chances of thoracic duct is quite high, where the arch of the azagus is being taking turn anteriorly. So this is being lifted off and we can dissect beneath the azagus. And this is the benefit of the robotic surgery or robotic instruments, where we can get the curve and we can lift the azagus with an angulation. And we can divide the attachments behind the azagus vein. After that, we'll go for the supraazygous part of dissections, where we make a pleural incision along the trachea and the esophagus. This is the posterior pleural cut, and the lymph node stations along the supraazygous esophagus is the station 105. So here the lymphatics from the azagus vein is being cleared off and they are being taken with the esophagus. So this is the esophagus, supraazygous esophagus, and level 5 lymph node dissection is being done. Through the same movement we can reach up to the neck, and even in extensively, if we want to go, we can go up to the thyroid vessels also through the thoracic cavity itself. So these are the tracheoesophageal lymph node dissections or paratracheal lymph node dissections, which is 106. Here we have to be very careful because the membranous part of trachea is there. So one of our assistants keep to retract this trachea with the suction or any grasper, so that we can make a plane easily between the trachea and the esophagus. And after this esophagus mobilization, the remaining fibers behind the azagus vein is being divided, so that we can get a Shusai maneuver and a freely mobile esophagus behind the azagus vein. This is the trachea, where we can see the membranous wall is being collapsing. And as a last step, I'll finish to show the subcarinal lymph node dissections, which we have left behind. This subcarinal lymph node is being dissected at last. We used to prefer these dissections at last because there's multiple small tiny vessels goes along these lymph nodes, and it makes our field quite oozy. So this lymph node dissections of level 107, we used to do it at last. So this has been cleared off. So with that, I've mentioned only the 2 studies which is relevant for the esophageal lymph node dissection, especially with the robotics, is the RAMIS trial. RAMIS trial is for the squamous cell carcinoma in the esophagus, which has already proven that with the practice, as Dr. Arun Prasad has also shown, that the shorter operative duration with learning curve, robotic esophagectomy can be done in shorter operative duration in comparison to the conventional laparoscopy. And definitely for the oncological outcomes, lymph node dissection is much better when we are going it with the robotics, while there was no significant difference for the blood loss or the conversion rate. Again, in the Robo 2 trial for the esophageal squamous cell, esophageal adenocarcinomas, the same parameters have been included, but the results are awaited for that. What the benefit of preserving azagus vein is definitely, it is a natural venous drainage system, so it preserves the renal perfusion with that outcomes and maintain the gastric conduit in midline positions. After esophageal dissection or azagus vein division, we many times see that the conduit get transferred from the one right side, so patient feels some heaviness in their chest. Again, it preserves the bronchial artery, hence the bronchial ciliary functions also can be preserved, and indirectly the atelectasis rate is quite low when we are preserving the azagus vein, where there is no oncological compromise with the lymph node yield is better when we are going for the robotic surgery. So at a conclusion, what we should divide the azagus vein only if we have to And in the last 3 years, if I remember, we have divided the azygosis vein only in 3 cases. One, the esophageal growth was adjacent to the azygosis vein with some quite adhesive to that azygosis vein. And another case, if I remember, there was some problem with the intubation. So the cuff was quite inflated in the bronchus and there was a bronchial injury. Because of that cuff, we took it as a lymph node. And for repairing that bronchus, we divide the azygosis vein. So most of the time, we don't need to divide the azygosis vein. Thank you. And as a secretary of the TROGS committee, this is a Global Robotic Surgical Society. I'll invite, if anyone want to join it for free, you can join us. Thank you.
Thank you, Dr. Vikas. Such a wonderful presentation, a very nice dissection of the esophagus. Thank you so much. Next, I would like to invite Dr. Amitabh Singh to the stage. Dr. Amitabh Singh is a distinguished uro-oncologist and robotic surgeon working at Rajiv Gandhi Cancer Institute. Please welcome Dr. Amitabh Singh.
So, thank you, everyone. So it's my honor to be here because I think the Maringo is doing very great work for the robotic surgery. I can remember that day when I started the robotic program with SSI Mantra with Colonel Sood sir at Maringo Asia. And it's very great news that they have completed more than 200 robotic cases at their hospital. So Monga sir has just called me for the presentation. Then I gave that I think there are many takers for the robotic prostatectomy, cystoprostatectomy. Then I thought just better to go for some very rare malignancies, a rare procedure for the robotics, so that we can expand our spectrum and we just can understand that what are the real advantages of the robotic surgery for very complex surgeries also, and they are feasible also with the robots. So I chose the robotic nerve sparing RP-LND for some purpose. So because this testicular tumor, I think it is not a very common malignancy, but it's very peculiar because it involves very young age group patients. And the RP-LND is a very important part of the treatment for the testicular tumor. And few patients, they underwent primary RP-LND and few patients, they underwent post-chemotherapy RP-LND if there is any residual lymph node into the retroperitoneum after getting chemotherapy. So now the important thing for the RP-LND is ejaculatory function. So if the nerves are not spared, then they will have a retrograde ejaculation. And it is very important to understand because most of all these patients, they are young patients and they do care about their ejaculation. So that's why I chose this video to give emphasis on the neural anatomy of the retroperitoneum and how to preserve them for the RP-LND. So this is just retroperitoneal anatomy for the postganglionic sympathetic fiber. So we do have a sympathetic chain on the right side and the left side. Then we do have postganglionic sympathetic fiber coming from the both side behind the IVC, and they are merging across both sides on the anterior surface of the aorta. Then they traverse down, they form this superior hypogastric plexus. Then they diverge into the pelvis, they form inferior hypogastric plexus, and they intermingle with the parasympathetic fiber of S2, S3 and S4. They form pelvic plexus and then go for this prostate, bladder and all these pelvic organs. So this is a arc basically, which is very important to understand for the ejaculatory function. So there should be a very well coordinated actually stimulation has to be there for a proper antegrade ejaculation of the semen. And we should know that there is a basically bilateral cross innervation. So even if we injure one side of all these nerves, these patients, they do have antegrade ejaculation. So this is a very simple thing. If we transect the spinal cord about T10, still they will have antegrade ejaculation because the local reflex is active. Just they need some kind of stimulation through a rectum vibration or whatever. If we even injure one side of inferior hypogastric plexus, they will have antegrade ejaculation. But suppose if you will injure both sides sympathetic trunk and superior hypogastric plexus, then they will not have antegrade ejaculation. Again, coming to the RP-LND. So now open RP-LND, laparoscopic and robotic RP-LND. So laparoscopic RP-LND is just a diagnostic RP-LND. It is not a therapeutic RP-LND. It is very important to understand. So if we want to do RP-LND for a therapeutic purpose, either go for open or robotic. But there is a difference. So on right side, there is an open RPLND with midline ugly scar from the G5 to the pubic symphysis, whereas the same surgery has been done with the robot with very minimal scar. And these patients, they are young patients, they do care about their cosmesis also, along with the antegrade ejaculation. So robotic RPLND can be done with the lateral position also, supine position also. So I started in 2015 doing robotic RPLND at lateral flank position. But now I am doing with supine position. So patient is being placed in supine position and robot is being docked either from the head end or from the side end, depending on the type of robot. If you are doing with the SSI Mantra or Da Vinci SI or X, you need to bring the robot from the head end, or if you are doing the robotic RPLND with the XI, you can do the side docking also. So this is some anatomical, you can say surgical steps. So we just do split and roll. We divide the lumbar vein, we lift the IVC, we see the neural anatomy. All these nerves, they go over the anterior surface of the aorta, they form the plexus, same on the left side also. So this patient actually had a testicular tumor, mixed germ cell tumor. After getting 4 cycles of chemotherapy, his tumor markers came to normal. CT showed there are few retroperitoneal lymph node, almost 9 mm. We had a tumor board discussion because is there any real advantage of doing RPLND for this patient or not? Then we got decided for the RPLND because this patient has a teratoma component in the primary tumor. So there could be teratoma in these retroperitoneal lymph nodes. So we decided for the robotic RPLND and we just planned for the robotic RPLND. So this is just a small video for robotic nerve sparing RPLND. So I always start with the mobilization of a small bowel mesentery. So this is a small bowel mesentery. On the right side, this is sigmoid bowel mesentery. So once you mobilize the sigmoid small bowel mesentery, you see the inferior vena cava anterior surface, you see duodenum, you see DJ flexor also. If patient is thin and you just do very enough mobilization and you lift the pancreas, then you can see the superior mesenteric artery like this. This is superior mesenteric artery. And once you define the lateral border of this robotic RPLND, you should see the right side of the ureter, you should see the left side of the ureter. So now you see the right side of the ureter. Now I am going up to the upper boundary of RPLND dissection. You are seeing this right renal vein just draining into the IVC. Once I am done with the small bowel mesentery, I will start mobilizing the sigmoid descending colon mesentery. So I'll just dissect, I will try to see the left ureter to mark the lateral boundary of RPLND. This is inferior mesenteric artery which is come into the field. So if the mass is large, it is complex mass, then you can sacrifice inferior mesenteric artery. But if it is like not necessary, you can save it also. So just after defining the lateral boundary, upper boundary and distal boundary of RPLND, I take this hitch stitch on the both side mesentery just to have a proper exposure of the retroperitoneum. So I take 30 centimeter vical suture, one hemolog clip at the end, take few sutures through the mesentery and tuck them to the anterior bowel, anterior abdominal wall. So same on the left side also with the descending bowel mesentery, take vical suture, take them with the anterior abdominal wall and retract them upward and laterally to expose the retroperitoneum. So once your retroperitoneum is exposed, you start with the split and roll technique. So here I am just telling my resident fellow the anatomy. So just I will start with the split and roll technique because you won't find any postganglionic sympathetic fiber on the anterior surface of IVC. So that's why we always start split and roll from over the IVC. So just dissect all these lymphocytic tissue after coagulating them, and you just start from the distal part of your boundary to upper part of your dissection boundary of RPLND. So once you see the draining right renal vein and left renal vein, you just start focusing on identifying the lumbar vein which are draining into the IVC. You lift the IVC, try to identify all these lumbar vein one by one. So usually there are 3 to 4 pairs of lumbar vein which drains into the IVC, and these pairs, they are on the both side of the IVC. So, but they are not in the symmetrical position. So it means like if you found this lumbar vein on this side, diagonally opposite, you will not, it's not necessary that you will find the lumbar vein. They can be higher or lower also. So once taking these lumbar vein one by one, lifting the IVC with your bipolar forceps, try to proceed up to the hilum. So you will always find a lumbar vein at the hilum of the kidney, and usually these are the thickest, largest lumbar vein which are draining into the IVC. So once the dissection has been done,
you dissect the fat, lymphofatty tissue to identify the sympathetic trunk. So now you can see this white band actually, which is just running into this lymphofattic tissue. It is a sympathetic fiber of the sympathetic trunk of the right side. And you can see all these very fine small nerves, which are exactly the post-ganglionic sympathetic nerves, which are arising from the sympathetic trunk. Now there is a swelling, which is exactly a ganglia on the right side, post-sympathetic ganglia. So once you have identified the sympathetic trunk, you divide these the last remaining lumbar vein, which is draining into the IVC. Now you can see the left renal artery also down below the left renal vein, which is going towards the right side kidney hilum. So once this dissection is done, I start dissecting the paracaval lymph node after applying a hemolog clip, because in RPLND the chylous ascites and chyle leak is a very actually big issue. So if you are not taking these lymphatics, then you will have very high incidence of chylous ascites and chyle leak. I have seen one patient even after 1 year of doing RPLND with chylous ascites actually. So you need to be careful. So once this paracaval lymph node dissection has been done, I need to retract this IVC. So I use this technique. I take this vascular tape encircling around the IVC. I lift with my progress forceps. So now I will focus on dissecting the postganglionic sympathetic fiber. So now this is sympathetic chain. These are the L1 and L2 postganglionic sympathetic fiber, which you can see very easily. So there is anatomy. If you have that anatomical knowledge, and if you want to look for that anatomy, you will definitely look, you will definitely see these anatomical landmarks. So now once you have dissected these sympathetic fiber, so I'll just mobilize this lymphopatic packet from the aorta, from the lateral surface of the aorta. Now I am dissecting it from the left renal vein. Here again it is very important to apply the hemolog clip sequentially to prevent the chylous ascites or chyle leak into the post-operative period, because this is a very important, you can say, the anatomical location where all these lymphatic, if there will be an injury, these retropancreatic lymphatic, they will cause the chylous ascites and chyle leak. Again, it is very important to understand, because all these lymphofatty packet, they are intertwined between all these lymphatics, postganglionic sympathetic fiber. So you have to be very gentle with your dissection. Try to see every structure bit by bit carefully, and clip them if there is any lymphatic, very big lymphatic, and dissect the lymphofatic tissue also without injuring all these critical structure. So this is one part of interaortocaval lymph node which I have dissected. Posteriorly you can see this anterior spinous ligament also. So this is the part of lymph node which is between the L1 and L2 sympathetic postganglionic fiber. So here I will do just kind of berry picking sort of dissection, identifying this thing. So now you can see this lumbar vein which is going through this lymph node packet. So you identify, you clip it so that there should not be any bleeding, because you need to understand this is a very limited space. If you will not identify these veins, they bleed a lot like a hell. So you need to increase the pneumoperitoneum, then you need to stitch them. So that's why you need to be slow down when you see the critical step, or if like is there any difficulty with the dissection, try to identify them and dissect it carefully. So now I have just dissected this part of the lymph node while preserving all these postganglionic sympathetic fiber. So now after completing the interaortocaval lymph node and pre and paracaval lymph nodal dissection, I will move on the left side. So now because this patient has a left testicular tumor, so the main drainage actually was the para-aortic site, and he had the lymph node also on the para-aortic region. So here I will not be able to save too many nerves, postganglionic sympathetic nerves, but still I am very happy because I have preserved the postganglionic sympathetic fiber from the one side. I have been able to preserve the superior hypogastric plexus, because the tumor control, cancer control is the most important thing. So here I am dissecting the para-aortic lymph nodal packet. So I will be doing this dissection in part actually. So just try to see the left renal vein first. Try to identify the draining gonadal vein, left-sided gonadal vein into the left renal vein also. So once the lateral border of the aorta is defined, you can see the left renal vein, you can see the draining gonadal vein into the left renal vein, and you can see the renal hilum also. Then you can be fair confident, then you can go for the left part of the dissection, trying to see the psoas muscle. Again, you need to see all these lumbar veins which are again going across all these lymphofatic nodal packet. Again, applying a hemolog clip at the distal part of the lymph nodal packet, para-aortic lymph nodal packet, and I start my dissection of this packet caudally, cranially. And these are the, actually you can say the veins which are going into the lymph nodal packet. So this is a very complex anatomical area, the retroperitoneum. So you can't presume, you can't be confident always about the anatomical. There can be lot of variation actually. So you need to be very, you can say meticulous, you need to be very careful while dissecting this space, especially retroperitoneum. So these are the actually, just I am about to finish, 1 second. So this is the part of, you can say all these small lumbar arteries or small arteries from the aorta which are going into the lymph node, which these are the veins which I am clipping. Again, I will be just sacrificing the postganglionic sympathetic fiber, but I will try to save the sympathetic chain at least on the left side, so that even because the studies has shown that even if you sacrifice L1, L2, and if L3 is preserved, then still these patients, they can have a antegrade ejaculation. So I know this is the gonadal vein of the left side, which is going to the left renal vein. I am sacrificing it, trying to this is the lumbar vein actually from the left side, which is draining on the paravertebral plexus, venous plexus, going towards the renal hilum, left sided renal hilum. Oh, sorry. Okay, so finally I completed this procedure, and the histopathology came that there was no positive lymph node on the interaortocaval lymph node, no node was positive in the pre and paracaval. There were 2 nodes which were positive for the pre and para-aortic node, and they had teratomatous component actually. So that was our concern. So that's why we went for the RPL-ND. Because these patients, they can have a secondary malignancy transformation, they can have a growing teratoma syndrome also. So that's why if there is a teratoma component in the testis, and if there are lymph node into the retroperitoneum after the chemotherapy, even if they are like 1 centimeter of the size, you should do RPL-ND in this patient. And this patient had a antegrade ejaculation after 1 month. So we served all purpose of doing RPL-ND. We preserved the antegrade ejaculation, we preserved the cosmesis of this patient. So thanks for your patience hearing. Any question?
I would like to ask you like the problem with the mantra system, or a difference in mantra system is like we have 4 arms which come rather than a single boom. So if we are doing RPL-ND on a mantra, then do you keep the patient lateral, or what position do you use once you?
So I did only, honestly speaking, I did only 1 RPL-ND with the mantra system, sir, and that patient was carcinoma urinary bladder. He had retroperitoneal lymph node to begin with, but he got chemotherapy NSCT, and somehow he responded very well. After 4 cycles of chemotherapy, he didn't have any residual disease on the PET scan. So I decided to go for a radical cystoprostectomy with RPL-ND also. RPL-ND I decided just to see whether there is any microscopic disease in the lymph node or not, because they can't be picked on PET scan. So I just docked all the arms from the head end, just like we docked the SI or X Da Vinci for RPL-ND. So we just bring the arms from the head end, and I was able to complete the RPL-ND, formal RPL-ND. It was not only diagnostic, I did complete RPL-ND, and the nodal yield was almost 25 lymph node, including everything. And all of the lymph nodes were free. So you can do RPL-ND with the mantra system, but I think to begin with, your patient should be very good, like tall patient, not very obese patient, having a good space of abdomen, because the retroperitoneal anatomy is very different. If you will have any vascular injury, and then you will start suctioning, your Nemo will go down, then it would be like a terrific day for you. So ideally choose your patient very carefully to, if you want to start with the robotic RPL-ND.
Thank you very much.
RPL-ND is a very complex and challenging surgery, but beautifully presented by Amitabh sir. Now I request Amitabh sir, Dr. Vikas Jain, and chairpersons, please come towards the right side of the stage to collect the mementos.
Next step.
And I request next set of chairpersons kindly come to the stage. Dr. Rajiv Sood, Dr. Manish Chaudhary, Dr. Saurabh Joshi, Dr. Ujjwala. Please come to the stage. I also would like to invite Dr. Manav Suryavanshi to the stage. Dr. Manav Suryavanshi is a well-known name in robotic urology. He is the head of the Department of Urology at Amrita Hospital, Faridabad. Please welcome Dr. Manav Suryavanshi.
Thank you to the organizing committee and Dr. Ritesh for inviting me and giving me this platform. As you can see, my core area of competence and interest has been robotics and uro-oncology. And I started doing robotics in 2008, and we established the first successful robotic corporate urological program in Fortis Vasant Kunj, and then moved to Medanta and then in Amrita over last 4 years over here. And I'll take you to an interesting topic. This is not about technique. You see, I'll talk beyond technique today. Maybe you can take it as a little bit of a philosophical lecture, but then it's about the judgment, landmarks, and reproducible outcomes. And I'll show what exactly do I mean. So when you talk about complications, you know, they actually start with small decisions. And when we are talking about the bladder neck continence, ROCOs and stuff, my concept has been bladder neck judgment decides continence, pure, simple, most important factor, 90%. And reproducibility separates your experience from the expertise. Why does this bladder neck size matter? Because continence belongs to the bladder neck. And the difficulty is not proportional to the gland size, as people say. Bigger the gland, most likely you will have simpler planes. And reproducibility in each case is better than brilliance. And your dissection has to anticipate reconstruction that you are gonna do. And this masterclass is about an anatomy, decisions, reproducibility, and difficult situations. It's not a tutorial, it's not a platform comparison, it's not a benign prostate discussion. And what makes a bladder neck creation difficult? The larger glands, especially the 100-gram or more, very small glands, because you have a sense of false simplicity. Median lobe distortions, closer ureteric orifices, post-UR or inflammatory cases. And what is the philosophy you see? Reconstruction has to be decided before your dissection begins. You have to preempt the situation. And bladder neck is designed, you do not discover a bladder neck. So the landmarks that I trust, there are fixed versus variable cues. I look at the detrusor fiber dissection directions, prostatovesical angles, posterior lip behavior, and Foley's traction response. So if I show you, this is a 125 gram or more gland, maybe 135. And I'll take you through this small clip. You can just see, if you just work patiently through the Foley's traction, and I went into a wrong plane initially and I rectified it. I came back close. And then I dissected the intraprostatic urethra over here. And I can show you even in a 135 gram gland, you can create a bladder neck that is as small as the tip of your fingertip. People talk about the Redges sparing technique. You can exactly do the same thing from the anterior direction if you have just worked your way through your mindset through it. And once the dissection is done, I have a paucity of time, it's a 15 minutes lecture. You can see it is just a thimble neck. So a slow, bilaterally symmetrical lateromedial approach was done, and early confirmatory clues led to the creation of a small bladder neck in a 140 gram gland. And when I come to the vesicourethral anastomosis in this gland, you can see the ROCO primarily, I do not know if it helps you in continence or not. It surely helps you in alignment. Today I can do a perfectly watertight anastomosis without a ROCO. But if you have to do a watertight anastomosis for first 60 or 80 odd cases, do a ROCO. It just makes your life so much easy. I realize over here that there's a step, despite it being a watertight, I take a 5-0 PDS, I remove that step. Because I do not want my patient to go, I have patients who can go into retentions post-anastomosis. And that is because of these small steps that have been created. So this is a desmoplastic case. Most of the patients we receive today have got 1 or 2 hormonal shots, but yet it's an Afro origin. So you see it's fibrotic, yet it bleeds so much. But at the end of this half-a-minute clip, you will see that it's again a thimble or a tip-like, small tip-like bladder neck. Because you have to just believe that consistency has to maintain under distortions too. So just see the patient dissection, the identification of the urethral stump at the bladder neck, and again a creation that is almost 0.5 millimeters to 8 millimeters of a bladder neck. And this is what is giving us continence at the catheter removal or within first 6 weeks together. So to say that a Redzius sparing outscores is a fallacy. I can show you with the uroflowmetry results that an anterior approach is as much as good as a Redzius sparing, and the data today backs it. So your tissue feedback in such scenarios has to replace the visual cues. What is the concept of a tissue feedback? You have to look at the resistance pattern of the tissue. Your fibrotic or wrong planes feel stickier, resistant and rubbery. And if your tissue is mobile, it glides, it separates with gentle traction. You are right there. Your energy responses in correct planes, you actually do not need to use cauteries. You are using more and more cautery. It's not a difficult case. You actually have to reset your mindset to the right plane. Your instrument feel, the tension behavior, the stretch responses, the brittleness of tissue. So experienced surgeons actually subconsciously read these signals, but they don't realize what's happening in their mind. And exactly if you see what I did not change even when the case was bleeding, it was my patience. Rather than you will notice a surgeon rushing through his case when the case is getting wrong, I go slower on it. I take a deep breath. It's like a yogic technique. You do not let your respiratory rate change and you get the same result. So I can show you this is a fibrotic case and exactly the same bladder neck and the same kind of an anastomosis. But I have many concepts to show, so I'll skip this video for now. Unfortunately, I do not have a complete recording. A 17-gram prostate. In fact, I had a doubt whether this patient has come with the prostate today to the OT or not. Once I dissected it, but yet you can see how beautifully, just by identifying the landmarks, I get an anatomical negative margin prostate out in this case too. So till this time, I did not know whether I'm into a prostate or what am I doing. Those critical steps were not recorded, unfortunately, due to software malfunction. But here is the prostate, correct apex, good stump, good nerve dissection, all negative margins, and a good patient back home. And these easy cases are actually dangerous, because there are deceptively clear landmarks. You have an over dissection risk, and there's a higher risk of sphincter compromise. So another case, large seminal vesicles. So the concept is this patient had unusually large seminal vesicles. So at the tip of the seminal vesicle is the area where you will actually end up injuring your ureteric stumps. So what I do is I use minimal cauteries over here. I peel the tissue out of the denonvillous fascia. You will see that you don't even need to actually cut through it. You can just peel off the denonvillous fascia if you're in the correct plane. It just slides off it. Not necessarily in every case because we have a lot of inflammatory cases in India, but surely in many cases. So when it's a large seminal vesicle, the traction alters your perception. You simply cold dissect lateromedially to protect the ureters. Come from lateral to the medial side, as well as the nerve stand protected at the tips and the ureters. Make the SV come towards you rather than you going towards it. Peel it, pull it out of the denonvillous fascia with focal cautery usage. So here just see how close the ureteric orifices have been. These are the ureteric orifices. So what did I do? I just took a finer suture. I did the Lamberting sutures where there is more of serosa and less of mucosa in the intestine. So more of bladder fibers and just the margin of mucosa in the bladder. So I protected the entire orifices and got an exactly same vesicourethral anastomosis at the end of the day. While people would make tennis rackets, fish mouthing, nothing. Simple cheating on the bladder side and then fine sutures on the urethral stump to avoid pursing. So your safety actually has to always override your elegance. Your elegance means a perfectly small circle. But the day I realize that there's a risk, I go an extra millimeter to avoid a risk of ureteric injury, to avoid causing ischemia at the distal margin of the tissue. Because the ischemic tissue or when we say brittle, chhichade jaisa jab tissue ho jata hai, the continence is always poor. So you don't compromise on tissue quality. Slightly larger bladder neck will still give you a viable bladder neck. So in post-ADT cases, safety means stop when it is oncologically appropriate, not when it is visually satisfying. Accept a wider excision in these cases. In case of neurovascular bundle dissections, you will widen the margin rather than chase a pretty nerve plane in case you are suspecting a locally advanced case and a positive margin. And I've been able to get practically very low margin rates because of this, because oncology is the first principle rather than symmetry. At the apex, you sacrifice a millimeter margin of safety because apex is the area where the prostate will have the highest margin positivity. So at the end of the day, I'm not suggesting that you be obsessed with perfect circles or perfect symmetry. Always aim for tissue viability, oncological soundness, and functional balance. So it's somewhere a life in a moderation, like the Buddhist concept, it's a balance. So what's the neurovascular bundle philosophy? You have an incremental dissection, no sweeping releases, stay in the plane of veins. I'll show you that track. It's simple, thin veins. You cut through them, you are saving the nerves. You see them or don't see them. Avoid energy spreads, progress millimeter-wise, and no blind tractions. And this is what you will see. So just gently peel it off, cut it millimeter by millimeter, accept some extra blood loss, don't use too much cautery, pinpoint coagulation at the time of arterial stubs over there, and you can see, you can actually get beautiful neurovascular bundle planes preserved at the end of the day. And then I have done every kind of an approach. Now I handle the DVC first because it's a strategic decision. It improves exposure, it reduces our apical distortion, it allows your deliberate urethral dissection, and it improves the intra-abdominal urethral stump length, the second most important factor. You can have 1,000 publications. You have these two factors well, your patient will be continent, whatever be the other factors. So the DVC is being controlled. There's a hood technique being explained. So you go close to the apex, but you go as close as you know the mapping of the biopsy. If you're suspecting a positive margin, then it is better that you don't go that close. And you see, I'm not allowing my assistant to suck over here. He only irrigates. And as he irrigates, I get a more clear vision. Only few drops to get perfect exposure, perfect apex, perfect cut to the urethral stump. No suction at all at this point. People think they will suck more, they'll have a clearer vision. It's contrarian. Don't suck. It's like a contrarian mutual fund. At the apex, dissect always strictly under vision, no blind urethral transactions, respect sphincter length, and there's a highest risk of margin positivity. So be very careful about this. So now you see everything is being done in vision, controlled cases. Every direction has been dissected, all bundles are separated, and everything is cut millimeter by millimeter. There is no chance of margin positivity in such scenarios if you do it patiently. An extra 5 minutes and the job is done. And urethral length is as important as the bladder neck. A controlled apex gives you a tension-free anastomosis. But then a small bladder neck creates a new problem, you see. You have to do a watertight anastomosis, and sometimes I can't find the bladder neck. So posterior reconstruction is not optional. It makes your learning curve easier. It brings out the bladder neck. It shows you the margins. So see, this is just a tip of a small finger kind of a bladder neck. And once you do the ROCO, the posterior lip simply brings it out. You don't need to find it again and again. So why not do an extra layer when it is making your life easier? And the only way to do a case fast is to do it slow and correct the first time. So my average time to a prostate is 1 hour, 10 minutes, 15 minutes, because I just never skip a step. I've just removed my non-ergonomic movements. From 3 hours, 30 minutes, I've come down to 1 hour. And my yields are as high as they were always. So strategic arm positionings, controlled tractions, respecting posterior support, and letting the anatomy present itself. A metastatic case, obviously I knew it post-op. Though there were some suspicions on the PSMA, yet you have the same bladder neck, same results. It's just tip of a finger bladder neck. So anyone claiming that a Retzia sparing approach gives you a smaller bladder neck is not then exactly going through the principles. What can be done from your back can be done from your front too, because the anatomy is same. So when I say you make the anastomosis watertight without strain, how do you do that? Instrument tip and the needle angle is the real trick. Men in India have smaller pelvis, android pelvis, bony islands. You just hold it at a 35-degree angle to your pincer grasp. अपना हाथ देखना है, उसमें नीडल पकड़नी है, exactly वो replicate करना है robotic instrument की tip पे. And you will have a perfect non-purse string, perfect vesicourethral anastomosis, and I'll show you what do I mean by that. Anyway, I've shown you the anastomosis. This is a final leak-proof confirmation. I do not need to put in a drain actually for last 4 or 5 years. I do put it because sometimes I have manpower constraint and I just want to sleep peacefully. So why this sequence matters? You have a small bladder neck, you get a controlled exposure, you do a stable anastomosis, and you get a better early continence. So when a person is writing less in an exam, 2 people write less, one who knows everything, one who knows nothing. So when you know too many things now, you know that it's just a simple life. Simple steps, simple results, consistent results, precision is reproducibility. So my mental framework is predictable anatomy, identify fixed cues, design bladder neck, re-expose deliberately, reconstruct without tension. The only one line I want you to remember, robotic prostatectomy is not about how fast you dissect, but how early and how consistently you decide. Thank you.
Thank you for a lovely presentation. The point that I want to make is, once you have a driving license, you can drive a car of any company. Of course, basic skills are required. However, experience is what brings about the judgment, and which is what makes your talk so enjoyable, because sharing your experience across those critical steps is the take-home message. And I think it was a very exhaustive presentation and a very nice presentation. Thank you very much.
Thank you so much, sir. My pleasure.
Manav sir, I have one question. How do you judge in cutting the neck in a small prostate?
Okay.
Less than 30 grams, because you cannot feel it.
So I'll give you the trick.
You
I'll give you the trick over there. More frequent Foley's traction to look at the vesicoprostatic angle. Your fourth arm always holding the fundus of the bladder, which is not in your vision, and this is not a static arm. Usually your fourth arm is static because you will toggle it and put it static. The moment I dissect 1 millimeter, I'll again pull it back. The moment I dissect 1 millimeter, I'll again pull it back. Secondly, the pressure will go from 15 to 20 for these 5 minutes. Thirdly, my assistant cannot suck at this time. He can simply throw a few drops, and that also is not in my vision at the roof. So the fourth arm is outside vision, the irrigation is at the roof, and these two in tandem are the dynamic components which people think are static, and these are what bring the results. Fourthly, you go from lateral to medial, bilaterally symmetrical, keep narrowing down, and just try and find that 2-3 millimeters of stump of the urethra at the bladder neck, which is going into the vesicoprostatic angle. And you will always get a bladder neck that is as the size of a small finger.
Sir, regarding the prostatic pedicles, nowadays nobody clips it. Simply they burn by bipolar and leave it. So you have any experience? Because I assist you in Medanta and you clip it. Now you have changed your technique or not?
No. I'll answer it another way. At the tip of the seminal vesicle, I'll clip it because there are bladder neck fibers. And even if you take a thicker chunk of tissue, it will not make a difference. But the moment I go farther up, I'll peel it and do a point coagulation. But occasionally, I cannot get away by doing a clipping because sometimes I will still need to use the clip. There may be days when I feel it is getting too close to the neurovascular bundle. I'll accept the bleed. I'll take a 5-0 PDS. At the end, I'll underrun it in a superficial manner.
Thank you, sir.
Thank you.
Dr. Manav, nice presentation. One basic question. If in case you have to do bladder neck tailoring at the end, what do you prefer, fish mouth, anterior or posterior racket angle?
So I have done every kind. Honestly, it depends upon the mood of the day. But I usually now end up cheating in such a beautiful manner that I do not need to do a fish mouthing. I would always keep it extremely close on the urethral stump. I'll keep it 3-4 millimeter separated on the bladder neck. And the last stub of 5 millimeter is the one that I'll do a tennis racket.
I mean the anterior one.
Exactly. So a small tennis racket, but I'll just cheat through on the side the way we used to cheat in our intestinal anastomosis.
Sir, cheating doesn't fold the bladder neck and it causes narrow UV anastomosis.
So I'll answer that question for you. You missed out on the point. On the urethral stump, my sutures are almost millimeter by millimeter close. So the purse string effect happened in laparoscopy because we would get tired, we would take less throws, and they were wider apart. The closer the stump is on the urethral margin, it will not cause pursing. And if some pursing is happening on the bladder neck, you want it to happen because your bladder neck is wide.
Thank you, sir.
Dr. Manav, Dr. Ritesh. Yeah, here. So, excellent presentation. So, I would like you to talk a bit about the ureteric injury, means a big median lobe or the ureteric orifice just close to the bladder neck. Is there any cases where you think of stenting before or something? Or
So, Dr. Ritesh, we have stented a couple of patients in 2009-10. After that, we have not needed to do that. I have had my teammates do a couple of ureteric injuries wherein we had to do a ureteric anastomosis alongside the robotic prostatectomy. That is why I made a point. Do the posterior first technique. It's simpler to start with. The most difficult step is done first. Your rectum is separated. Stay bang in midline. Do not go on the sides. Once you're going to the sides of the SV, pull it, peel it, and move from lateral to medial rather than medial to lateral. The moment you move, peel the tip and start moving from lateral to medial, your ureter is already left away. When I do the lymph nodes, I'll make the same point. I go to the external iliac artery and vein, my instrument will move like this to this, towards the bladder. It never moves like this to this. So that is what I tell my students also. The moment you do this to this, you're away from the zone of injury. So by touch wood, by God's grace, over the last 7, 8, 10 years, probably no injuries on this front.
thank you very much.
Thank you. Thank you.
Thank you, Manav sir, for such a nice presentation and very well discussion. Next, I would like to invite Dr. Magan Mehrotra to the stage. Dr. Magan Mehrotra is a well-known minimal access bariatric and robotic surgeon. He is the director of Apex Hospital, Moradabad. He has done thousands of the laparoscopic and many complex robotic surgery. Please welcome Dr. Magan.
Thank you, Dr. Ritesh and Dr. Hemant, for giving me the opportunity to be here today for this talk. And I think most of the urologists and gynecologists are here. So this is more like a marketing presentation for me. So you can send all your hernias to me. I will show you why. So I work in Moradabad. I work on the SSI Mantra system. And my love with hernia goes back to 2007 when we published this, when I was training with Dr. Chaube for laparoscopic ventral hernia repair and incisional hernia repair. And now we see why we want to go from laparoscopy to robotics. 3D vision, stable and magnified image, endo-wrist, physiological tremor filtering, and motion scaling. I will not spend much time on this because this is something you must have been hearing since morning. And now we have come to this, a real world performance of SSI Mantra, which we contributed to. And the great thing about this study was 40.6% of the cases were from general surgery. So general surgery is coming up as one of the biggest contributors to the cases done on any robotic system in all hospitals. So robotic hernia, ventral, inguinal, diaphragmatic, all hernias can be tackled. In ventral, we have three different categories, primary midline, then the incisional, and then the borderline hernias. So primary midline ventral hernias are 75% of all ventral hernias that we encounter in our practice. And if they are with divarication or if they are less than 5 centimeter in size, then although we have multiple options, but the best option seems to be transabdominal preperitoneal because it does not involve dividing any muscle fascia or does not involve placing an intraperitoneal prosthesis unlike other repairs. And when we do a transabdominal preperitoneal, the peritoneum is places at a single thin, single cell layer membrane. So it needs a completely tremor-free environment to be dissected. So we published our study on this, comparing an ETAP repair with a TAPP for primary midline ventral hernias, showing that a TAPP repair is definitely better because it gives a consistent peritoneal flap. It can be combined. We can combine an inguinal hernia repair with umbilical hernia. With obesity increasing, these diseases are now commonly seen together. And suture closure of the peritoneal flap is more ergonomically done. And the extraperitoneal mesh with minimal or no fixation gives very less pain as compared to the other techniques. So if you can see here, this is a large epigastric hernia that we dissected, and there is no hole. The sac can still be seen inflated if we give pressure on this. So this is the beauty of the robotic techniques. So now I come to the paper that we published about robotic transabdominal preperitoneal for primary midline hernias, and we showed that the learning curve is about 20 cases, and you have a backup plan. You can convert to TRM and give the same results, and very mild postoperative pain is there. So now we have another repair which is called a P-TAP repair, where we go directly extraperitoneally. Till now I was talking about going transabdominal preperitoneal. Now with the robot we have the convenience of going only extraperitoneally and dissecting in the extraperitoneal plane, which is called the P-TAP plane. This is the fat distribution that was discovered by the Spanish group, which gave us the P-TAP repair. So here the patient in the robotic repair can easily lie supine rather than in an arthroscopy position, as we need to do it when we do laparoscopic P-TAPs. So it is more physiological. We do this at our center with this patient lying flat and with the mainly the pelvic ports in position. So for incisional and recurrent hernias, IPOM plus, ETAP plus minus star, open sublay, onlay, these are the options. And ETAP definitely has an advantage because it gives less pain and a sublay mesh. So when it comes to dissecting in this area, which you see purple in the figure, then it is okay to do a laparoscopic ETAP with these ports. But when we do a crossover, we actually have to dissect in this area or to suture in this area. Laparoscopically, we are not able to do so because we don't have wristed instruments, and our shoulder has a limit to suturing at very odd angle. So here we have to make another 3 ports and change the position of the monitor and everything if we want to do a perfect job. However, when we do laparoscopically, we can put these ports lower down and we can suture with these very well. And also we can give a very perfect repair with less pain. I'll skip the video because of sparsity of time. The advantages of robotic ETAPs are stable vision, aids during navigation in limited spaces. Crossover is facilitated by tremor-free instruments. Reconstruction of the linea alba, and I think this is the most important point, that the complete reconstruction of the linea alba, which is necessary when you divide the posterior elements, is achieved due to endo-wristed instruments. And entering the TAR plane, if it is a big hernia, it is facilitated by the stable vision as well as the stable instruments. So lateral and boundary wall hernias, again we have the problem of the bones coming at the boundaries of the abdomen if there is a subcostal hernia. So here TAPP repair is very well done when we do lateral hernias with robotics. And larger and consistent peritoneal flaps and suturing at odd angles is done seamlessly. And patient positioning is very physiological. We can have the patient lying supine while we do a long surgery. So this is for a subcostal hernia, in fact an M1 hernia, where after a CABG. So simply we have put the ports down there and we have dissected retromuscular, then closed it, and then a mesh can be placed and complete the procedure can be completed with very minimal pain to the patient afterwards. Robotic inguinal hernia repair for large inguinoscrotal defects, we sometimes need to close the defect as well as obliterate the dead space in the sac. For younger patients with bigger indirect hernias, we again need to do all this. Recurrent hernias need better fixation of the mesh. A larger mesh has to be placed, so and they sometimes have more bleeding, so robot is definitely helpful there. And concomitant repair of umbilical and inguinal hernias can be done. And older patients with larger defects need defect closure, because otherwise the whole mesh can go into the defect because they have very less muscle tone. So we published in the hernia journal this routine defect closure and obliteration of dead space in minimal invasive inguinal hernia repairs, and it is a very recent publication. Just to show you a small video on how we do it, I've come directly to the area where we start the suturing. So this is the direct hernia that has been dissected, and we have taken a barbed suture here to close the defect and obliterate the dead space. So two things, our mesh lies perfectly well, and second thing is that the seroma which forms in postoperative period, which definitely is a mental tension for the patient, because most of us have seen that after doing laparoscopic hernia repair, the patient will come and he will ask us that whether this is a recurrence or what has happened to this, that it looks just the same like the hernia. So this seroma can be avoided, and we do collect data for the India Hernia Collaborative, and we have seen that even when people are doing laparoscopic TAPP, they are not closing the defects because it is so cumbersome to do so with the laparoscopic technique. And therefore, the robot scores here again over laparoscopy for doing large direct inguinal hernias. Similarly, we can, this is for the direct hernias. Similarly, we can do for the indirect hernias. The big thing is just to avoid the genital branch of the genitofemoral nerve, and you can get the details of this technique in the paper. And what we saw was that chronic groin pain was not a problem even if we close the defect. So no nerves are getting involved. This is the biggest apprehension when we are suturing in the inguinal region. So a proper technique has to be followed, and you can decrease the risk of seroma formation, and a Chinese study has shown that even the recurrence can be reduced by doing so, but we don't have our long-term data. Robotic inguinal hernia repair is a very good procedure to start your robotic journey for any general surgeon. People think cholecystectomy is the starting case. Robotic inguinal hernia is the best case, TAPP. Ergonomics and port placement is the same as lap, easy to convert to laparoscopy, and the same anatomy as laparoscopy, and so the OT staff also adapts well to this procedure. Advantages I just enumerated, so I will skip this video again. So AI and robotics, just a small slide on this. Tremor filtration we are already experiencing, that is AI and robotics. Data learning and guidance and roadmap for surgery, real-time guidance can be given. We already have telesurgery and telementoring available. We can relieve the cognitive and physical stress on the surgeon, and simulation for neurosurgeons can also be there with AI in robotics. So as of now, we are taking ourselves from laparoscopic to robotic surgery. We are in the hybrid stage. So we all need to go through this so that we can embrace this new technology which can enhance our surgical skills and make us do things that we can't do laparoscopically. So I would say those surgeons who believe that only I can do everything laparoscopically, so I should not be doing a hernia robotically, please keep your ego aside, because if you carry your ego, your back will be burdened. Ride your ego and try to understand that this is just a tool, another tool in your hands. Thank you.
Very nice presentation, Dr. Magan sir, as usual. Sir, which procedure you are preferring, TAPP robotically or TEP?
For the inguinal hernia?
Yes, sir.
TAPP definitely.
TAPP.
Because TAPP is much more versatile. For complicated hernias, you can do TAPP. For larger hernias, where you need to do a defect closure. And in robot, the disadvantage as compared to laparoscopy is that the endorist needs at least 4 centimeters to function inside. So TEP, you are always cramped for space. So there is no point doing a TEP when you can do a TAPP and suture the flap very easily within less than 5 minutes it takes to suture both. So I think that is a better option.
So ETAP RS you prefer for mainly umbilical hernias or incisional hernias?
Only incisional hernias.
Only incisional.
ETAP RS because we are dividing a support of the abdominal wall, a posterior rectus sheath division is required. So for primary hernias it becomes a bit too much. So, and because with the robot we can easily make very good consistent peritoneal flaps, so we tend to go more towards TAPP or PTEPs for patients who don't have a lower abdominal incision already. So PTEP is a very good option there.
And sir, for bilateral inguinal TAPP, so do you prefer separate flap creation or a midline flap?
Separate flap, see midline flap has, I am not against it, but if you make an injury in the linea alba, you will create a hernia. Because you can easily lose your plane in a very thin patient if you go, because the arcuate line is there and the posterior rectus sheath is getting thinned out there. So if you lose your way in a midline flap, in a single flap, then you can land up injuring the linea alba. Okay. Or if this is a patient who has had a previous prostate surgery or any pelvic surgery, you can injure the bladder much easily because you are in the midline. You are approaching it from the place where it is hottest.
Okay.
So it is better to make 2 flaps. And with robot, again, it is the most expensive suturing machine. When you have it, take good advantage of it.
Because somewhere I've seen that some surgeons, they prefer to make a midline flap because the dissection is easy.
Yeah, so I feel with experience, one can do it, but with very little advantage and probably risking these two things that I said, the linea alba injury and the bladder injury.
Okay. Thank you so much, sir, for a nice presentation, and
Great. Thank you so
welcome to
much.
Faridabad.
Thank you so much for your invitation. Thank you.
Thank you, Magan sir, for such a crisp presentation. Now, I request Dr. Manav, Dr. Magan, and chairpersons, please come to the right side of the stage to collect the mementos, please.
Ladies and gentlemen, we now move to the next session focusing on robotics in gynecology. Robotic-assisted surgery has significantly transformed the field of gynecology by enabling greater precision, enhanced visualization, and improved patient outcomes, particularly in the complex procedures. This session will highlight the evolving role of robotic technology in advancing minimally invasive gynecological care. For the same, I would now like to invite Dr. Aparna Agarwal to begin the session.
Good afternoon, everyone. I am Dr. Aparna Agarwal, consultant in Maringo Asia Hospital. I am here as a convener for the gynae session. So I would like to call upon the chairpersons to sit on the stage. Dr. Nisha Kapoor, ma'am, Director Obs Gynae and Minimal Invasive Surgery, Maringo Asia Hospital. Dr. Indu Taneja, Director Obs Gynae, Cloud9 Hospital. Dr. Punita Hasija, past President IMA, Faridabad in Haryana. Dr. Kiran Chandna, President Faridabad Obs Gynae Society. Ma'am, please come on the stage. We will start our first presentation with Dr. Priya Bhave, who will be giving her presentations via the telemedia. Dr. Priya ma'am, can you hear us?
Hi, very good evening, everybody. Am I audible in the hall?
Yes, ma'am.
Oh, thank you so much. Whenever the chairpersons permit, I can start my talk.
Yes, ma'am, you can start, ma'am.
Thank you so much. At the outset, I would like to thank Dr. Ritesh Monga and entire team at Maringo Asia for giving me this opportunity. Today is a special day for us because we are completing our first year of our hospital. But he was really kind enough to allow me to do this on Zoom. And it's a fitting thing because, you know, nowadays we are very comfortable doing tele-robotic surgeries. So why not a tele-lecture? So I bring to you the perspective of a gynecologist. Gynecologists were the one who were at the forefront of innovation when it came to minimal access surgery. The start of minimal access surgery happened with a gynecologist. And so it is really not very paradoxical that, you know, gynecologists should be the one who are adapting to surgery with the robot. Now, the conventional surgery, I think all of us have more or less abandoned, and it is the exception rather than the rule. But as times have gone by, we hardly see any woman with previous normal deliveries, very lean and thin women. More and more patients that we see are previous cesarean. More and more patients have abdominal wall defects, hernias, obesities, adhesions, and so, in the present scenario, gone are the days where you would get very straightforward hysterectomies. We are getting more and more surgeries which are complex, with the increasing prevalence of endometriosis, with the increasing prevalence of infertility and adhesions. Most of the times, we face challenges even in laparoscopic surgery. Now, the big advantage that I have found myself in my short journey of robotic surgery of maybe around 125 cases is the wristed instruments. We all have used, I have used the 3D HD Rubina system, and so the visual part is very well taken care of. All of us have done laparoscopy for a very long time, so we have somehow adapted to the straight stick instruments. But getting the wristed instruments and those degrees of freedom, that has been the game changer for me. And also superior surgeon ergonomics, because as all of us age as surgeons, somewhere the comfort of a surgeon, the ability to take a very short break, the ability to sit and operate, and the best is most of us gynecs have been ipsilateral surgeons. So the the convenience to operate contralaterally, I think that has been the major game changer for me, and surgeon guided magnification. All of us who work in big hospitals, all of us who don't have a permanent camera surgeon will resonate with this feeling. Everybody who has one camera surgeon who has been with them for a long time will never understand how important it is that when your assistant keeps on changing, it's very difficult to make them understand where you want to go, how much you want them to magnify. And so surgeon guided magnification, this also has been a very big advantage for us. Now, I am mostly a fertility specialist. So most of my cases are myomectomies, that is, their fertility preserving surgeries. And because I come from Madhya Pradesh, where we do see prolapse often, and we see prolapse in situations where a patient wants to preserve the uterus. So pectopexy is one surgery where I have found a very big advantage of robotic surgery. So I'll demonstrate this with few of my cases. Now this is a patient in whom you can see a very deep-seated fibroid, very anterior. It's much below the UV fold, and on first glance it's not even visible. This could have been tackled with laparoscopy, but there are two or three things which I would like you to see as in this case. The first is that you can see that if you cut in the right plane with the unipolar scissor, the fibroid kind of pops out on its own. The disadvantage that we had is that the ability of traction was not there, but this is the robotic tenaculum which is developed by SSI, and this gives a very good traction, and even deep-seated fibroids, like in this case impacted in anteriorly in the anterior pouch, can be delivered properly and sutured very nicely. Now here you can see that the capsule is really deep-seated. It's practically in the lower uterine segment. And here a good approximation is very, very important, and that we are able to achieve very nicely with the robotic suturing. There was one more fibroid sitting there, and that also we have removed. So I think whether it is laparoscopy or robotics, your pre-operative mapping and making a mental picture is very, very important. You cannot be a good fertility preserving surgeon if you don't do your scans yourself and you don't make a mental map of which fibroid you are going to encounter, because the tricky fibroids will be the one which will not indent the cavity. Now, the big advantage which I have found has been in robotic tubal recanalization. So in recanalization, the advantage that I get in robotic is contralateral. I can do a very good triangulation. So I'm sitting in the center, and the right tube, which is a little difficult to join in laparoscopy, it becomes beautifully clear. The second is because of surgeon guided magnification, I am able to see, excise the fibrotic tissue with great precision, and the luminal approximation is just next level because the sharpness of this robotic scissor is just amazing. It doesn't compare with the sharpest of laparoscopic scissor that you can get. I always strip out the serosa a little bit so that after I have sewn the mucosa, I take a seromuscular layer to kind of reinforce the suturing. The best results are gotten when you excise the fibrosis completely and you get a good luminal parity in the sense that both the lumina are similar. Here, the anastomosis is a little distal for our liking, but what I will do is fish mouthing, so I'll make the proximal end little bit wider by cutting it, and then I will approximate it. The one difference between robotic and laparoscopy is the instrument changes. You know, the instrument change takes a little bit of time. So here you can see I have prepared the ends on the right side, and then I'm going on to the left side without changing into a needle holder. That's because I want to avoid the time that is spent in instrument changes. That is the one thing that requires a little bit getting used to when you shift from laparoscopy to robotics. Now look at the amount of magnification that I'm getting, and absolutely tremor free. Now in recanalization, in laparoscopy, it is not possible to be so steady because the closer you go, even the finest of the tremor is little bit exaggerated and you will find it. So I will just rush this video a little and I will show you the luminal approximation. So see, there are many people who don't like to go through the lumen, but I'm not one of them. I always like to approximate the lumen. I take proline and I take good bites through the lumen. First is of course outside in and then inside out. I will always reinforce with a seromuscular layer. So this is the right side, and in this video you will show, I'll show you a beautiful, methylene blue coming out after the anastomosis is complete. Now, most of us have, actually, we don't do too many recanalizations. We prefer to push the patient to IVF. But in my experience, this is one of the surgery which gives you a beautiful gratification. Look at this dye coming out after a very nice robotic recanalization. Now, so this is what I mean by the magnification and true 3D vision. Now look at this. Look at the amount of magnification I get. I can really go very, very close and identify the lumen very properly, cut out all the tissue that is fibrotic, and look at this. Outside in and inside out. This kind of precision, I would have been doing laparoscopic recanalization for a very long time, but I have never found this kind of beautiful magnification and approximation in laparoscopy. So can you see, it's a narrow lumen, it's on the isthmus, it's a little isthmoampullary anastomosis, but I'm very satisfied with the outcome. Now, the second thing is planes of dissection. Entire gynec surgery is a story of planes. But when it comes to cavity sparing, being a fertility sparing surgeon or infertility specialist, look at this. Can you make out that this is the endometrial cavity which is bulging below the fibroid? And because of the excellent magnification, there's absolutely no way that I'm entering inside the cavity. I'm cutting the subendometrial myometrial fibers without pulling the uterus too much. The commonest reason that we end up opening the cavity is when we pull the fibroid a lot. Here I don't have to pull, I just peel it off, and this bulge here that you see, that is the endometrial cavity. In all of our series of type 3 fibroids, we have never opened the cavity in a robotic myomectomy. Another very satisfying surgery is that of a dermoid cyst. This is a small cyst, but I would always prefer to remove a dermoid when it is smaller than when it is larger, because these kind of dermoids are very likely to undergo torsion, especially when the patient conceives, because around 12 weeks when the uterus becomes abdominal, this is very likely to get twisted. Dermoid contains a lot of fat, so it is lighter, it floats in the pelvis, and it is a tumor which is the most likely to undergo torsion. Now here again you can see smaller the dermoid, less are the chances that it will rupture during removal, and you can see so beautifully how I am removing it completely intact. Now, dermoid is a tumor which arises from the stroma. So there's absolutely no problem with the ovarian reserve. When you remove a dermoid, the AMH will never fall. So this is the dermoid, it has been removed. Now I'll take a purse string suture and the ovary will look exactly the same. Now, if you ask me the real advantage of robotic surgery, I think in cases of dermoid, it is mainly surgeon comfort, and I think it is the magnification and finding the correct plane. However, we are all very comfortable with removing dermoids by laparoscopy also. So there's not a very great advantage as I see in recanalization. So I think it is complex myomectomy, endometriosis, I think definitely recanalization, pectopexy, yes, there's a very big advantage, and this is a video of pectopexy. Now we would have done good number of pectopexies, and the finding out of the pectineal ligament, which used to take me a little while, especially on the right side, it is as easy as a piece of cake. So very quickly we are able to figure out the pectineal ligament, take sutures there, because we are operating contralaterally. So there's a beautiful triangulation, and the stitch which used to be difficult to take, especially on the left side, is very easy. So I'm cutting the UV fold, and the trick is that between the triangle between the obliterated umbilical artery and the round ligament, that's where you have to dissect and find out the pectineal ligament. Please never go near the external iliac, because that is where your dissection is too lateral. You always have to be very far from the external iliac. So if you are in the plane between the round ligament and the obliterated umbilical, I'll just show you. So this is the plane between the, I'm holding the round ligament and cutting along parallel, and then I will just pull up the obliterated umbilical. So can you see, that is the obliterated umbilical, and that right there is the lighthouse of the pelvis or the pectineal ligament. So to see the pectineal ligament is really easy, not very difficult. There you, that's the pectineal ligament there. And you will always see some anastomosis of over the pectineal ligament. Don't worry about that. It is called the corona mortis, quite a scary name, but all that you need to do is clear at least 4 to 6 centimeters over the pectineal ligament, so you are able to comfortably suture. Here the corona mortis is seen very nicely. And how I do it is I mostly use a Marceline tape. We can use a mesh, but I always prefer a Marceline tape. This is the dissection on the right side. Here also the ligament is beautifully seen. This is best done for patients who have a significant cystocele, and it works really well. And in fact, in menopausal women who have a atrophic uterus, whose endometrium is thin, I actually don't mind doing a hystropexy. I don't think that prolapse patients need removal of the uterus always. If it's a healthy uterus, atrophic uterus, thin endometrium, I think you get better tissue without, creating another cut, and that actually causes mesh erosion. So I prefer a hystropexy in some patients with postmenopausal prolapse. I don't prefer to remove the uterus always. Now this is always a knot which we take with the needle. So you take the needle out through that loop and you tie it, and 2 or 3 such loops are enough. You have to give enough thread to do this. Initially it's a little difficult, but once you get the hang of it, that's it. So this is the first knot that is done. After the first knot is done, we remove the uterine elevator. That is because we need to understand how well we have placed the uterus. There should be no descent, and the uterus should sit comfortably above the ischial spines. So after this suture, we will remove the elevator and then tie a similar suture on the right side. This surgery at any given time, I would prefer to do it robotically rather than laparoscopically, simply because it takes a shorter time. So this has been our journey in benign robotic gynae. We did the first surgery on 18th of July. We have finished around 125 cases and lot of them have been telesurgeries. We have done reciprocal telesurgery with Dr. Amit. Dr. Amit, as I understand, is going to take a lecture after me. We have done telesurgery using the Mantrasan in telethon, and we have also recently done a reciprocal surgery with a bariatric surgeon, Dr. Mohit Bhandari. This is the telethon, which was the brainchild of Sudhir sir, where we did almost 25 cases in the span of one day. So I think there's a big role of robotic surgery in benign gynae, and I think all of us have to work together to understand how we can improve outcomes, how we can balance the costs, and how we are able to give the patients a better outcome with the latest technology. Thank you so much for a patient hearing. I really wanted to be there, but I'm very glad that the organizers allowed me to do this. Thank you so much.
And Dr. Priya Bhave, welcome, to Faridabad, although not physically, but we were looking forward to have you with us. And it's been as clear as a physical talk. I'm sure everybody's quite well versed with the online things nowadays, and we are pretty comfortable with that. So I just wanted to ask one question, like if you have deep and big cavities of myomas, and taking big needles with the robotic needle holders is a challenge, no? So how do you manage that? Because usually we have to have smaller needles and thinner threads.
Right.
And if you have a big myoma bed and a deep myoma bed, how would you manage that?
Ma'am, I had a lot of difficulty initially. So now what I do is three things. I use another needle holder, which is the large needle holder. There's one called super needle holder. I use a large needle holder. And secondly, there's a new suture which has got a square, the needle shape is not round, it's square. So the needle holder holds it really well. The third thing that I have understood is that with the left hand, you can just reflect the tissue a little and sometimes take it in two layers rather than trying to take in one layer. The big advantage in laparoscopy is that we are able to use force drive the needle very well. So it was a challenge for me, but I think eventually we have gotten around it using the new thread which is developed for robotic surgery, the new suture which is developed for robotic surgery, and using the large needle holder.
Okay, I think
What is your trick, Nisha ma'am? I'm really curious to know.
I'm still, the way you told that multi-layering is, of course, that is the simplest answer. That you have to put more layers. If you have a bigger thread and a bigger needle, possibly, you can suture it in less number of layers. But if the needle is smaller and the thread is thinner, you have to work more, do a layered suturing. So, but
It feels like
that's
as if we are
that's a
learning
good
suturing.
solution which has come up. And I'm sure, this is going to work very nicely for bigger myomas. Yeah. And what about bladder dissection? I just wanted to ask you, when you are doing it with previous cesarean sections, TLH, etc., and that tactile feel, do you ever miss that tactile feel which we get in laparoscopy when you're dissecting the bladder?
Ma'am, no, I have actually never missed it because I feel that getting that triangulation and ability to operate contralaterally gives us that big advantage that we are able to deal with the bladder right in the center. So I think most of us are ipsilateral surgeons, so all of us became very comfortable with this lateral window approach and getting that tactile feel. But I think going very close to the bladder and just lifting it up and the scissor is really very good. So I really don't miss the tactile sensation. In fact, all the hysterectomies that we do with previous three, we deal with the bladder with the central approach. We start with the adhesions centrally.
Yeah, I think that is the difference that, in robotic you find the midline approach is slightly more comfortable as compared to the lateral window, which we normally prefer in laparoscopy. Thank you very much. Thank you so much. Any comments from Dr. Indu?
Thank you, Dr. Priya. It was really wonderful and very clear pictures we saw. It was amazing to see the surgeries. Thank you so much.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Priya. As we know, today is International Women's Day. So standing in a room full of such inspiring women is truly inspirational for me as a budding young doctor. And for the same, I would love to invite Dr. Sushma ma'am for felicitating our women's cake cutting ceremony. Please welcome her with a round of applause.
Good evening, everyone. So we are in the middle of a very intense academic conference, but this is the time for a pause and time for a sweet cake to celebrate International Women's Day, which is being celebrated today across the world on 8th March 2026. Can we get the cake on the stage? So while the cake is being brought to the stage and we are planning and we are ready to cut the sweet cake, it's also a time to talk about a not very sweet but a very strong topic of why Women's Day. Why do we need to celebrate Women's Day even today in 2026? So in this hall there are so many accomplished women. There are accomplished women on stage, there are accomplished women sitting here. Most are doctors, some are there in the organizing team. So everyone is independent, accomplished, earning, smart, well-behaved, very eloquent. So why do we still need to celebrate Women's Day? Aren't we already equal and don't we already have access to equal opportunities? So I'd just like to dwell upon why do we still need it, because you see this is, what we are seeing here is not something that was always there. So this women in medicine is a very recent phenomena when we talk about the history of cultural evolution of mankind. So while men have been there in medicine for many, many centuries, women in medicine is only a 2-century-old phenomena. So it was only in the early 19th century that a woman by the name of Margaret Annie, she disguised herself as a male. Dr. James Berry, that was the pseudonym she took. She disguised herself as a male to be able to practice as a surgeon in Ireland. So that was the state of affairs. And she was recognized to be a female only after her death, when they took her for ablutions and all. So look at the sacrifice. The whole life this woman spent disguised as a male just to be able to practice as a doctor, and look where we are today. So from there to here. And then there was Anandibai Joshi around in the late 19th century who started, who was the first woman doctor from India, and against so many odds, she had lost her child. She was 19 years. She was married in childhood. And after losing her child, then she took to medical studies, and then she went abroad and earned her degree and came back. So that was the level of sacrifice, and these are the women on whose shoulders we are standing today. And have we still, completely made it? So ma'am, I'll just, you see, when we start our MBBS, so number of women, number of girls is either equal to or more than the boys who join MBBS. By the time we join our MD or MS, the number of men ratio starts changing. More men are there in MD specialization courses than women. By the time we reach our DM or MCH, even lesser women, even more men. By the time we reach to leadership positions, like directors, the CEOs, the executives, women keep on shrinking and shrinking and shrinking. So even today, the glass ceiling still exists. We might have made it to a great extent, but we have still not everyone is able to smash the glass ceiling, and we still need more voice, more representation, more women there in the leadership positions and reaching to their full potential. And not just about the glass ceiling, in so many parts of the world and in many rural parts of India, even today, women are struggling for the basics. In Afghanistan, a woman cannot go out on her own. She cannot study. She cannot hold to a job. In Iran, women were killed just for coming out on streets demanding very basic kind of rights. And even in so-called developed country, in the United States of America, recently so many young girls being exploited. The cases all over the world. So that is the state of world we are living even today, and that is why this day. So it is still very, very important that we carry the legacy forward. We have come here because women before us have worked hard, have sacrificed, and on their shoulders we stand, and it is our duty that we take this legacy forward and we make it easier for the next generations to come so that they don't face the challenges that many of us still face today. So on that note, I would invite all the women present here to please come on the stage and let's cut this ceremonial cake to celebrate where we have come and to also continue our love affair with success and to continue our love affair with more achievements and to inspire our coming generation of girls and women. So can we have this cake, and please everyone present all the women present in the hall, please come on the stage.
Let's call Dr. Ritesh also. It's his birthday today.
Dr. Ritesh,
Dr.
you can be the
Ritesh,
only man among women.
You can also come because of... Come. It's his birthday today.
Happy birthday to you. Happy birthday to you. Happy birthday, dear Dr. Ritesh. Happy birthday to you. And happy Women's Day to everyone.
Aajo. Come. Yes, you should come. Come.
Happy Women's Day.
Happy Women's Day, everyone.
सबको happy Women's Day. आज बच्चे तुम्हारी आओ.
See, he should cut the cake.
No, ma'am, you should do the honors. Ma'am, लीजिए, सुनीता मैम लीजिए. सब एक दूसरे का हाथ पकड़ लो, जैसे सब ऐसे पकड़ लो. ठीक है, ऐसे पकड़ लो.
Well spoken, ma'am.
Thank you. So happy Women's Day. All the men to keep cheering, please.
अब आ जाओ.
Happy birthday कर.
आ जाओ अब.
Thank you, ma'am. Sunita ma'am.
चलो.
काफी खा लिया बच्चों के खिलाफ. हाँ जी, थैंक यू. चलो आप सब कर रहे हैं. आज सब बच्चे. Happy Women's Day. और बच्चे का एक रोज सबको खाना है.
अब डॉक्टर रितेश की बारी. I think just call him now.
Yeah.
I would like to say one thing which I think Dr. Sushma did not mention. That we have equaled men as far as profession is concerned. But men have not equaled us as far as homemaking is concerned. So that is why, because of the dual role, we have been playing, as professionals and as homemakers. We are always going to have an upper hand over you men. Please I apologize but then this is what it is. So on that occasion, I wish you all a very happy Women's Day. Thank you.
Younger generation, they are becoming equal. The men are also doing household activities nowadays. So we must promote that. Yes, that's what the young girls are doing that. That's what young girls are doing nowadays.
Now resuming with the session, I would like to call Dr. Amit Tandon from Agra. He will give his presentation on the role of robotics in carcinoma endometrium. Sir, please come on stage.
So it's good evening, everyone. So it's being the fag end of the day. So I will just restrict much more of my talks on the video presentation rather than giving speaking more on the slides because most of them have been covered. So we know that there has been a paradigm shift in the management of endometrial cancer from being a evidence-based organ to origin and tumor morphology to a more of a immunohistochemistry-based treatment. Now all tissues are rendered to immunohistochemistry, and then the further chemotherapy or radiation is being given to them. So incidence of uterine cancer has been increasing in the metros throughout these years, and the most common class is the affluent class, which it's increasing, the obese, low parity, postmenopausal, diabetic, hypertension, and most common, it's genital malignancy of the Western country. So when we come to the treatment, we know that surgery is the mainstay of treatment for endometrial cancer. Early stage uterine cancer is surgically managed by conventional, that is laparotomy, minimally access, laparoscopic or robotic assisted approaches. Obesity presents challenges in optimal surgical management. Survival and quality of life are concerned. So the standard surgical management was abdominal hysterectomy followed by bilateral salpingo-oophorectomy and pelvic and para-aortic lymphadenectomy. And now since the advent of sentinel lymph node mapping, the treatment is getting more simplified. So the drawbacks of open surgery were large abdominal incision, though there were good tactile feedbacks, but there were higher blood loss, longer hospital stay and higher wound complications. On the other hand, the laparoscopic surgery had minimally invasive approach, reduced blood loss, shorter hospital stay, and technically demanding in obese and old age patients. So the drawback of the laparoscopic surgery was the fulcrum effect and the straight rigid instruments which we were using. On the other hand, the robotic surgery provides a 3D high definition visualization, wristed instruments with greater dexterity, tremor filtration, improved ergonomics for surgeons, and useful in obese and high-risk patients. So before the use of laparoscopy for oncology was very minimal before the advent of robotic surgery. Less than 25% of surgeons were using minimally invasive for oncosurgery. As compared, we know that blood loss is least in robotics, hospital stay is minimal, operative time initially may be more, but eventually it becomes lesser with experience, and conversion rates are lower in robotics versus laparoscopy. So the goal of LAP2 trial, which was to eliminate laparotomy, showed that minimally invasive surgery had a higher complication rate, minimal antibiotic use, minimal hospital stay, and better quality of life and lesser pain and faster return to activity. So gynae oncologists were very few percentage who were using minimally invasive for oncology purpose. So why robotics is being promoted in oncology is mainly because it improves outcome and cost effectiveness, and it's more benefiting in the elderly and the obese patients. So this is the graph which shows with the event of 2006 and 7 with the robotics, the open surgery went down and the robotic surgery really stood up. This is another similar slide showing since 2006 and 7, the Da Vinci days, the robotic surgery really picked up versus the open surgery, where the laparoscopic surgery remained at the same level. And even the robotics as compared to the laparotomy has shown equally good survival rates. So these were the other comparisons between robotics and versus laparotomy and laparoscopy, which showed that robotics has an edge over laparoscopy as well. So why robotics? Because it's more benefiting in the elderly and the obese patients, and most of these patients are obese. And it has been shown that during surgery, the hemodynamic stability of the patient in a reverse tendon bend position is very good in laparoscopic surgery. So these are similar evaluation slides which shows the benefit of robotic surgery over the laparoscopic surgery, which I am not going to go into detail and make it boring for you. So we know that the first line treatment for endometrial cancer is hysterectomy and adenectomy, and lymphadenectomy followed by lymphadenectomy and chemo and followed by chemosurgery, and if needed brachytherapy or telesurgery. So we know that this is for the obese patients, and we know with the weight, with the BMI, the chances of cancer endometrium increases. So this is a graph depicting that. And sometimes these are the class of patients which come for CA endometrium postmenopausal obese patients, with high risk of diabetes, hypertension, and very high ASA grade 3 and 4 class patients. So when we are doing laparoscopy, there are higher chances of conversion in obese and old age patients versus robotic, where chances of conversion is minimum. So all these slides are, and when we are using a system, which has a console and a good, developed navigation system, which is better than an older version which we use in like laparoscopy. Central lymph nodes has also enhanced prevented the patients from developing complications relating to lymphadenectomy. SSI system has recently introduced the ICG system, so we can take advantage of that also. So initially there was this confusion of, should we do lymphadenectomy or should we not do, has quite been reduced by the sentinel lymph node staging and MRI staging. So I'll just go to the videos so that we save time. So this is one of my first surgery which I was doing for CA endometrium robotically. So first we usually do the colonic mobilization, and followed by we open the space between the round ligament and the infundibulopelvic ligament and carry the incision downwards, and we expose both the ureters and the external iliac vessel and the uterine arteries. So you see the robotics instruments dexterity helps in better dissection of the tissues and delineation of the tissues, and it's been made such to go inside the depth of the pelvis and cover the pelvis. So after doing delineating the uterine and the ureter, we go ahead along the psoas muscle and to the inguinal ligament, dissecting the round ligament as well, and exposing the external iliac vessels, and then the iliopectineal ligament. So these are so you can either start by doing first the lymphadenectomy or the surgery. This is the external iliac vessel which we have exposed, and see, we can go close to the veins and do the dissection. Even if there is a bleeding, we can easily coagulate the bleeders and proceed ahead. And in front of the iliopectineal ligament is the deep circumflex iliac vessel, which needs to be tackled sensitively. And then we can go down behind the external iliac vein with the help of the robotic instruments and shave off the whole of the, end block. You can carry on with your end block dissection, preventing injury to the iliac vessels, and you can proceed downwards and go up to the obturator nerve. So with the help of two instruments, you can complete your dissection very well and completely expose the retroperitoneal space downwards. So here you can see the obturator nerve, shining obturator nerve, and you can clear all the lymph nodes from here, the iliac fossa. So once we are complete with the dissection on this side, then we can proceed on to the dissection on the other side, because this patient was quite obese and she was quite vascular also. So similar dissection is carried on to the opposite side, where we open the space between the round ligament and in the infundibulopelvic ligament and go down and do a dissection on the fat, on the psoas muscle, and expose the genitofemoral nerve and save them. And this is the external iliac vessels, which we can shave off all the fatty tissue. And this is the lymph node, which is at the below the inguinal ligament. So here you can go deep. Also expose the lymph nodes in the bifurcation of the external iliac and the internal iliac. And this is the obturator nerve, which we dissect the lymph nodes above it, and then we go further ahead with the hysterectomy part. So hysterectomy part, I think we open the peritoneum, we open the broad ligaments, we do dissection all around the uterus. So steps of the hysterectomy are same as we do in other surgeries, other hysterectomies. So this is the hysterectomy part which we were doing, and this is the once we are done, we remove the ovaries, and then we close the vault with the help of the vicryl. So so these are the few steps of doing this. So this is another surgery where I will demonstrate to you how do we do port placement in case of robotic surgery, and how are the ports placed. So these are the port placement which we do for benign surgery. But in case of robotic surgery where we need to do para-aortic lymph node dissection, so we take the camera port high above in the transpyloric plane or the Li Huang point, which we normally do. So these are the robotic ports, and this is the port carried by the assistant, and we can put another port up here for the assistant to help during the surgery. So here you can see, so the lower port you can place either on the right side or on the left side, depending upon your choice. So there's one port above for the assistant and one port below. Or you can put another robotic arm on one of the sides to help you. So this is the docking of the instrument. Once we are inside, so we can again steps. You can start on one side of the infundibulopelvic ligament and go on with the dissection on this side, or expose the uterine artery and the other infundibulopelvic ligaments. So, and create a window below the infundibulopelvic ligament. So, and you can even coagulate the infundibulopelvic ligament, but not cut it, so that your twisting of the uterus doesn't occur. So, just a minute, I'll forward it more, just to. इसमें forwarding नहीं हो रही है. Can the computer sorry. Okay. So I'll just fast forward it a little. So once we are complete with the, so this is the lymph node dissection which I showed you previously along the similar steps, and then we can go ahead and complete the hysterectomy in a similar manner. So here you can see that the lymph node dissection is being done up to the common iliac vessels. And you can see this is the dexterity of the robotic instruments. You can do separation of the iliac vessels. You can go below the iliac vessels, behind the, below the veins and the arteries to take out all fat deposition. So this is, which is little difficult with the help of, sometimes with the manual instruments, where the dexterity of the arm is little lesser. So here you can see that you can even go to the depths of the instrument in between the external iliac vessel and do complete removal of the lymph nodes. So here, this is again the lymph nodes on one side is being removed, and similarly on the.
So we are running short of time.
Okay, it's just this is the third presentation which has the, how to do a para-aortic lymph node dissection. So as compared to open surgery where you need to convert yourself on the opposite side, here you can go high up in the epigastrium and do para-aortic lymph node dissection in the similar way as you are doing the pelvic lymph node dissection. And here you can see once you give incision on the peritoneum on the iliac vessel, then the peritoneum opens up and you can carry on the dissection along the external iliac vessel, follow it laterally to the psoas muscle, and then carry it forward up above to the gonadal vessels and up to the renal vessels. So here you can see that you are standing in the, you are sitting on the console, and the arms of the robots are, you don't have to change your camera position. See here, when you see the stability of the robot, there is a lymph node on the inferior vena cava, and how patiently you can dissect that lymph node from above the inferior vena cava. Even the inferior vena, this lymph node seems to be quite adherent to the inferior vena cava, and how gently with the help of dissection you can remove this lymph node. So so in this way, these lymph nodes and other tissues, here you can see that the cystic duct, the chylic duct is being coagulated, and then the lymph node is being cut. So sorry. So I think, robotic has a certain advantage over the laparoscopic surgery in terms of oncology, and further, as we get access to the robotic surgery, more patients will be benefited in terms of lymphadenectomy in oncology cases. So minimally invasive surgery is preferred over open approach. Robotic offers technical advantage over laparoscopy. Oncologically, outcomes are comparable across all methods, and choice depends on expertise, cost, and patient factors. Thank you.
I think for oncology, it is beyond doubt, and it is very non-controversial topic that robotic has definitely got an upper hand over laparoscopy. when it comes to dissection of lymph nodes. So it was a very beautiful presentation of all nice videos also. So thank you so much for your talk. Thank you. And thanks for coming over to Faridabad.
Thank you.
Thank you for the enlightening talk, sir. Now I would like to invite Dr. Leena Mehrotra, ma'am, Director, Apex Hospital, Moradabad, for her presentation on telesurgery with gynae perspective.
Very good evening to all. So it's evening right now. So I bring greetings from Moradabad, and I thank Dr. Ritesh Monga, Dr. Hemant for giving me this opportunity today to present my views on telesurgery. So what do you understand by telesurgery? It allows the surgeons to operate on patients from a distance using robotic systems and high-speed internet connections. That is, robotics along with telecommunications and information management systems. In 1998, first remote telerobotic percutaneous renal access procedure was performed between USA and Italy using plain old telephone system, POTS line. But what was impractical with the telesurgery system? The low data rates, high latency of POTS line, and high costs. So with the availability of high-speed connectivity over long distances now, like fiber optics, 5G, SATCOMs, we all can easily access to this technology of telesurgery. What is the need for telehealthcare? It's because urban-centric healthcare is there. The rural demographics in India is 65% of people residing in rural areas, travel-related stress, consequences of limited access. The patients tend to ignore their symptoms to avoid the long distance travels, and they reach the doctor at an advanced stage. Current telemedicine limitations. So this is a beautiful publication in Journal of Robotic Surgery which evaluates the feasibility, safety and efficacy of remote telesurgery to precisely carry out predetermined surgical procedures using dual console SSI Mantra surgical robotic system. So I would be sharing our experience at Apex Hospital of telerobotic surgery from and to Apex Hospital. The network provided to us was Bharti Airtel Limited, a secure private point-to-point connectivity over fiber between SSI Mantra office and Gurgaon Airtel office, and between Apex Hospital and Moradabad Airtel office. The teleconnectivity between the two Airtel offices was 5G. The mean transmission latency time was between 250 and 260 milliseconds, which was quite safe, and the data packet loss was less than 0.1%. So this is how we proceed with the telesurgery. And this is the system, the Mantra Sync system, which has to be installed at your center, and it is integrated with the robotic system. Till now, we have an experience of 9 telerobotic surgeries, 1 robotic hysterectomy, 7 robotic hernia repairs, and 1 robotic vesico-vaginal fistula repair. So this is a small snapshot of telerobotic hysterectomy. We are privileged to be the first, amongst the first few doctors to have performed telerobotic using Mantra system. Here you can see the patient at the operating theatre in Moradabad and the surgeon operating from the Gurgaon office at a distance of around 200 kilometers. And the surgery went off very well without any latency, and the post-op period was also uneventful. So now if I talk about telerobotic vesico-vaginal fistula repair, this is the true benefit of a telerobotic surgery. I would be happy to share the experience, because this was a patient who had a vesico-vaginal fistula with failed repair. She was the ideal candidate for a surgery to be done by an experienced person who is known for such recurrent vesico-vaginal fistulas. And so the patient consulted us at Moradabad. She was told that we can get her operated by a renowned urologist at Hyderabad, who is known for this vesico-vaginal fistula repairs. Dr. Chandramohan Vaddi, who consented kindly to us to operate on that patient from our center. He was operating from Hyderabad, and the patient was at our center in Moradabad. The surgery was uneventful. The patient did really great in her post-op period because she was troubled with her fistula, with her urinary leakage for such a long period, and she really needed this expert surgery. And this is the true benefit because she didn't have to travel to Hyderabad for such a surgery, and obviously she saved her financial expenses also, and she was relieved of her distress. If we talk of other surgeries, gynec surgeries, which the patients can benefit with telerobotic, that include malignancy surgeries. Somebody who is not doing malignancies, only benign gynec surgery, and the patient is consulting her, like endometrial CA, just Dr. Amit Tandon was sharing his video, we can always admit the patient at one center and get it operated by a gynec oncosurgeon at a different center. So this is the best part of telerobotic surgeries. So if I talk about SWOT analysis of telesurgery, there are certain strengths, but then there are weaknesses also, like high cost, need for trained ground staff, dependency on technology, latency issues, and certain threats like cyber security threats, patient acceptance, and regulatory acceptance. What is the future of telesurgery? In space stations, in fact, NASA was the first to have introduced the idea of telerobotic surgeries. In battlefields, in the remote areas, this is the future, the SSI Mantra M, India's first mobile telerobotic surgery unit, which I could see here outside the venue also, and everybody I'm sure must have experienced this system here in the bus. And this bus is specially made for, with a good battery backup, with a good power backup, high internet speed, and vibration masking is there so that a surgeon can operate sitting inside the bus in remote areas also. And what is the future? We can have a surgeon with a backpack and a headset and operating anywhere outside the operating theaters, sitting on a chair. But this is not the future, this is the present of Mantra, because Mantra has just introduced Mantra Asana, the world's first telesurgeon console, where a surgeon can sit comfortably at any place, maybe at his home, at his or her office, sit on this chair and operate at a distance and give good results to the patient. Thank you so much for the patient hearing.
I just wanted to ask one basic question, that suppose, at any point of time you need to convert because of any technical difficulty to a laparoscopic surgery. So I think one very important prerequisite is that the team sitting at the patient end has to be very competent to take over from you just in case it needs a conversion, or there is any snap in the system, in the communication system, in the net and all the fiber optic, anything can. These are all technical difficulties.
Yeah, because this is the beginning.
Second thing is, I want to ask you, what is the legal aspect of this? Suppose a patient is sitting at a distance, lands into any sort of problems post-operatively. What is the legal status for telesurgery in today's era?
Yeah. Answering the first question, yes, the team at the patient side should be competent enough. But if I was talking about a vesicovaginal fistula, Dr. Vaddi operating from Hyderabad and we sitting at Muradabad, we are competent enough to manage any complication if by any chance anything happens to that procedure, or if there is any problem with the internet connectivity. Definitely one should be trained enough to be at the patient's side. And talking about the legal aspect, this Mantra system is approved with CDSCO, which is Mantra in fact is the first system all over world in fact, which has been approved for telesurgery and teleproctoring. So first thing is the approval of the system. Then talking about the legal aspects, definitely there are things under consideration nowadays, because obviously one has to take off the responsibility of the patient. But what is till now, what it is, that the patient admitted under the doctor, that doctor is the primary doctor who would be responsible for any legal aspects. But there are considerations under things like this, the surgeon who is operating from a distance should be contributing to the legal aspect also. So there are things which are under consideration right now, and the legal aspects are to be finalized right now.
Yeah, it means the counseling part is very, very important.
Very important.
The consent, how the consent has to be taken, who is the first liable person, and who is responsible for any kind of complications.
that is really required. The patient was counseled very properly that she'll be operated by a doctor from Hyderabad, and she'll be benefited with that. She agreed to that. She gave consent for that. She knew about all the aspects. And we had a urologist also at our center who was giving us a backup.
What is the cost like?
Cost of telesurgery? It depends, the surgeon who is agreeing to operate for you, the surgeon will charge the cost and the rest expenses you have to bear.
But really interesting and upcoming
Thank you so much.
aspect of the surgery. Thank you so much.
Thank you so much, ma'am.
Thank you. Thank you for the talk, Leena ma'am. Now I would like to invite the chairpersons and Leena ma'am to please move forward for the felicitation. For the next talk, I would like to invite the chairpersons on stage. Dr. Shivam Vatsal, Dr. Itisha Chaudhary, Dr. Amit Tandon, Dr. Savita Kumari. The talk will be by Dr. Arun Pandey about Faridabad's opinion in role of robotics in gynecological malignancies.
So, good evening everyone. I'm Dr. Arun Pandey, Surgical Oncology at Metro Hospital, Faridabad. So, we'll be talking today about, we have a small panel discussion. We'll be talking about the gynecological oncology and robotic surgery. We'll be speaking about the evidence and what we practice. So, the objectives here will be only two malignancy will be covered, carcinoma cervix and carcinoma endometrium. And we'll look at the evidence, what it says, and then we'll look what we are practicing here again. So the standard treatment, surgical treatment for carcinoma cervix is radical hysterectomy, along with some sort of nodal surgery in the form of either dissection or sentinel lymph node mapping. Now the supposed benefits that should come along with the robotic surgery are better magnification and 3D vision, which should allow more efficient nerve sparing and other tissue structure sparing. in the narrow pelvis. Then again, wristed movement should be beneficial in closed pelvic space. But then in 2018, this trial came out, lag trial. It was basically a minimally invasive versus open radical hysterectomy in CS cervix patients. All these patients with early cervical cancer patients. But in the MIS group, the minimal invasive group, most of the patients with laparoscopic group, the 89% was laparoscopy and 11% was robotic surgery. Now it was surprised to find that overall survival, disease-free survival, both were lower in the minimally invasive group. Open surgery group was better at the survival findings. There was higher risk of death in the MIS group due to cervical cancer. What was interesting happening here in the subgroup analysis and the pattern of recurrence assessment, what they found was majority of the recurrences in this MIS group were in the pelvis. The locoregional recurrence rate was higher. And the peritoneal recurrences, which are actually very uncommon in CS cervix, were observed in the MIS group. Subgroup analysis, what they showed was tumor size of less than 2 centimeter. These patients had less difference in the survival outcomes between MIS and the open group, and there was no difference based on surgeon experience, although the surgeon experience to be included in this trial was a baseline credentialing was done. So the probable culprit, a lot of studies came out, a lot of discussion happened after this trial. A probable culprit was tumor dissemination. So how do we address this problem? A lot of discussion took place. So these techniques then evolved regarding reducing the risk of tumor dissemination while doing minimally invasive radical hysterectomy. For example, vaginal closure before colpotomy, that can be done from the inside parabdominally, or it can be done through the vagina. Staple division of vaginal cuff, it carries the same logic. Cable tie ligation, again the same logic. Another technique that came out of Japan was no look, no touch technique. It was basically a combination of 2 or 3 techniques, including vaginal closure, no uterine manipulators, and retrieval of the specimen in a bag. And some surgeons have also reported use of preoperative conization to remove the tumor before you do a radical hysterectomy, thus removing the risk of tumor dissemination during radical hysterectomy. Now another study from India by Dr. Puntambekar, it's a retrospective study, it is not exactly open versus robotic or laparoscopy versus robotic. But what is interesting here is they used these techniques, the tumor containment strategies were used in this study. They did not use any uterine manipulators and they closed the vagina before colpotomy. What they found was their survival rates were 95 and 94%, which was at par with the lag trial for open group. That means whatever survival rates were there for open group in the lag trial, they had the similar results for the minimally invasive laparoscopy group. So now coming to this, there are these 2 trials, the ROC trial and the RAC trial, that are ongoing now to assess the role of radical hysterectomy done with robotic. Now the essential component of these trials are tumor containment techniques are required, no uterine manipulators allowed. So both these trials, they have now included tumor containment strategies in their strict protocol. Let us see what the results will come out. So now we come to our panelists. So in the today's practice, what are we practicing? Are we doing open or minimally invasive for CS cervix? Particularly after the findings of lag trial have come out. Have you changed it?
The lag trial was the patient selection. They have never told what was the criteria for patient selection. They choose the patient randomly. The patient included was from stage 1A1 to C1. So we just cannot blindly take the statement that the open were better and the laparoscopic arm were very less.
Right.
So the first and foremost what we have to understand is the disease biology. It's CS cervix. By surgeons, we do not mean that we can take out everything and oncologically it is correct. After this study, there was a big whether we do operate or we just straight away go for chemoradiation. The main thing is that we should realize surgical option for CS cervix should be given only and only to early stage. By that I mean only to B1. After that, no surgery. Whatever good surgeon you are, I think that's not the purview that you can do surgery, you take out the
Right.
take out the specimen.
Right. But in practice, like if we are talking about early CS cervix, if it is a case of, for example, 1B1
Minimally
lesion.
invasive,
So
if
we are,
best possible,
Okay.
robotic, else laparoscopic.
okay. So whenever possible, we are doing minimally
Whenever
invasive.
possible, and the criteria to do laparoscopic in these or robotic is, do not use manipulators. What you can do is you take a hook or so that you can put the traction on the uterus, retrieve the organ, the specimen in a bag by through the colpotomy.
Right.
Or if it's not to be cannot be taken down, give a minimal fenestrine incision.
Okay. So, ma'am, Dr. Savita, right?
Dr. Itisha.
Okay, so Dr. Itisha, sorry. So, is there anything you would be looking for in the patients, how to select patients for minimally invasive if you are particularly doing in CS
I think
cervix?
what Dr. Shivam has said is exactly correct, but at the same time, disease which is less than 2 centimeter, depth of stromal invasion which is less than 10 mm. I think this was in most of the trials, patients falling in this category, they had still benefited from the robotic or laparoscopic surgeries. While any tumor which is bulky, in which you feel that the kind of infiltration into the stroma is higher, is more.
Okay.
Tumor more than 4 centimeters. Definitely they are not candidates for robotic surgery, even if the patient is completely fit, or even if the patient has other criteria which, or the patient's willingness to undergo minimal invasive. So, most often you have to see if oncologically you're correct or not, and you don't just go by the whims and fancies of what everyone else is doing. You have to see, you have to oncologically justify. Definitely for nodal dissection, I would say robotic and laparoscopic, definitely, in fact, robotic offers the best kind of vision that you do.
Agreed.
In open, it's difficult to do, you have much more blood loss and other issues, but definitely in obese patients, it's again a problem, but exact patient selection, that you choose the right kind of patients who are very early in their disease, and definitely stromal invasion is one of those factors. Disease size less than 2 centimeter, these criteria, if they are there. In India, I don't think we see those kind of patients, especially in CA cervix. Most of the
Agreed.
patients who land up with us, they are candidates for CTRT. Very occasionally, you find a patient who has been incidentally found to have CA
So,
cervix.
finding
in
an
early
operable
stage.
and a small
Exactly.
tumor with a limited depth
Right.
of invasion, it's
So,
very rare.
Correct, correct.
In our practice. So, Dr. Amit, whenever you are doing CS cervix, minimally invasive, are you following any tumor containment strategies in your personal practice? Any tumor containing, like we spoke about the no uterine manipulators or colpotomy being done after vaginal closure.
So we normally, to prevent manipulation of the uterus, we normally put a stitch to hang the uterus up, which come above from the abdomen.
So
and
no
goes-
uterine manipulators.
No uterine manipulators.
And what about are you doing any vaginal closure before opening
Yeah, so we take a purse string suture before we cut the vagina.
Okay, so you do it like from the inside or from the per vaginally?
From the inside only.
From the inside only we do it.
Yeah.
Right. So these things have shown to reduce the local or loco-regional recurrences. So now that was about the cervical cancer. Now with the endometrial cancer, most of the data that comes is from the systematic reviews and meta-analysis. There is only one RCT. That is also not for long-term data. So this trial that came out, which Dr. Amit also spoke about, this basically was a laparoscopy trial and showed laparoscopy is very good or as equivalent, oncologically equivalent as laparotomy. So this paved the way for robotic surgery adoption in C endometrium. This trial by Mina et al., this came in 2016. It was a prospective randomized trial. It basically looked at short-term outcomes in endometrial cancer with robotic versus conventional laparoscopic surgery. There was lower risk of conversion to laparotomy. Operating room shorter in the robotic surgery group, less blood loss, similar blood loss, and complication rates were comparable. So this was only, this trial only focused on the short-term outcomes of the surgery, not the long-term oncological outcomes. Now this was the meta-analysis. It showed some mid-term oncological outcomes. The lymph node yield was similar and the survival rates were similar. The long-term outcome or the oncological survival rates that came was from the Argenta study. The 5-year DFS and 5-year OS were similar in the robotic as well as laparoscopy group. The recurrence rates were similar in both the techniques. So these studies more or less favor, or they at least state that the laparoscopy and robotic groups are equal, particularly in endometrial cancer. So now I think we have the consensus that robotic and laparoscopy are equal, so no point of discussing that. So how do we choose laparoscopy versus robotic in CA endometrium, Dr. Shivam? How do you choose that in your practice?
Actually, there is nothing much to choose. You can offer both the modalities
Agreed.
for the same patient. It is to which the patient agrees.
Right.
Definitely, if the patient is slightly obese, bulky nodes, then definitely robotic will be the upper hand.
Right. So basically it's patient and doctor choice. Yes. So there are some technical advantages to robotic surgery in these cases. So in CA endometrium patient selection, so Dr. Amit actually already stated that obese patients, there is a lower risk of conversion to open surgery, particularly when you are choosing robotic surgery in CA endometrium. Now for para-aortic dissection, what do you say, robotic versus laparoscopy?
It's a very difficult thing to do laparoscopically, almost impracticable for 90% of the people, and even if they're doing it, I don't think they're doing justice to the patient.
Right.
So either I would go for open if my patient is not agreeing for robotic, or I would choose a robotic surgery, because para-aortic dissection is a part of staging modality.
Right.
You have to stage the disease. And
Right. So when it comes to sentinel node mapping, Dr. Amit, is there any advantage of robotic over laparoscopy for sentinel lymph node mapping?
I don't think so that there's any
Yeah,
advantage.
so fully agreed. So laparoscopy or robotic,
I would want
both
to
are.
add something. In robotic, you have the facility of getting an ICG. So any unidentified node on a PET scan would still might be found on a field which is outside the usual dissection field. And
Okay.
it might be picked up on ICG, while it might not have been picked up if you are going ahead with a direct surgery without a robotic system.
Okay.
That is there.
And about the cost cutting measures now, the robotic.
ICG is also
sorry.
available in laparoscopy.
So Dr. Shivam, about the cost cutting, I mean, endometrium 2-arm versus 3-arm.
See, you need at least 3 arms, one for the
No,
camera.
we are not counting the camera arm now. It's just the operating arm.
2 arms.
So routinely you are doing 2 arms only.
Yes. The third arm, the third port which you need is mainly for the suction or any other which your assistant or any energy source you need. Apart
Right.
from the
So in CA cervix, whenever we are doing, we are not having a manipulator. So probably we can put an extra arm there, but not in endometrium. Agreed. So there are some perioperative benefits, and particularly in CA cervix, maybe some gray areas. And there are higher costs and the learning curves involved with this. Now we can probably make a consensus here, like for example in CA cervix, the data still, yes, it supports open abdominal approach. In selected cases with strict protocols of tumor containment, we can probably go for minimally invasive radical hysterectomy. And in CA endometrium, it's an acceptable modality. Any comments other than this? Okay, thank you.
So for 1B2, you would go for laparotomy or CTRT? CTRT.
Thank you for the insightful discussion. Please move forward for felicitation. I would like to invite our organizing chairperson, Dr. Ritesh Monga, for his vote of thanks.
Thank you very much, Dr. Aparna. Before the vote of thanks, I would request Dr. Amrita. She comes over, like we completed close to 200 robotics. It's all about the team. So I would request Lakshman, Pankaj, Varsha and Shweta. They have their robotic nursing and technician certificates. In a minute, if we can take that and have a photograph for the same. Please come over, because robotics is something which is always a teamwork. I have done my first case with them. I'm still doing with them, though I have changed my hospital. Can you hand over the certificates from there? Paras certificates. Lakshman. Just 1 minute, let the camera be free from there. Then Uh, excuse me, the cameraman. So basically, Lakshman has been very instrumental in our robotic program from starting it. So we are happy that it's his certificate of that he is now a trained technician with the robotic system. Pankaj. No, Shweta. Two young girls, Shweta and Varsha, who come early in the morning and they start the robotic donors and radical prostates. Gopalji, Varsha, the hardworking girl, and our Gopalji, who has been so hardworking with the robotics and the steep head down positions and everything. Thank you so much. At the conclusion of the session, good evening, and as the organizing chairman for Robo Fest 2026, I am filled with immense gratitude towards all who have joined hands together to make it a successful and an inspiring event for me. At the outset, I would give my sincere thanks to Dr. Rajiv Singhal sir, the visionary leader of our hospital, who had wholeheartedly supported the idea once I gave it for the conference. I am also extending my heartfelt thanks to Sudhir Srivastava sir, the CEO of the Mantra Robotics System, who supported the idea, who helped me inviting the best of the faculty from all parts of the country. I will fail if I don't give my heartfelt thanks to Mrs. Dipali Jetli and Colonel Chabda sir for extending their help whenever required. I am so thankful to IMA Faridabad, especially Punita Hasija ma'am, whom I have been troubling time and again for small things, sometimes getting things from Haryana Medical Council, sometimes with the program. So I am very thankful to IMA and Punita ma'am in particular. Also, I have to give my due to Haryana Medical Council for recognizing our efforts and giving 4 credit points to the conference. The heartful thanks, so he is my team member, so he does not deserve the thanks. He is my team member, it belongs to us, to Dr. Lokendra, who is co-chairman of the conference, my younger brother Hemant, and our dashing Deputy MS, Dr. Amrita, who was the co-organizing secretary, for leaving no stone unturned. These are the people who made the conference successful. Then, thank you so much all our faculty and the moderators who have accepted our invitation. They delivered excellent talks, came from various things, and we sometimes always ask them to decrease the time and all this. Thank you all the delegates. No conference is successful without the delegates attending it. Their sustained interest, the questions raised. Many thanks to Mrs. Mamta and her team in the branding department. From the day one of the conference, Mrs. Mamta, she had joined new, and she did all that paperwork and everything, making this conference successful. Special thanks goes to the team marketing. Mr. Yogesh Sharma, Mr. Paras, Sanjay and their team, they deserve a very special thanks for all their help. Day and night, inviting the delegates, inviting the moderators, they have been very helpful. Thanks to our pharma partners, Elchem, Sen, Conquest and the Suction Pharma. Lastly, I thank my better half, Dr. Sushma, who despite her own busy schedule, she was, a day before she was in Allahabad for a presentation, and she has reached yesterday night only, and she has been here. So together as a team, all of us, we take pride in concluding the first successful robotic conference of Faridabad. We hope this is the start for many more better things to come, and Faridabad will remain on the robotic map of India. Thank you very much. I would also take one announcement regarding the PG students, the judges. Like we have 3 students who have made it. The first is Dr. Anaita, Dr. Nidhi, and Dr. Maitri. Their prizes would reach them to their respective colleges. The e-poster judges, what have they decided? So these 3 are the prize winners for the e-posters for PG students. Dr. Anaita, first prize, second Dr. Nidhi, and third is Dr. Maitri. Thank you very much. And I would also take this opportunity to invite all surgeons, gynecologists for the coming SMRSC conference, Robotic Surgery, Global Robotic Surgery Conference, which is on 9th to 11th April at the Bharat Mandapam, Pragati Maidan. Let us all surgeons, gynecologists, oncosurgeons be part of it, because that is going to be the biggest event of robotics in the country. You all would receive the registration messages soon. So you all should register to be part of what all is going on in robotics right now.
सुबह से लगे हुए हैं और कॉन्फ्रेंस समापन की तरफ है। रितेश सर का बर्थडे है, एक बार मैं कहूँगा जोर से रितेश सर के बर्थडे के लिए हैप्पी बर्थडे रितेश सर। एंड जितने भी लोग हॉल के अंदर अभी हैं, सुबह 6-7 बजे से हम लोग आए थे और अभी हॉल में जितने भी लोग हैं, मैं चाहूँगा एक ग्रुप पिक हो जाए और बर्थडे केक यहाँ हम काटेंगे और आप सब लोग आ जाएं। जितने भी टीम मेंबर्स हैं सभी लोग, डॉक्टर्स, टीम मेंबर पीछे बैठे हुए A to Z जो भी आज सुबह से यहाँ बैठे हुए हैं, प्लीज एक बार मंच की तरफ आ जाएं, एक ग्रुप फोटो और सर का बर्थडे सेलिब्रेशन। थैंक यू।